No, but then you want to tell that the 9:15 is the inauguration. You asked me, do you know the time? I was not giving you the inauguration. Yeah. Then I told, yes, I'll be there by 9:40. Be careful, girls, when you're walking around.
It's request to everybody, do not bring water bottle here. Please, it's not allowed here. We have a message. We have a message from our respected director, Dr. Indeep Guleria, AIIMS New Delhi, as he cannot join us on this event physically, but he has joined us virtually. So, please kindly welcome our Honorable Director, Dr. Indeep Guleria, sir.
Good morning. At the onset, let me really congratulate the College of Nursing for holding this very important workshop on the essentials of hospital emergency preparedness. I'm also happy to note that the CNO, Mr. Kamlesh, who is the guest of honor, and she will also be here to help not only encourage the nursing officers to be part of it, but to see how it can be further disseminated so that we are looking at it from not only our own institute point of view, but from the point of view of other institutes also. Now, the COVID pandemic has taught us, I would say, how important it is to be prepared as far as any unexpected event is concerned. And this could be accidents, fires, sabotage, we could have biological terrorism, and it could be some natural disasters that may also need to sort of have ourselves prepared for the surge that may happen in patients requiring special attention in these situations. We've seen that in COVID-19. We've had a surge of patients who required a lot of care, and protection was needed for healthcare workers in the form of PPEs, N95 masks, because it was a airborne infection. I remember way back in 2006, we had an outbreak of dengue. So we had a huge surge of patients who came with fever, and we had to really open up new areas. At that point in time, the new trial ward was the nurses' hostel. It was lying vacant, and overnight we converted the nurses' hostel into a surge capacity area by putting beds, trolleys, and posting doctors there, because we had a huge outbreak of dengue in Delhi. Luckily, that was not a respiratory infection, and we didn't have to have all the PPEs and things like that. But it was still a vector-borne infection with huge outbreak. Similarly, there is always this issue of accidents which happen, and when it's a mass casualty, we have a huge number of individuals with trauma coming in for care. So I think it's important that hospitals plan for this, because planning is very, very important. And that is why this workshop becomes essential for us to be able to understand. How will we be able to meet the needs from various sectors as far as an emergency is concerned. And these are not only from human resources point of view, but from the point of view of equipment, from the point of view of drugs, and for other essential items which could be required. It could be IV fluid, it could be syringes and needles, it could be extra beds, and it could be also how we can reappropriate our resources and manpower to manage any surge that happens. Therefore, it is important for us to plan. And planning means that we need to look at it in a holistic manner from various angles. And that is why I'm very happy that this workshop has actually 10 segments, and they will discuss all areas as far as emergency preparedness is concerned and look at all types of emergencies that we can have. It's important that we have a plan in place which is there, and an SOP is created so that whenever there is an outbreak or a disaster, that SOP becomes active. How do we create a special area for managing the increasing number of patients? How do we create our increasing beds or the equipment or the drugs or chemicals which are, or the medicines which are required? We had this challenge during Delhi, and we've seen that during COVID, that we had to suddenly convert the trauma center and MCI into a COVID area. At the time of dengue, I've already told you that we had to convert the nurses' hostel into a dengue block, as a matter of fact. And we even had to convert the waiting area outside the emergency into a fever OPD, because many patients with fever thought they had dengue and were coming there. We had to do strategies of how do we decrease the turnaround time of platelet count, and the sample would go to the lab and then come back. The strategy was then we shifted the machine to the emergency so that the sample was, the time that was taken to send the sample to the lab and then come back was condensed, and we could have the sample being done at that point where the patient was coming, and that saved us a lot of time. Also, an SOP as to what should be the treatment strategy, so that anyone who is also not an expert in that area can manage patients when they have a surge as far as that outbreak is concerned. So these SOPs have to be developed. I had also been involved in developing an SOP during the time when there was a fear that we may have an outbreak of what was known as H5N1 or bird flu, and we felt we may have a huge number of cases of H5N1 infection. And again, a booklet was made by collaboration with the Department of Emergency Medicine. How will we get our resources together? What should be there in stock? All of that is important, and I'm very happy that this workshop is being conducted. We have to see how we can use our limited resources in the best manner, and how we can reappropriate things in the hospital so that it provides care that is required, but also is able to manage the surge that happens. I'd like to take this opportunity to wish the entire team, led by Dr. Tata Venkateshan, the principal of the College of Nursing, and Dr. Deepika Thata, who is also involved in this. I'd like to congratulate both of them for this effort, and I'm sure this will be a great learning experience for all the nurses who are going to become a part of this activity. So I wish you all the best. Thank you.
Thank you so much, sir, for your valuable work. Next, moving forward, the first session of our workshop, that is on pre-hospital care. The first session on pre-hospital emergency services, an overview by Dr. Sanjay Kaushal, MBBS, MBA in Hospital Management, Consultant, Medical Preparedness and Biological Disaster, National Disaster Management Authority. Sir worked as an instructor for training, nursing assistant at Army Medical Corps Center and College also. As Director, CBRN, Headquarters IDS, coordinated medical relief measures, ex-Ministry of Defense during disaster in several countries and states. Over to you, sir.
Check. फिर इसको full screen कर दो. Full screen कर दो. इस पे कर दूँ? इसमें full screen कर दो. ये कर दो. Check है ना problem. Good morning, ladies and gentlemen. I am audible? Yes. Audible? Can you switch it off? Then I'll see, am I audible?
Yes, sir.
Okay. At the outset, I will like to thank the organizers, College of Nursing, All India Institute of Medical Sciences, New Delhi, for giving me the opportunity to speak from this podium in your this workshop. I bring to you compliments of National Disaster Management Authority. I am grateful to Dr. Lata having tracked us and give us an opportunity to interact with you. I have a personal interest in coming here. I have worked for almost 40 years, in which almost 15 years training nursing assistant. You see, the army has got a set of people. One is the nursing officers who take care of most of our hospitals, but normally they do not go to the field. But we have operation theatres functional in the field, much advanced, like Kargil, Uri, advanced places where our nursing technicians hold the fort. Everything which a nursing officer does, he does the same thing. So army is very much dependent upon male nurses because of the nature of our job, because we go into the enemy area under the firing and shelling. And we do not have the comfort which you have, because sometimes they operate and move things under actual enemy fire, where your own life at risk. So that is it. So moving on to the topic today. The topic which is given to me is basically pre-hospital emergency medical services, an overview. Now the topic means that I will be technically covering little of everything which you are going to study today. And in case you want to know something more or anything, you can stop me anytime. I will be more than happy. Thank you very much. Next, please. So from my side also, Dr. Sanjeev took the lead on the occasion of International Women's Day, where the theme is gender equality today for a sustainable tomorrow. I congratulate you and my wishes to you. Thank you. Next, please. Now the thing is, let us do it in a narrative way. Okay. Because see, if there is a lecture and an audience, there is no communication. But if you look into my eyes, you will be able to communicate better. So it will more of a, will paint a sort of a picture, and then we will go forward how the things moving in the emergency medical services in India. Now, why this topic has been selected by ma'am, emergency medical services? Two parts, pre-hospital and intra-hospital. You all are working in intra-hospital. So if somebody says whether you know CPR, whether you know how to give an intracare, whether you know how to intubate, you are a master at it. Correct? But in ideal situation, where you have a bed, where you have a light coming onto you, where somebody is also assisting you. What if the same thing happens on the slope of a mountain, somebody falls, where you can hardly stand up yourself? There is mud, you are slipping down, and you were asked to go there. Then I once had to put 92 sutures on a scalp in a motor traffic accident in a torchlight, because there was no electricity there, no generators there. I was in a field where a vehicle has gone down the slope. We brought the chap up, his whole scalp had falling in front of his face. You know, it has got a loose tissues below, and if you just pull it, the whole skull comes out literally. And 92 sutures. So these are very, and there is no bed, there is no hospital bed. So if there is no hospital bed, what you are literally on a normal camp bed, sitting and suturing, and ultimately 3 days I had back. You can realize how much time it will take 90 sutures to be put. So the conditions are different. So why the need for emergency medical care? Statistics have shown that 23% of all trauma cases are transportation related, mainly road traffic accidents. And about 77.2% are other cases. They can be drowning, agriculture related, poisoning, suicide, and many other things. In India, 1374 accidents happen every day, leading to almost 400 deaths. So if this is per day, if you multiply it with 365, and these are the ones which are reported, what about those which are not reported? So you can think that the figure may be very high. Out of every 1 million or 10 lakh people, 42,800 people die every year from sudden cardiac arrest. Why did they die? He has cardiac arrest. I know there is a cardiac arrest, but is it irreversible? Can somebody make a difference? Yes. If there was a person there who was trained to make the difference, it is not that a novice sitting there who in the case of a fits will say, pick up your shoe and put it in front of the nose. I have actually not planned this thing, but I want to share with you gravity, real-time incidences which happened with me. I had a Dr. Bapchi who was with me. His younger brother, 18-year-old boy, in 1982, had an attack of epilepsy or fits in a DTC bus in Delhi near AIIMS. The bus was crowded. The boy was frothing from the mouth. He became unconscious. You know, after the fits, there is a period of aura where you do not come to know what is happening. There were 35 people in that bus. Everybody said, make some space, Juta Sungo. He died. Son of a brigadier. Why did he die? He suffocated in his own vomit. Nobody turned him. The only thing required was to make him semi-prone, right?
Yes.
Any unconscious patient, if you had made semi-prone, that is the level of competency in our community. Who is to be blamed? You can say system, this, that, but yes, awareness. That is why this small thing is so very, very important. Pre-emergency medical services, where on the spot there is a person who can make all the difference between the life and death. Next please. Now how do you define emergency medical services? It is a branch of emergency services dedicated to providing out of hospital acute medical care or transport to a definitive care to patients with illness and injuries which the patient or the medical practitioner believes constitutes a medical emergency. To emphasize, a 22-year-old young graduate from National Defence Academy, a smart 6-foot handsome boy, he was taking a presentation in Srinagar. He was bitten by a bee. He had severe anaphylactic shock. Died. And he was very close to the hospital because the BD body camp in Srinagar, hospital and everything is inside only. Somebody had to put steroids in him. You needed to put hydrocortisone, correct? At that time there used to be only Avil. If his collapse, you put some adrenaline. Let his heart move, but he died. So these are things. So on the spot treatment is very important, and that is the genesis of emergency medical services. We are losing too many valuable lives because of too much of ignorance and the system not in place. That's right. Agreed, everybody? Yes, am I audible? Comfortable? That's great. Now, initially the emergency medical services before 1985 and all was basically what I will say patient transportation services. If there is a patient, put him in a vehicle, you may call it a car, a bus, motorcycle or an ambulance, and send him to a nearest medical care facility. But that golden hour is lost because there was no medical attendant to do anything worthwhile on this patient. So the concept came later that what is actually an ambulance? So now the new nomenclature is all the vehicles which you see which do not have a medical equipment and attendant, they are to be designated as patient carrying vehicles. They cannot be called ambulances. Ambulance is a vehicle which is fitted with essential equipment to give basic life support and has got an attendant. So patient needs to go attended, and that is what we call a ambulance services. Am I very clear? So the difference between a patient carrying vehicle and ambulance, it does not matter it is 15 crore vehicle with a plus sign with sirens hooting, it doesn't make any sense if you cannot give basic life support to a patient while traveling. So, and that forms a part of emergency medical service. Sending an ambulance and bringing without attendant will just be considered as transportation service for the patient. That's right. Next please. Now, in India, everything is right. India is a very friendly constitution. In our constitution itself, the right to live is a part of your right, which is Article 25, which has been used too much during the COVID. When a person goes to the hospital, they say no bed, he says it is my right to live. Article 21, I must be given a hospital bed. Insignificant whether it is a private hospital or this thing. So our government has taken at the highest level the right to live. But if there is a right to live, we should have means to make the person live. That is also important. Otherwise it doesn't make any sense. Correct? So that is there. However, till a few years back also the basic concept of emergency medical services was scoop and run. Go there, pick up the patient, move to the hospital as fast as possible. Why? Why? Anybody? The reason was this, that we did not have enough emergency medical technicians. If you do not have the technician, the person there is not confident to deal with that patient, and he thinks that if I do something, he dies then. So our government, our orders are evolving, which I will tell you during this overview, that where we are actually going to the right direction, but with such a huge population, things are moving fast. Next please. So prior to 1985, it was just patient carrying vehicle. We had ambulances which was not run by the government, some charity no, but in 1985 things started changing, and the first such change was establishment of emergency medical services in the Mumbai with 15 ambulances which were connected with a wireless dispatch center. Can anybody tell me why wireless dispatch centers in 1985? Simple algebra. Anybody? You must participate. None of you were born in 85, that's right, students? Because there were no cell phones that time. There were no mobiles. There were only wireless. Police used to use that, army used to that, so it was known as wireless services. Since there were no mobiles, so there was no other way of communication. That is basically elementary. So then the thing started moving in mid 1980s, when I just told you. Next please. But in 1991, the experiment was over, and now the government started thinking that we have to now fund this emergency medical services, mainly the pre-hospital part, because the private companies are not coming that much. So in the national capital area of Delhi and around, almost 13 ambulances were procured, and the CAT service, Centralized Accident Trauma Services, was started. This is the origin of a systemic organized ambulance services as a part of emergency medical services. Next please. Now we all are based in a urban setting where we have all the resources here. You can call a cab, you can call an ambulance and all. But what happens in the villages? The National Rural Health Mission, which provides pre-hospital medical services, mainly the ambulances, and these ambulances transfer the patient to nearby hospital. And you see the amount, now type of patients which are transferred, it is on the view file. It covers almost every case, from pregnancy to neonate emergency, poisoning, snake bite, suicide, drowning, collapse of a house, child falling in a well, everything these ambulances are taking care of. Burns, very common in villages. Next please. Now the concept of golden hour. All of you are very much aware what is golden hour. If anybody has any doubt, you ask me, because it is a part of your nursing training. But my question is, what do you mean by platinum 10 minutes? Anybody? Ma'am, I'll request if there is some interaction.
Yes.
I'm sure you are the finest of the country.
They all
Why should you be assistant?
So take a chance. Yeah.
Don't worry, I'm not going to say you are wrong. Nobody is ever wrong. But that will help me also to know whether you are with me or not. Anybody who knows what is the platinum 10 minutes, which is on the top, from 12 o'clock to 2 o'clock? No, not an issue. Pardon? Yes,
No, the position is 2. Yeah.
12 to 10 minutes. If you move the needle to 1, 2,
So that is a platinum.
yes.
And rest 1 hour is a golden hour.
But why we call it platinum 10 minutes? What is the significance of this
Because
platinum?
there is a chance of brain death. If you will not resuscitate and the blood supply will not go into the brain, then the person will have brain death and the person will become in a vegetative state. Rest, if you will do anything, that is, it's just like you are giving something to a vegetative state.
Yes, you're absolutely right. You see, whenever there is a trauma, or even I say, even a myocardial infarction is a trauma, the most important thing is, if I am not trained, I should not waste my time there. I should move the patient as fast as possible after doing whatever possible I can do to the definitive care place. The rule says there should not be more than 10 minutes time to be wasted on resuscitating a patient. 10 minutes should be good enough. That is what the book says. But what she says is actually practical. Absolutely. Why do you see we say A, B, C, D, E? What is the first A? Why not C? If there is a heart attack, why not C? Second question. Interesting. We'll come to that. Why next, please? We will come to that when I come to that slide. Now you can think by that time. Why not C? हार्ट अटैक हुआ है ना, तो ए के पीछे क्यों पड़े हो?
Because blood side by side blood supply, airway means oxygen is also very much needed.
उसको तो
And
हार्ट अटैक हुआ है.
airway pathway should be clear for the oxygen supply there to the brain.
Okay, welcome. Now, what are the various levels of pre-hospital care? They are basically basic life support. You are aware of it. Advanced life support, different type of classification, different type of students, and different type of competency. It's an overview. You can read it later. And there is something known as intermediate life support. Somebody does a basic life support and he does a little more, but doesn't do the complete more. So it becomes an intermediate life support person. Next, please. Now, what is the aim of the acute trauma life support? You are again aware of it. But the important thing is this person who is trained in ATLS, he must do at least these 5 things confidently. Rapid and accurate assessment of patient condition, resuscitation and stabilization, determination of the patient's needs, arrangement for the patient's transfer, and assure that optimum care is provided to the best of his capability. A layman cannot do it. This only can a person do if he is trained person, the people like you. Next please. The philosophy is treat the greatest threat to the life first. Lack of definitive diagnosis should never impede the application of indicated treatment, and a detailed history is not the essential prerequisite to begin the evaluation of acute intervention. Now this is a very important thing. This gives you a lot of freedom. When you are doing an emergency medical care at a site, you do not go as per academics, because the situation is not always as painted in the thing. I say treat the greatest threat to life first. There is a fire. What is the commonest cause of death in case a person is trapped in a room which is on fire? Fast, 15 seconds. Anybody? If there is a fire, what is the best way to save yourself from that suffocation? That is the second part.
You should lie down on the floor.
Third thing, why should I lie down on the floor?
Because the gas is, it goes up. It is very lighter.
Perfect.
Than the oxygen.
Very happy. The hot air goes up, along with the charcoal and all everything, smoke. Lie on the bottom of the thing, close to the door. You will survive a little longer. You will always die of suffocation. Nobody dies of fire initially. So that is a very excellent. So treat the greatest threat to life. Don't start doing CPR there when there is fire in the room. Take the patient out. That's one thing. Lack of definitive diagnosis should never impede the application of indicated treatment. Patient is unconscious. Now you start Googling whether it's a brain stroke, whether it's a MI, whether this thing. So you don't have a definitive this thing. Or patient may have just fainted. It could be a syncopal attack. It could be a vagal attack. Patient was so nervous. Don't start thinking that what should be the diagnosis. You know if a patient is lying unconscious, do the care of the unconscious, which has been taught to you by your tutors. This is what I have to do. Put him in semi-prone position. Neck should be this thing, this way, that way. That is all. Check whether he is breathing. Check whether the airway is clear. It is more important. Next, please. Detailed history is not required, because most of the time nobody will be there to give the history. Most of the passerbys have come without knowing anything. They are just putting their ideas because they were actually not there when the accident happened. So don't rely on what people are saying. Use your own training. Next, please. Normally, who summons a pre-hospital response? Where is the pre-hospital response? Pre-hospital response is normally in the hospitals or in the clinics. Somebody calls you. Anybody can call up. It could be a passerby. But in India, what happens is that it is the passerby rings up 100. 100 is the police control room. Police control room tracks you where you are, and it passes the thing and tells the control room that this is the place where there is some accident has happened. Please go there. Unfortunately, nobody does anything there. That is the bad thing in India. Next, please. Now, role plays of emergency medical responders. Now, an emergency medical responder has got various roles to play. I will one by one. How much time I have on? How much time I am left with?
20 minutes.
Excellent. I'll be able to finish it. So next, please. It is the police control room, or basically emergency response center. In Maharashtra, they call it emergency response centers. In your hospital, probably will be called as the emergency response center. There is a person sitting there who has got a role to play. This person should be knowledgeable, because it's a this person, when he gets a report, he should accurately log it. As we say, sir, there is an accident on the Agra highway. And he puts the phone down, the Agra highway is 400 kilometers long. So that person should be trained to extract the exact information. Okay, it is near metro pillar number 44 on so and so road. It is near so and so cinema hall. It is from milestone 24 highway. So that gives a general idea, so that that person can actually send the right person, because whether the person has to come from Ghaziabad or a person has to come from Delhi, patient may be in Ghaziabad, but it is again Agra highway. So that thing is very important, and it should be trained to tell exactly where it is and what is required, and able to assess what is required. Next, this is one role a first responder plays. This is the flow chart which I have just read. Alarm calls from emergency exit site. Nowadays the number is 108. Information to ambulance via mobile phone these days. You stabilize with the ALS protocol, that is the first responder who reaches there, transport the patient to the hospital, informs the hospital, I am coming. There may be 20 hospitals. Somebody has to inform the right hospital where you are coming. I had a boy who, in January, who fell down from a bus, whom I knew. His father rang me from village that my child has fallen from the bus, has gone to the hospital. Where he has gone? He has gone to the hospital near Janakpuri. Which was no, government hospital. DDU. He went to DDU. It was a case of head injury, so the DDU transferred that case to Safdarjung. The moment I came to know, I came to Safdarjung. I spent 3 hours in Safdarjung hospital. I went up, down every ward. I could not find this boy. I went to the police checkpost there. His photo was there on their mobile. Then where is this boy? 5 hours at my position, I could not track that boy because he was unconscious. And then I found him in the Rajkumari Amrit Kaur Trauma Center in AIIMS. Why he came from here? So you say this is the communication gap. The Safdarjung hospital people could not tell me, and everybody helped. They went out of the way to help me. They walked with me. Sisters walked with me. Doctors walked with me. Couldn't help. So the correct flow of information should be there. Just an example, personal experience. Next, please. Now, initially, there was no term as emergency medical responder. It was always called as a first responder. Any person who goes there is called a first responder. Emergency medical responder, we use the term a person who has been trained as a medical in some sort of a basic life support training. He should be able to recognize serious of the condition, provide basic care, and relay information. Next, please. Now we have just said it. Next, please. Now, nowadays, I think you people are also using the word emergency medical technicians here in it. No? These are not full-fledged nurses. These are technician courses.
And these are the courses which are newly coming up now.
So these are
I
things.
think over the past 10
But
years.
abroad there is something known as the emergency medical technician courses, and these are the people who actually go in the ambulances to pick up the patient. They are trained in basic life support. This is just the initial course. It's not a very long course, about 6 months to 1 year, and that's good enough. Next, please. Now this is where it is a slightly detailed thing. Emergency medical responder roles and responsibilities. Can you see it? Okay. Now you see, the first one you see is preparation. Now you see, this is preparation for emergency responder. Now preparation actually means that you were educating that particular person. He is preparing himself to perform that task which is expected of him. So he should be physically and mentally, emotionally strong, knowledge and skillful, and he should be able to utilize the equipment which is available in the ambulance. Then he goes to response site. He should be quick to respond. If he is on duty, it should not be that he should be away from the site of duty. If you are there, musibat bata ke nahi aati, and it always comes when you are not prepared, unfortunately. Correct? So he should be always ready to move. When he goes to the scene, he has to do the scene management. The first thing is basically, which you will learn in detail when triage and all. I will not go into it. But first thing is secure the patient, take him from a place away from the harm. Secure yourself. You do not get harmed, like slope. You go down in the river, there is no point. Then you do his ABCDE. Make sure that his airway is open, breathing is on, CPR is done, position is correct, mouth and nose are clear of anything in case of trauma cases. Then inform patient assessment and care. You have done some management. Inform the person to get an ambulance or the police and remove him. And once you have come back, do not stop. All the equipment which you have used, put it back in place. Whatever consumables have gone in, what happens that somebody has used up everything, and when actually required, the next person goes in the ambulance, it is not there. Next please. So this is the complete role of an emergency medical responder in a non-hospital setting. Next please. Now these slides are particularly selected for all of you because I personally feel that everybody, whatever job he or she does, he or she should be good at it. When I go, somebody should not question that I am not good. I am a graduate from AIIMS College of Nursing. Nobody in the country should be at par with me in my knowledge. There is no shortcut, and especially in a medical profession. I must be thorough with the procedures which are taught to me. And a person should have a personality. Each person who is performing as an emergency medical responder in a pre-hospital setup, or even as a nursing technician, or in army we call nursing officers or nurses, you should be good. Now you can read it yourself. You should be you are a highly visible role in the community. You won't believe when you go there and you say, sir, I am a nurse, I will do it. Even an IAS officer will stand on side. They will just leave that place for you. And that moment is your moment of glory. Because that is the time you are going to make a difference between life and death, and there is nobody who will come in your way, I can assure you. And you will be the role model. They will be looking at you, what he or she is doing. And to do a particular job, you must have confidence. And confidence comes from knowledge. Knowledge comes from training. Training comes from practice. Practice comes from, and everything comes from a good teacher and a good student who wants to learn. I have been a teacher, so I am using this word, please don't mind. Okay? You should establish and maintain credibility, show concern for your patients. No shouting at your patients. It doesn't serve a medical profession. You should be very much compassionate and lot of empathy with you. Your appearance should be slick. People should look at you, how you are dressing, how clean your dress is, whether your dress is ironed or not, whether your hairs are done or not. Because if I have a choice, picking up this medical attendant and this medical attendant, I will prefer an attendant who is well groomed. That's the right word. This is a part very important. Present a professional image and treat colleagues with respect. She may be wrong, but she has got 5 years of experience. What she is saying, she has said and learned, she has said the right thing. You have not been wrong, you have been right, don't worry. But ma'am has got 40 years of experience. But the person can be, if you are senior, guide your subordinates. Do not look down upon them. Okay, next please. These are the characteristics you should imbibe in your character. Communication skills, this is very important in our profession. Patient may be panicking, and it is not the patient, his relatives are panicking more. You are not only to deal with the patient, you also deal with his relatives. In India, politicians panic more. I have seen a case where the politician comes and says, this is my constituency, you put 2 bottles of IV fluids. I said, why? He said, my reputation stake पे कि नेता सब आया है यूपी में this संजय गांधी पोस्ट ग्रेजुएट इंस्टीट्यूट नेता साहब ने आके बोला, आई एम नॉट स्केयर्ड ऑफ टेलिंग कि 2 बोतल मेरे नाम से लगाओ, वरना लोग कहेंगे साहब क्या आने का फायदा क्या होगा. It's a fact, it happens in our country. It happens. So, but you should be able to communicate. कि सर ये जो पहला है वो भी आप ही के नाम से लगा रहा है. Something like that. You should be have a skillful in your communication because especially handling the patients as well as the relatives. Next please. Documentation is very important for emergency medical responder at the site. Why? Anybody? Why?
So the repetition is not
Yes,
there.
I gave injection morphine there for a crush injury, and again here it was again injury morphine. No, repetition should not be there. Very, very nicely done. That a person knows what you have done there, and it has got lot of legal implications. Legal patient was dead there, but being a good faith, I sent him to the hospital. That probably may be revived, and the relative says he was dead, he was alive. That's why he was sent there. So write clearly, patient is not breathing. Patient has got nothing. Documentation should be correct. Then you can prove that. See, I tried my best. He could have been revived, but he was dead already. Okay, next. Is it possible for a dead man to move his arms? Just to break the monotonicity.
No.
I have not said yes or no. I am just checking your response. It could be anywhere. Or should I leave it?
Yes, it can be happen if your documentation is not
No.
right.
My question is very clear. A man is dead.
No, sir, it's not possible.
Anybody?
Sir, there is a condition known as Lazarus something. Lazarus
Lazarus effect.
condition.
I have seen a patient who was dead for 8 hours and he moved his hands. And the relative says, see, he is alive. Dead man can move. Food for thought, read it, come back to me. Okay, this is for you. It's very simple logic, but not at your level. But I am sure Dr. Sanjeev would have known the answer. He is a forensic man. He would have given you the anyway. Food for thought. Okay. Now the rules and responsibility. Your responsibility doesn't end with the evacuating the patient, giving the first aid treatment. You have also to train the community. To that way, NDMA has done its part. NDMA has developed first aid training manuals for students of class 8 to 12 and also for teachers. And they have also developed an app. And also NDMA has approached the government Ministry of Education to implement this in all the schools and put it as the school's curriculum. I will be grateful if somebody can check from the children that whether it is part of this thing, can let us know. So that thing, but from our side we have delivered a thing. To use it, not to use it, we cannot actually enforce. But these are fantastic modules which tells you the basic first aid if something happens in the school or in the community. Next please. Now this part you will be covering, I have just put as an overview. That triage, the speaker next to me is going to speak about it. The legal issue, somebody else is going to speak upon it. When they will be doing a triage and roll, probably he will be telling you exact way of doing first aid, CPR and all. So we are not covering that. Next please. The rural emergency medical services has its own challenges. You all know, although it is said that, but still the connectivity is a problem, electricity is still a problem. The healthcare centers are there, but they are not equipped. If they are equipped, they are not manned. These are things. If they are manned, the person doesn't go there. So all those things are there. So these are things, but things are improving and improving at a very high rate. And I expect you people to contribute to it. Next please. If at all you go there, there is no cell phone, no connectivity. In NDMA Bhavan, we don't have an Airtel connectivity. So how can I expect something happens in the real village in Arunachal Pradesh or in Uttarakhand? So we must think of these possibilities which will happen. So why I am using this word again and again, you must understand that our children are not too used for Googling. Papa ye kaise? Papa मैं भी बताती हूँ. But the day my internet is not working, the whole world collapses. Doctors also doing that. Doctors also doing that. It doesn't work. You must understand that in our profession we are not like lawyers, where you may take 8 years to take a decision and reverse your decision. Our decision has to be split second. I don't have time to refer. I have to use every movement which I have learned in the hospital every patient we have seen. We were so proud of a graduate of Safdarjung Hospital because at that time in 81, 82, when I was in Safdarjung Hospital, you can find any case in any book in some floor or some staircase of Safdarjung Hospital. It was a poor man's hospital. We used to have 2 to 3 patients per bed. AIIMS was still a VIP hospital at that time also. They used to have a stamp. Patient comes here, stamp, no bed available, Safdarjung. We used to take. But we learned a lot. Next, please. Now, NDMA, just one slide on it. NDMA is a very powerful autonomous body. We have developed guidelines on medical preparedness and mass casualty management in 2007. It is a fantastic book. You just check it on the website NDMA. It is available free to download. Every part of hospital preparedness, every part of pre-hospital preparedness, CBRN preparedness, disaster, the book covers almost everything. Please, if possible, go through 2 pages per day. You will finish in 150 days, but it will be worth it. We have also brought out books, manuals on hospital safety. Very exhaustive, almost everything is covered regarding different parts of the hospital. Fire safety, oxygen safety, and all those things. Please go through it, if possible. Next, please. Now, these are various laws. You can just, next, please. It will be covered, I am sure, in the subsequent. Next. Yes, this is important. It's a little bit. High-low trauma care. Now, initially we never had roads in which the vehicles could travel at 100 kilometers an hour. The day this Delhi-Agra, the most disastrous was the Pune-Bombay highway. Number of people who have died on this road because we started zooming at 100, 120, 140 kilometers an hour. So this code has come in 2007, where the government has approved the establishment of an integrated network of trauma centers along India's busy highways connecting the major cities. So on that road, if you say even all the national highways, there are trauma centers after a distance of 8 to 10 kilometers. We are not aware, I think after every 2 kilometers, there is a box on the side of the road in which you can dial free of cost to the nearest trauma center. It's made, but we are not aware. There is no card required to do it. They are just boxes on poles every 2 or 4 kilometers on any highway which is newly built. So you should be aware of that. Next, please. Now the thing is, in India, there is a great potential for basically emergency medical technicians. 1 lakh vacancies is just an understatement. The requirement is more than 10 lakhs which we see. The only thing is, the problem is we have to still formalize a system where the children who take up these jobs are well paid. Because ultimately the payment is an issue. Health is a state subject. Health is not a national subject. Now states vary from one state to other states, and states have their own priorities. But there is a hidden requirement of lakhs and lakhs of emergency medical technicians in our country, and that is why there has been mushrooming of so many institutes which are imparting this knowledge. The only thing is we have to standardize the training. It should not so happen that you don't go there and you get a degree. Next, please. Next, please. So, here I would like to conclude that we have progressed a lot. Before 85 to 2001, things are very, very good. We have got a National Disaster Response Force which moves very fast, which is airlifted in case of disaster. We have a mobile ambulances. Every hospital has got its own ambulance services nowadays. So, in a metropolitan city, EMR system is very well established. The only thing we have to go a little further in the rural, because still 70 to 80% of the country stays in the villages. It is time to take stock of where we are now and plan and the directions further. India's emergency medical system is progressing. It is doing well, and sitting at NDMA, I can assure you, every year we are adding considerable amount of capacity into this particular system. And I am very hopeful that over a few years, another down the line, 8-10 years, we will be at par with any Western country. In fact, we have progressed a lot compared to many other countries. With this, I finish. Jai Hind. Thank you very much. If we have time, madam, I can take questions. I will be more than happy.
Definitely. Any questions from the floor?
Sir, as you have discussed about the technicians, emergency technicians, so there's already lack of these technicians. You have discussed. There's also places where these are not also
That's true.
available. So I want to ask that is it feasible to train the community where health and care workers could
That's why it is. See, there are a lot of efforts is going into training the community. School health, putting classes for first aid in the school curriculum.
Yes.
If it is supposed to be taught to every child. If every child is trained, let us say even 20 classes, that is more than enough. He is aware of basic first aid. So much of we spend so much of money in IC material. What to do in case of earthquake? You must have your children are told you hide beneath the desk because desk is a hard place and all those things. Come out of the building. This is also community training. The NDMA funds a group of people called as Apada Mitra. These are not uniformed people. Each state is given funds to volunteer people into known as Apada Mitra. In case of disaster, they will volunteer and come. And we run regular training classes. We organize it in the states for them. And with the hope that once we train so many people, there will be further training. A lot of things are going. Tremendous things are going. And don't forget, there is an army man everywhere. From every village in the country. And this man is trained. Whether he says yes or no, I train everyone. Anybody why? Every army soldier is trained in basic first aid. Why? अरे गोली लगेगी तो कौन आएगा तुम्हारे पास उठाने के लिए? The rule says go forward. We move forward. We cannot stop an operation because of injuries. He has to look after himself and his body. We train everyone. Just talk to them, they know everything. And I don't tell me there's any village in the country which doesn't have army, ex-retired or somebody. They are a very big potential for training. We are trying to have a system where we can rope them as Abda Mitra in India. That answers your question? Even mother teaches a child. आँख में हाथ जल जाता है तो क्या करना है, क्या नहीं करना है, आटा नहीं लगाना है, तेल में नहीं डालना है, ठंडे तेल में, पहले तो स्याही में डाल देते थे, वो भी नहीं डालना है, ये सब चीजें मम्मी बताती है ना बच्चे को. Just put cold water on it. That will be good enough. Anybody else? There are no other questions? Thank you very much.
Thank you so much, sir. I think we want to listen to you for more time. I think this kind of experience we will never find in Google or in any textbooks. And I think when time permits, you should write all your experiences as a textbook, sir, for the next generation to read and learn how to respond in the pre-hospital emergency situations. It was such an interesting session. I think the slides were not required for him to speak.
You knew everything.
He was speaking from his experience, from his heart, and with true intention of inculcating all the experience what he has to us today. Thank you so much, sir.
Thank you very much.
I think we will call you more frequently to talk to our students. We have around 570 students with us. I think you should address all of them sharing your experiences. Somewhere this experience will be helpful in saving a life in the pre-hospital
If
emergency.
my little effort motivates even 5%, I have earned my.
Thank you.
That
Thank
I
you, sir.
always say, even in my a tutor, that is good enough. 5% is good enough. They will take the flame forward. This is a light forward. Huh?
We are really honored to have you today as a speaker. Thank you.
I will take leave. Huh?
Thank you so much, sir, for helping us gain insight regarding pre-hospital emergency services. Now I request Archana to present token of appreciation to Dr. Kaushal.
Same one. Just check the vehicle in the back.
Let's move forward toward our next session, that is on ethical and legal considerations in pre-hospital EMS by Dr. Sanjeev Lalwani, Professor and Registrar Academics, AIIMS, New Delhi. His professional qualification is MBBS, Dr. SN Medical College, Jodhpur, Rajasthan, MD Forensic Medicine, May 2002, AIIMS, New Delhi, and he also got Certificate of Appreciation for promoting the cause of organ donation in India. That is given by Honorable Prime Minister Shri Atal Bihari Vajpayee on 3 August 2003, and Certificate of Appreciation by AO Education in April 2009. And also he is a member of professional bodies like Indian Academy of Forensic Medicine, executive member in Society of Trauma and Acute Care. Now I request Dr. Sanjeev Lalwani to take her session.
Okay, good morning everyone. Again, the topic is very much relevant because that is one of the fear in the mind of caregivers always. What is the legal implication in the given situation? How law is going to handle that? Whether law is giving me some protection in this regard when I am trying to help someone. So this is one fear which is always restricting the people. Arey kyun pachode mein pado unnecessarily. We don't want to help the people on the road. Okay, so law is protecting us, and we'll be discussing some legal and ethical issues related to that. Basic question in this topic is whether law allow anybody to die or facilitate anybody to die. Anybody wants to answer the question? Whether law facilitates the death in any way? Yes or no? No. Okay, so this is basic. No law allows anybody to die, and that's why we should not be fearful when we are trying to help anyone in any given situation. Next please. So when we discuss about the emergency health situation, all emergency related issues, particularly legal issues, we have to have a balance of view always, at an individual level, at community level, and considering the issues of public health which is in front of us, that we have to save the life, the person who is in front of us. Again, what Dr. Kaushal has said, there are significant interferences from the relations as well. So we have to make a balanced view always, so that we are not annoying anyone and we are simultaneously helping the person in saving the life. Always emergency working is complex, it's not easy. There are a lot of issues from all corners. Every day we have new situations which is coming to us, and we have to find solution to that. Similarly, we say that looking at that situation, we have to overcome those hurdles which basically provide some sort of a restriction on us in providing care, that is free care. Whatever way best we can do, sometimes we may not be doing that. We are basically guarded in providing some sort of a response. Again, everything is in the mind. It's whether I am going to be caught in the court of law, whether I will be asked to depose evidence in the court of law as witness, whether I should be involved in this situation or not. Many people will say no, don't involve yourself. Law is always facilitating, it is not restrictive. We should not be fearful, but simultaneously, whatever the legal requirements are, we have to respond to that as a citizen, as a professional. Whatever we do for the patient, like I deal with the postmortem examination or dealing with medical legal cases. So I am working in a hospital. If court is asking me to appear for witness for deposing my evidence, whether I should say no, or whether I should stop working, then who is going to attend the court at subsequent times and whenever I have been called. Even at times we have to travel at distance places to depose. It's not easy. Traveling by road, traveling by air, traveling by trains, staying there, waiting in the court for hours together. These all are part and parcel of our life. We should not be fearful to that. Because we have two responsibilities. One, towards our patient, towards our profession, while working in hospital, and simultaneously towards the state as well. So we have to fulfill all those responsibilities. It is not one way. and one should not be fearful. Whatever you do is in the best interest. Ultimately, court says best interest. You are trying to help someone. So these are few terminologies which are very much relevant. Whatever you do is for the best interest. You are not going to harm the patient. You are trying to help the patient. That's why law gives us protection when we are working in hospital settings. And when we discuss about the concept of pre-hospital care as well, there are a lot of legislation which are prevailing in our country altogether. Okay, next please. What is law? What is law? Anybody can give definition? Who passed the law? Court? Parliament? Government? Parliament makes the law? Okay, through the process. Sometimes Supreme Court also issues guidelines which are at times being converted in the form of a law subsequently by the government. There may be certain guidelines which are issued by court in given situations. We have earlier Vishaka guidelines which have now been converted into in form of a law, that is Posh Act 2013. So depends upon the situation. Things can come from any corner, whether from court, whether from government. And whenever we are working in professional capacity in the hospital, we interact with the law in routine, whether knowingly or unknowingly. Okay, so we have a strong relation between law and medicine altogether. Any example you can cite of relation of law and medicine?
Whatever medication we are giving, that we are working under law only. Little medicine gave wrong.
So that is your professional judgment. Okay, medication prescription is your professional judgment.
MTP Act, sir.
MTP Act. You are practicing according to the law. There are rules and regulations prescribed in that. Okay. First and foremost thing, you are nursing graduate. You have to be registered first before you are allowed to practice. So there is law. Indian Nursing Council Act. We have Indian Medical Council Act. Now a National Medical Commission Act. So first and foremost is as soon as you acquire the degree, you are interacting with the law. Practice comes later. You can practice only once you are registered. Okay, so things starts as soon as you acquire the degree. You have to be registered. So here law is regulating the practice, medical practice. Every profession is regulated by one or other law. Nursing Council, Dental Council, National Medical Commission, Bar Council. So our interaction with the law starts as soon as we are part of the registered body. And when we practice in hospital, we follow the law, we work according to the law. So one is MTP Act. Whenever there is a case of MTP, you go through the guidelines which are prescribed, rules prescribed under MTP Act. There has been recent amendments as well. Okay. So that is one example. We have Transplantation of Human Organ and Tissue Act, which regulates the transplantation process, organ retrieval process. One basic thing, consent in the treatment. Whether there is any law for the consent, any IPC, any CRPC or any other law which is there, which regulate the process of consent? Yes. If you see section 88 to 92 deals with consent only. Who can give consent and what circumstances consent will be invalid. So we interact with the law on day-to-day basis. So we should not be fearful. Whatever we do, it is according to the law. And there is a lot of interaction between law and medicine. When we provide care to the trauma person, trauma victim, we prepare the document, and that documents can be used by the court of law subsequently. Whether injuries were simple, injuries were grievous, whether they were dangerous altogether, whether person was fit for dying declaration, everybody certifies whether patient is fit for a statement. Every document which we prepare is a medical legal document in trauma situation. And these documents can be used by the court of law, and whoever has prepared that document can be summoned in the court of law subsequently. So it's an interaction of law and medicine. It is two-way interaction. One is you are helping the law enforcing agency by preparing the documents. So documentation is one of the important part. Second is you are following the law as well in your routine medical practice, whether MTP Act, whether PCPNDT Act, whether it is Transplantation of Human Organ and Tissue Act. So it's a strong relation between law and medicine. Many doctors write in prescription, it is not valid for medico-legal purposes. That has no meaning. Whatever you are writing, creating a document can be produced in the court of law subsequently. And court may ask, can you explain for what purpose you have given the treatment? You can't say no. So documentation is one of the important part as far as law is concerned, where we are helping the law enforcing agency, but simultaneously we are also following the law. So it's a very strong relation between law and medical practice altogether. So one is forensic medicine, when we are helping the law by preparing the document, whether it is postmortem report, whether it's medical legal report or any hospital record, even nursing chart. Every document is important for the purpose of court of law. In case we are following the law, we are doing practice according to the law, it is medical jurisprudence. Law pertaining to medical practice. Okay, so just to say that there is a strong relation between law and medicine altogether. Next please. How we help? This is basically just part of the BLS program as first responder. Okay, safety. Your safety as well as patient safety. That is to be ensured always. I'll be just covering very important point here. So safety is important. Seeking the help. Beside following what is, how to seek response from the patient, shaking, shouting. Okay, so there are different ways, but important thing is whenever you are trying to help, ensure your safety as well. If there is a bomb blast at any given situation, we should not rush immediately. Take some time because there may be second blast immediately after that. So safety is to be ensured looking at different situations. We should try to help ensuring the safety of the person as well as our own safety. And then whatever best you can do according to ACLS or BLS protocol in coordination with the hospital. So safety is to be ensured before you put yourself into a position of helping someone. Next. Now I was discussing something to you in the morning. Why this pre-hospital care? So these are certain data you can see which are related to trauma. Near about 950 autopsies we perform every year. Maybe 50 to 60% they are declared broad dead. So one aspect is that in case we intervene prior to arrival of their hospital, by training community, by training police person, by involving somebody in emergency ambulances services who is trained and can provide some sort of a support from site throughout the process of transfer, we can save maybe 10-20% of the life. So delay is one of the reasons for loss of life. So we can help. Simultaneously, we also have to educate the people in enforcing the law, following the law. Like in case you see out of these cases, 50% cases are related to head injury. And in case we analyze the data of head injury itself, alcohol is one of the important contributors. Mobile phone is another important contributor. Number 3 is, anybody else? Mobile and alcohol, these are major contributors. Speed, what Sir has also told earlier. Speed kills a lot of people. These are 3 basic things. And in case we ensure that people follow the law, they don't drive while under influence of alcohol, the speed is controlled. Okay, they don't use mobile while traveling, particularly on highways, it can save lives. Now, two-wheelers particularly in case we see. In case we analyze cases of head injury itself, there is a study from Trauma Center which has been published. Routinely when we see the gross cases, maybe 950 autopsies, 20% are women, 80% are the men. Women, male or female ratios, 80:20. But when we discuss the issue of head injury specifically, Okay, it may be 60-40 ratio. Females are more because of the reason that they don't wear helmet when they are sitting on the two-wheeler as pillion rider. So we have to ensure that law is followed. But still, things are not in our control. We have to educate the people at larger. Even government is trying their best. But whenever we have opportunity to interact with the people, we should educate them. And again, education should start from within our own place, house. Even many times you see children are also pointed out, "Arey, aapne seat belt nahi pehna, helmet nahi pehna." Okay, so these small things are important. And this is based on these parameters that in case we enforce the law strictly, many lives can be saved. In case we train the people at community level, many lives can be saved. And that's why we have this important aspect of pre-hospital care. Next. Now, what is ethics? What I have dealt with the word best interest, trying to help. What are ethical issues? Basically, grossly, which we discuss in patient care is beneficent. Whatever you are trying to do is for the benefit of the person. You have no intention to harm. You are not doing the act of maleficence. Okay, so you are not harming the patient. Third important thing is patient has right to choose what he wants. Okay, whether he wants to be treated, he wants to go home. You can explain everything to the person. That's how we see absconded patient, lama. These are situations which we see. So patient has right. We can counsel the patient only about the safety situation. And last important thing is every patient is same for us. Every patient is equal irrespective of their socioeconomic status. Whatever facilities are available, it is equally distributable to all. Every patient should be given equal quality treatment irrespective of their socioeconomic status. And then confidentiality is another important parameter when we discuss about the patient care. So these are very basic things when we deal with the patients altogether. Our intention is to save the life. That's why law is protecting. In any emergency situation, in case you are trying to help the patient, even patient is unconscious, nobody is there with the patient, you do surgery, it is protected. Whatever, even you intubate the patient, put many things on his body, IV line, central line, you are trying to help the patient, save the life. So you are protected. That's why we say best interest of the patient is the supreme. Next, again we have the concept of golden hour, silver hour. Earliest transport is the key for saving the life altogether. We have many situations. Maybe trauma is one. Maybe some natural disaster. That is another one. Maybe a situation where something has happened at a particular place, all of a sudden stampede all over in a temple. Some natural calamity which we have seen in COVID times as well. You don't know what is going to happen, and there will be altogether a lot of casualties, a lot of injuries, a lot of illnesses among the community altogether. So we have responsibilities at the site, during transport, and everything has to be well coordinated. Dr. Akshay will tell you later that how things are coordinated, and then you have to basically work at the sites to see who are salvageable. So triage is another important thing. Segregation of the patient to the priority area, low priority area, death cases, all these are important parts. Next, please. Now, we are working within our professional capacity. It is our professional duty to treat the patients in whatever best possible way it is. Many cases may be falling in the category of medico-legal cases, so that is for the purpose of documentation. Law is very clear. It is not going to allow anybody to die. It is to save. So whenever we have emergency situation where treatment is the priority, law enforcement is always taking it backstage. So don't wait for MLC. Don't wait. Send the patient to some places where the MLC can be registered. Law says treat the patient, give first aid, stabilize the patient, and then in case you feel, you can transfer the patient. So law is protecting in that regard. And whenever we have that situation, treatment is always the priority. Safety of the person is always the priority. Intimation to the police, again, not the priority. When we are dealing with life of human being, it can be at later stages when patient is settled. So many hospitals, they have their inbuilt system, but intimation to police is also not the priority altogether in medical legal situations. Appearance in court, it is our legal duty, professional duty as well. We can't say, as a citizen even, if you have seen something happening in front of you, you can't say no. Okay, so appearing in court, deposing your evidence as witness is this part and parcel of our professional life. One should not be afraid of. Even when Honorable Supreme Court gave a ruling on Good Samaritan Act, they said that in case it is required by the court of law, we have to help. It is not a blanket protection to everyone, that you are doing the act for saving the life, but whenever it is required by the court, you are not spared from that. You have to help the court of law. Then consent is important. Emergency situation, rule of consent is only whatever you do for the best of the patient, in the best interest of the patient to save the life. No consent is required. In case somebody is there, definitely you have to inform, but nobody is there, no attendant. Whatever you do to save the life, you are protected under section 92 of Indian Penal Code. Then we have a treatment. Again, this is our responsibility. Whatever best possible we can do, we can. Next. Now, this important judgment came in 1988-89, Pandit P.N. Katara versus Union of India. The question was, law helps the injured to die. That was the highlight in newspaper. Where one person who was driving a two-wheeler, after meeting with the accident with a car, was lying on the road. Somebody tried to help him. He was taken to a hospital, and immediately looking at the situation, he was referred to other hospital which was about 20 kilometers from that place. That they will register the MLC. We are not authorized to register MLC. The person who helped this injured victim again took that patient to the other hospital, which was about 20 kilometers by the time patient died. And that's why this case was filed in Honorable Supreme Court. It's a very landmark judgment altogether, which says injured citizen brought for treatment should instantaneously be given medical aid to preserve life, and thereafter procedural criminal law should be allowed to operate to avoid negligent death, and in the event of breach of such direction, apart from any action that may be taken for negligence, appropriate compensation should be admissible. So court made it very clear that criminal proceedings regard whatever is required, maybe informing the police, registering FIR, documenting the case as MLC, always take backstage. Emergency treatment is always the priority. And then subsequent judgment came in West Bengal Case Mazdoor Samiti versus Union of India, somewhere around 1994-1995. And this basically gave important clause of right to health to every individual as per the Constitution of India, right to treat emergency treatment, and simultaneously, in case you are trying to shift the patient from one hospital to another, it should be a coordinated effort. It should not be just like take the patient to Safdarjung hospital. No, it should be in coordination. You have to inform them that so and so patient is there. We are unable to accommodate. Though things are not practical because of many reasons. We have huge number of patients in emergency. They also have huge number of patients. We have some understanding that every hour or every 2 hours they will be accommodating some number of patients. But it is a coordinated effort. And these two judgments which came from Honorable Supreme Court, they are basically landmark judgments as far as emergency medical care is concerned altogether. And these judgments also provide some sort of a protection to the doctors who are working, or maybe I'll nowadays say it's basically a team. It's not the individual doctor who is working in hospital. Everybody from lab technician, from emergency medicine technician, nursing staff, other paramedics, sanitary attendant, they all are basically a team. which provide support in patient care. So it's a teamwork, it is not an individual's job. Everybody is protected by the law in case we are doing any act for the benefit of the patient. So we should not be fearful. Next. Then came Good Samaritan Act. People were not helping. Again, there have been a lot of video clips, many times it has been displayed on news channels as well, that nobody came to help and person died on the road. Many people have been saved by the people as well. It is not always the negative news, that people are trying their best to help the people, and many people have been saved by the Good Samaritan Act. And again, who came in support of this act? Again, Honorable Supreme Court. And in India's Good Samaritan law that was passed in form of a bill by Honorable Supreme Court in 2016. This was subsequently in form of the guidelines issued by the Ministry of Road, Surface and Transport. And again, notices were displayed in various police stations. And these notices basically gave protection to the individuals who are helping the injured victim on the road. And these guidelines which were issued subsequently says that police should not involve the Good Samaritan for investigation. So they should not be called. Number 2, hospitals should not refuse to treat the accident victims and should not charge for the first aid. So it's a free of cost emergency treatment. Then we have Good Samaritan should be protected from civil and criminal liability. It also says Good Samaritan need not to reveal their identity. So any patient can be brought by anyone in the emergency. Patient is handed over to the hospital staff and person can leave. It has also been cited many times that though the person who was responsible for injuring the person has brought the patient in hospital, left it to the hospital, at least it was a good act on his part. He was shifted to hospital. So even if person is coming to the hospital to or bringing the injured person to the hospital, he should not be asked to reveal his identity altogether. And then we have that they can choose to be an eyewitness and should not be compelled otherwise. But Honorable Supreme Court has a little bit reservation on that. So in case you have seen something, as a citizen of India, you are responsible to assist the court of law. You can't be spared for that. So whether it is documentation, whether what we see in front of us, we are liable for everything as a professional. Next please. Most important thing. Whenever we are trying to help, we should try that investigation is not going to suffer subsequently. Evidences which are required for investigation should be preserved at the best possible. In case somebody has met with injuries because of bomb blast and there are some foreign particles inside, we have to preserve during the process of surgery altogether. And it should be handed over to the investigating officer. Even if we are recovering some bullet from the body, it should be handed over to the police. So evidences are to be preserved altogether whenever required, and in case we are asked to appear in the court of law, we have to appear in the court of law as professional. And again, nowadays things have changed significantly. Court is also giving due respect to the medical professionals. They are not wasting the time which was earlier observed on many occasions, but they are trying to free the medical person who is appearing in the court of law at the earliest. And nowadays even there is liberty that instead of 10 o'clock you can go at 2 o'clock by the time maximum work of the court is over in the morning hours. And at 2 o'clock you are basically given the first priority altogether. So everywhere we are given protection. We are protected by the law. We should participate in any act which is for the benefit of the humanity and public at large. So these are certain things which I wanted to convey, that everywhere there is protection. One should not be fearful from the law. But yes, we have to fulfill our legal responsibility, but these are not the immediate requirement in any emergency situation. We have to work in a team. Everybody is equally responsible, not less or not more. Everybody is equally responsible, and we should continue to provide all sort of a support in any given situation. And I hope that you will be contributing significantly in healthcare setup as a team and everybody is to be given due respect when we are working in a team. Everybody is playing its own part as far as outcome of the patient is concerned, always. So this is something which I wanted to convey. Any question you want to ask? You can, please. Thank you. Any question you want to ask? I have within time. Yeah. Yes, please.
One time I was at Lucknow railway station and saw a patient who meet with rail accident and under the supervision of RPF. I tried to serve him. I had some medication and I asked them, but they refused me to do something.
That's again, these are basically issues because of lack of awareness at many levels. Okay, so in case you see somebody is trying to help, there is no restriction on that. It is because of lack of awareness. We have to create awareness among the people who are working in different settings. So you can see now that with the awareness, there are arrangements even at airports. So you can see that AED and everything are available at the airports in case you want to help someone. So it is just because of lack of awareness that these things are happening altogether. And we have to go a long way. I totally agree with you that you tried to help, but people were not interested in taking your help. We have to go a long way as far as the support system establishment is concerned, that who can help at any given situation. Any individual who has been trained in BLS program can provide any sort of a support in any emergency situation. So it is just because of lack of awareness, and I hope that the way airport authority has created awareness and established emergency care system in the at the airport itself, it will be coming in railways as well. But we have to take up these issues. I think Dr. Akshay through they have a good team which is creating a lot of modules for training at different levels altogether. Even recently we have been requested by Delhi Police as well. They want to collaborate with us for providing training to all their sub-inspectors who are going to join in future as far as this BLS and ACLS program is concerned, so that they can provide training. So they are requesting for signing an MOU with us. We are in process of discussing that how we can collaborate. But again, railways another area where I think emergency faculty members can take up the issue whenever they have opportunity to improve the system, and any emergency support which can be provided at then and there itself is available at that particular site, and anybody can be providing that sort of a support. So that requires some sort of awareness, nothing else.
So there is one question that is not related to the medical law, but just before you, one sir was saying that he's seeing some dead person. After 20 hours, that dead person is moving his hand.
So I think one response from your side was appropriate, because we have seen in brain dead patients. Yeah, so I am coming to that question. So one answer was given about this ledger sign. Somebody that is it is seen in brain stem. It is seen in brain death cases, particularly when we are declaring somebody brain dead, and then all of a sudden there is movement of the limb altogether, or people are just thinking of that whether really person is dead, the person is moving the limb. So that is one part as far as brain dead people are concerned. Movement is because of rigor mortis. When rigor mortis is appearing in the body, a dead body, which takes 1 to 2 hours on an average, and it starts from top to bottom. So when this process of rigor mortis is appearing in the body, there are contractions of the muscles. That's why body is becoming rigid in next 12 hours. It's totally stiff. And because of these rigor mortis, sometimes you see slight movements in the body altogether. The reason is rigor mortis, nothing else.
So then what is Lazarus affected?
It is basically spinal reflexes. It's related to spine. These are spinal reflexes, not related to brain stem.
So one practical what we are facing now in emergency, एक कोई भी पेशेंट अगर बाहर emergency registered हो चुका है किसी भी हॉस्पिटल में, is it necessary to register him again as emergency?
One thing is, maybe we are not documenting appropriately as MLC, but when we are registering the patient, it should be MLC, because somebody who has been already labeled MLC at some other place, you are not labeling it, what will happen subsequently? All documents will be non-MLC then. In case there is death of the person during the course of treatment, body will be handed over, citing it as non-MLC as far as our hospital is concerned. So it is to be labeled as MLC always. All documents should be MLC. Okay, that's why we say there is no harm in making one extra MLC. But in case you miss one and body is handed over to relation, there are a lot of complications subsequent. We may not document in that green sheet as MLC altogether, making it a proper document as far as MLC is concerned, since MLC has already been made, but registration is always under the MLC category.
तो जो भी MLC registration हुआ है किसी भी अदर हॉस्पिटल में, तो यहाँ again it will be different MLC registration.
Yes, हमारा अपना registration number होगा. We have our own. We are responsible from the date we have taken over from the patient.
Secondary sir, अगर कोई minor है, कोई बच्चा है, अगर हम उसका MLC कर रहे हैं, तो we always like to take left thumb impression for the patient. तो बच्चे का क्या हम thumb impression लेंगे या उसके related?
देखो, purpose is identification mark. Whether thumb impression or something else, you can even take some birthmark or mole or any other identification mark. Thumb impression, it is not necessary. It is basically a practice because it is easy rather than looking at various injury mark and then documenting it. You need not to ask anything. Just take thumb impression and put it on the paper itself. So we can take any other identification mark. Mainly 2 identification marks are required as far as MLC is concerned. So thumb impression is not the issue as far as identity is concerned. We can take any other marks altogether.
So the purpose of thumb impression is identification.
Yes, the purpose is identification. Even you can identify the person by other 2 injury marks, black tail, mole, or any other birthmark which is related to that patient.
Sir, in the presence of court, see, right now in our hospital, what we are doing, that we are doing the repetitive things.
Repeated?
Means repeating the things like charting in nurses chart, in treatment papers, in computers. Is it necessary to chart everywhere?
No.
But our senior saying that it is necessary because according to the law.
No, actually, again, there is basically some.
Yeah,
This is something.
what
This is something which is internal policy. We can discuss it within our team. Whenever you have interaction with the faculty in the morning, or maybe you have a group meeting where all the staffs are there.
Sir, I am just asking when we have to produce some document in front of the court, what exactly is needed?
Like suppose I have prepared some document. I am responsible for that. Okay. So a court may even ask entire case file. Entire case file.
Entire case file. Is it the nursing chart or the treatment?
Mainly is the treatment and details of the injuries or any other surgical procedure which has been done. It is not basically what you do, how you monitor the patient in routine. That may not be relevant. But court can ask the entire file, and even in negligence cases, any expert can look at then how care was given. Okay, then it is basically an overall responsibility, not the individual responsibility.
In many cases, nurses' documentation has saved as a proof because we have got pakka handing over process, no, every shift. So many a times the nurses' notes have supplemented the
Yes.
progress of the patient and has saved the hospital in many cases.
So ultimately it is overall care which has been given to the patient, particularly in negligence cases when entire document is asked altogether, who has done what, at what time. But whatever you are telling that it is basically something, in case some duplication is there, that can be avoided in consultation. Ultimately we have to make a policy that how we are going to document a particular thing.
Duplication, lot of effort is there, and at that time we are lacking with the patient here.
Yeah, I understand that, but that can be sorted out, and
That
that can be sorted out in our discussion within the department itself. You should bring it to the notice of your in charge, and then that can be sorted out at that time.
It is very
Okay.
heartening
Yeah.
to see so much of interaction there.
So I'm
So,
lacking in
yeah.
time because there is another delegation which is coming up, so I have to rush. Thank you very much. And any question, you can move to me anytime. Don't worry about it.
So only to add on, Indian Nursing Council has revised the syllabus and now they have added one new subject called forensic medicine. Now we realize the value why we should learn forensic medicine, the basic principles. and how to behave in the hospital setting when there are medical legal issues.
Thank you.
Thank you, sir.
In case you have any query, you can move to my office anytime.
Thank you, sir. Thank you, sir.
Thank you, sir, for giving your valuable time and helping us to upgrade our knowledge regarding ethical and legal consideration in AIIMS. I would like to invite Mukesh Kumar, PB student, for giving token of appreciation to Dr. Sanjeev Lalwani.
As a chief guest.
That was the thing.
Ma'am on screen.
On screen. Here, sir. Thank you so much.
Moving forward, I would like to welcome Dr. Akshay Kumar, MRCP Medicine, FACEE Emergency Medicine, Associate Professor, Emergency Medicine, AIIMS, New Delhi, to start the session on disaster preparedness and field triage. Dr. Akshay led large validation study over 15,000 patients to test the AIIMS triage protocol and the AIIMS sepsis protocol. Developed and led National Acute Critical Care course for doctors and nurses across India. Led key quality improvement projects in improving sepsis care, STEMI care, triage and emergency airway. Welcome, sir, and over to you.
So, will I change the slide?
Yes. Slide 2.
So, a very good morning, all of you. Thank you for having me. Special thanks to the College of Nursing for organizing this and having me here. So today's discussion, I was very pleased to hear Dr. Sanjeev Lalwani talking about ethics and all the legal issues which we go about every day. So today, this topic is slightly different, and we are going to again relate it to your pre-hospital system and disaster preparedness. But mask, utar de mask. Is there? Yeah, I'll just take it off because I saw doctor. So, right. So the idea is to sort of enhance. I don't know if you've had formal training in disaster. We do not have a disaster program in India as such. We have very limited programs across India, and but I think we are very prone to disaster in India. I mean, in Delhi, every year there is a disaster of some kind, whether it is a bomb blast, whether it is a sudden COVID. We've been seeing COVID disaster for the last 3 years now. Every first wave, second wave, now the third wave. So there have been disasters since I've been at AIIMS for almost 10 years now. So we've seen dengue disaster. We've seen there was a Mayapuri mein radioactive disaster. So we've been having lots of disasters. And the awareness, I assume, is not so little, and that is why I was asked to sort of talk about this very important topic. So next slide, please. So in my next half an hour to 40 minutes, I'll be talking about the concept of disaster, types of disaster, the characteristics of disaster, preparedness and planning at national and community level, mostly focusing at the hospital level, because we are all working in the hospital. I assume most of you are working in the hospital, so we'll be talking about that. Decontamination, triage, and treatment, minor treatment, basic treatment in the disaster setting, and field disaster response, where we'll be having some question and answers. Okay, so next slide, please. So the concept of disaster. Right. So the WHO defined disaster as a sudden ecological phenomenon of sufficient magnitude to require external assistance. Okay. Now, a hospital disaster is an event which overwhelms the resources. So, koi bhi disaster, any disaster which will overwhelm your system. Okay, it can be just one single patient. Let's say, the Prime Minister of India comes to the emergency department. Maybe a disaster actually. Why? Because all the resources will be for the Prime Minister or somebody. So somebody very influential, or let's say a very big businessman comes to the emergency department, the head of the departments are coming, all the team is there, 20 doctors are lining up, nurses are there. So
that can also become a disaster. So when a single patient can also be disaster, then depends on your setting. You may be a small hospital in rural India, and you have 5 cases of organophosphate poisoning. That is a disaster for a small hospital. That may be a disaster. So the disaster is a relative term, depends on your scenario. So it may be defined by, at AIIMS, we are very used to see VIPs coming in. So for us, a VIP coming is not a disaster, but if a VIP gets to a smaller hospital, it may be a disaster there in terms of the resources being used, in terms of everybody having to be involved, and it's overwhelming the resources. A single patient, for example, with organophosphate poisoning may be a disaster if there is no expert present there. Let's say there is no toxicologist or somebody who's not an expert in managing organophosphate poisoning. There is no physician who knows about organophosphate poisoning, and it is being manned by just a new team. That may be a disaster for that area. So disaster is a relative term, and you have to understand whenever it overwhelms the resources, when you call it a disaster. Event is a disaster or not depends on the time of the day, time of the presentation. So if, let's say, 20 cases of trauma present at 2 in the night, okay, it may be a disaster. But if the same patients come in the early hours of the morning when the whole team is there, it may not be a disaster. You understand? So time of the day is also important. So agar patients are in raat mein 2 baje, senior doctors may not be present, nurses may not be, an adequate number may not be there. There may be a small team, so then that can be a disaster. So, and the nature of injuries. Let's say radiation injury ho gaya. Somebody was working on a nuclear plant in Rajasthan or in Andhra Pradesh, is being brought to emergency at AIIMS. He's a suspected case of radiation injury. He is just 1 or 2 or 3 patients, and he can be a disaster because the kind of event he's gone through, the nature of the injury he's had, is a suspected case of radiation injury. We are not sort of equipped to manage a radiation injury in our emergency department. Okay? Not many people are trained in managing a radiation injury. Not many people know how to handle a radiation injury when it comes to triaging or treatment of these patients. So that also is a disaster. So before I go on to the other aspects of disaster, this is a very important slide. ठीक है? ये इसे कहते हैं disaster cycle. ठीक है? तो इसमें 4 parts होते हैं. So one is the mitigation phase and the preparedness phase. This is where we are right now. आज I am doing a public education. I am doing a education of the nurses and the doctors today. Right? So I am doing an awareness session, which is what I am trying to mitigate. I am trying to create a awareness. Preparedness phase, where you talk about training, exercises. I believe the next sessions are talking about training and exercises. Also, you have a policy, a standard operating procedure in your institute, and that is a part of preparedness. You should have a telecommunication response plan, a national emergency phase. So all of that is the preparedness phase. So the mitigation and the preparedness phase is a very important phase. Right now we are doing a mitigation phase because we are training, we are educating, we are creating awareness. So all of that, we are part of that. When the response happens, when the disaster happens here, this is the response phase. So the response phase is when the communication and the coordination starts, when you have to save lives, when you actually have to be on the ground, you have to go on the field. This is the response phase. And then जब disaster खत्म हो जाता है तो आप recovery phase में आते हो. जैसे कि COVID खत्म हो रहा है, right now in the COVID, as long as COVID is concerned, we are in the recovery phase, kind of restoring. We are going back. The trauma center is moving back. We are telecommunications में जो problem हुई थी, जो director की meeting होती थी हर morning में, that is now being coming down. Earlier we are having a meeting every day. Now we are having a meeting once a week only. So we are going back. So it's a recovery or rehabilitation of other services. So we are recovering. OPDs had were curtailed. Now the OPDs are back to normal. So OPDs are back to normal. So things like that. So you have this cycle you have to remember. So we have always, if the disaster isn't happening, we have to be carrying. So as an institute, as a government, as a Delhi disaster authority, or an NDMA authority, National Disaster Management Authority, my challenges and my priority is to think about mitigation and preparedness at all times. Mitigation is also, trying to see कि safety हो, जैसे earthquake zones है, let's say there are earthquake prone zones, तो वहां पे जो घर बने वो earthquake proof हो, या जो घर बन रहे हैं coastal areas of India में, let's say Orissa में there is a problem with hurricane, so जो घर वहां बन रहे हैं, the authorities should look at reducing the number of houses close to the coastal area so that next cyclone may they are not affected, lives are not lost, people don't have to leave their homes and move to other areas. So that is also a mitigation practice. So mitigation is at a national level, it is at improving infrastructure, it is improving the authorities, national authorities looking at preventive things, how we can prevent next disaster, things like that. Okay, so I'll be talking about the preparedness phase today. So what are the types of disaster? Natural disaster, okay, so earthquakes, tsunami, hurricanes, man-made disaster, vehicular crash, industrial explosions, terrorist related disasters, we all know that. Then disasters have been classified in different ways. There's an external and internal disaster. External जो hospital के बाहर हो रहा है, internal जो hospital के अंदर हो रहा है. Let's say there is a hazardous material spill हो गया, radiotherapy room में radiation exposure हो गया, power failure हो गया, there is no electricity in your hospital, it may be a disaster. So that is an internal disaster. Then they have also classified acute and non-acute disaster. एक event हुआ, it is an acute disaster. Long event चल रहा है, जैसे COVID है. COVID is a non-acute disaster because it's been going on for 3 years now. So there is no well-defined starting point. It can start any time. They are saying June में 4th wave आ जाएगी. So it is a non-acute disaster. Acute disaster is like एक explosion हो गया, या एक earthquake आ गया. So that is an acute disaster which happened suddenly. So there are different classifications of disaster that we have to understand. So these are some of the common natural disasters we've been seeing. I'm sure in the last 10 years we've got all of that. So we are not far away from disaster, and Delhi is also on the earthquake belt. So we should be very careful about this, and it's important that we know and have awareness about disaster management. So disaster की characteristics क्या हैं, right? So a lot of studies have been done, a lot of papers have been published around disaster, especially from Japan. Japan has unfortunately been where a lot of tsunamis have happened. They do amazing disaster training. They have a very DMAT training where they do disaster training as well. And what they have seen कि जब भी disaster होता है, सबसे पहले जो hospital पास में hospitals होते हैं, वहाँ सबसे पहले जो patients पहुँचते हैं वो minimally injured patients होते हैं. They are minimally injured. उनको चोट ज्यादा होती नहीं है और वो सबसे पहले पहुंच जाते हैं because they self extricate themselves. They don't come by ambulances. They reach by themselves. वो अपने व्हीकल से ऑटो लेके आ जाएंगे, उन्हें थोड़ी सी चोट लगी है या थोड़ा सा, तो हम लोग ने भी देखा जब ट्रॉमा सेंटर में एक बार डिजास्टर हुआ था, देयर वाज अ बस कैजुअलिटी, तो जिनको कम चोट लगी वो पहले पहुंच जाते हैं. एंड देन इट इज फॉलोड बाय most affected patients reach a little later, okay, and the peak is expected at 2 to 3 hours after the event. Okay, so that is when the peak happens. So let's say there is an accident close to AIIMS, some big accident. Let's say there's a railway accident where more than 500 people are injured, expected to be injured. So the least injured will likely to be present first. Most जो सबसे ज्यादा injured होंगे वो pre hospital care लेके आएगी, उनको EMS system लेके आएगा, ambulance लेके आएगी. They will reach a little later. Okay, so that is the flow of patient. You have to understand that. Why you have to understand that कि जो माइनर आएंगे उनको रेड एरियाज में नहीं ले लीजिए, आप माइनर्स को अलग करिए, अदरवाइज आप, क्योंकि जो सीरियस पेशेंट आने वाले हैं यू हैव टू कीप स्पेस फॉर देम. ओके, सो ऑलवेज अंडरस्टैंड सीरियस पेशेंट्स पहले नहीं आएंगे, माइनर पहले आएंगे, सीरियस बाद में. दैट इंपॉर्टेंट इज इंपॉर्टेंट. एंड द वास्ट मेजॉरिटी प्रेजेंट सेल्फ ट्रांसपोर्ट टू द हॉस्पिटल. सो दे जस्ट कम टू द हॉस्पिटल, ऑटो लेके आ जाएंगे, किसी की हेल्प कर देंगे, कोई वॉलंटियर्स उनको रिक्शे पे लेकर आएंगे. सो दे विल जस्ट कम टू द हॉस्पिटल. Then infectious disease का जो pandemic का जो disaster होता है, that is usually a slower onset of surge and hospital volumes remain elevated for a longer time. So, for example, in COVID we've seen hospital volumes have been elevated. अभी भी COVID के patients वहाँ पे भर्ती हैं, and it's a slower onset of surge. धीरे we've seen the wave rise. It's not like an acute disaster period. So these are some characteristics. So let's say there is a disaster, somewhere in the community. Let's say there's a natural disaster, there's an earthquake happened about 100 kilometers from Delhi, and we are the emergency team or the hospital team working in medicine department, ICU, emergency medicine, and trauma areas. And so what are the problems we are going to face? So let me have from you. Any problems you encounter? So what are the problems we can face? Let's say there is a disaster हो गया एक, you understand? एक disaster हो गया. अभी patients, अभी आप hospital में हो, बहुत भीड़ हो रही है hospital में. So what are the problems you may face as a medical care provider? Please, yeah, आप बताओ. Yeah, anybody wants? आप बताओ. Sorry, anybody?
Coordination नहीं है medical.
Coordination नहीं है. That's a very good point. Coordination between
the medical team, क्योंकि कोई अगर disaster team नहीं बना रखी है तो coordination नहीं है तो we can don't try कि किसको priority में red patients करना है. Suppose जैसे हमारा trauma center है वहाँ पर बिल्कुल significant है कि red patients यहाँ जाएंगे, green यहाँ जाएंगे,
right.
yellow.
So what she's talking about is intra-hospital coordination. So within the hospital, triaging is not proper. Okay, so classification may be a problem. Very good point. Anything else?
Minimal resources.
Minimum हो सकता है resources enough ना हो. Ventilator की जरूरत है, ventilator नहीं है. Bomb explosion हुआ है, patient में need ventilator. Okay, resources in terms of infusion pump नहीं है, fluid नहीं है. You know, PPE नहीं है. Let's say COVID हो गया, suddenly 100 patient आ गए, डेंगू आ गया, 100 patient आ गए, एक दिन में IV fluids नहीं है. For example, let's say. So resources नहीं. What are the other problems we can face? Sorry? Manpower नहीं, very important. So human resource नहीं, doctors नहीं है, nurses नहीं है, support staff नहीं है. We need support staff. We need HAs. We need sanitation people to help out because there will be a lot of, you know, it's a teamwork as we discussed in the last lecture also. What are the other problems?
Inadequate transportation.
Inadequate transportation. Yes, so there may be a problem कि जहाँ disaster site से hospital site में आने के लिए there may not be enough vehicular transport available. Very good. Anything else? Lack of experience. So training नहीं है. Very valid point, and we are going to discuss that I think in the subsequent presentations where we are going to talk about disaster drills and all that. Very good. Any other points? What are the other problems which we may face?
Communication.
Communication, right? Very important point is coordination and communication within the hospital, with the ICU, with the emergency. Emergency में patient आएगा उसको ICU में जाना है या medicine ward में जाना है. Pre-hospital communication with the emergency department. So pre-hospital notification system is not. So it's overall coordination which may be a problem. Okay. So with that, because now we have discussed the problems, what are the solutions? So what are the components of a disaster plan? So hazard vulnerability analysis. So what is hazard vulnerability analysis? Part of the disaster mitigation. ये hazard vulnerability analysis तब नहीं करते हैं जब डिजास्टर हो जाता है, ये तब करते हैं जब डिजास्टर नहीं हुआ है. फॉर एग्जाम्पल राइट नाउ वी शुड हैव अ हजार्ड वल्नरेबिलिटी एनालिसिस ऑफ एम्स. वी शुड डू कि क्या क्या प्रॉब्लम्स पॉसिबल हैं in let's say in our area where we live. For example, if I was working at AIIMS Rishikesh, I know there are a lot of landslides happening there. If I'm working in the I know landslides are happening. Landslides में rubble होता है. Landslides में we've heard of Kedarnath में there was a huge landslide which resulted in so many deaths. People were lost. We don't know what happened. So what happens there? People get rubble में फंस जाते हैं. Rubble, there's a lot of rubble. People get trapped. There may be people who may take 2 days, 3 days to get them out. Extrication time is long. So you need to look at different morbidity patterns in different kinds of disaster. So that is hazard vulnerability analysis. So what is like, for example, in Delhi, any kind of disaster can happen. Delhi is so located. We have seen radiation disaster. We've seen a chemical disaster. We are liable for we should be planning. We are a tertiary level center. We can plan big. But let's say there's a small center in Himachal Pradesh. They should be more. They should have a specific planning for crush injuries, because in earthquake there is crush injury. In landslide there is crush injury. Crush injury में फंस जाते हैं और उसमें आपको you can have long extrication time. तो dialysis की जरूरत पड़ सकती है. Cardiac arrhythmias होते हैं. So things like that. Similarly, if you are living in Rajasthan, जहाँ पे एक बड़ी industrial agency है, वहाँ के hospital हो तो वहाँ पे आपको chemical disaster का डर है, तो you should be planned for that. फिर hospital community coordination होना चाहिए. That is notification and communication system should be present. There should be an integration with national response. So NDRF should be communicating with your system, with your facility, and there should be training, disaster exercises, mini drills happening all the time. So there is a hospital planning group for disaster. So what is that group? That group has a public and safety, security is very important. So you should have a crowd controlling, facilities, engineering, structural damage अगर कुछ हुआ है hospital के अंदर, या हमें structural changes करने पड़ रहे हैं because of COVID. Let's say COVID की वजह से हमें एक special ward बनाना पड़ रहा है. So we need engineers, we need to make these porta cabins to house, or we need to make a special decontamination room, let's say in chemical disaster. So you have to think of facilities, engineers. Hospital administration is at the center point of all this because they are the people who are coordinating all these activities in our setup. Most of the big hospitals in India will have a hospital administration department who will be coordinating all this. They'll be coordinating the disaster response. Then clinical, we need clinical experts. We need experts of emergency medicine. We need experts of ICU team. We need experts of physicians. We need surgical team, pediatric teams, etc. Then pharmacy has to be there. We have to have access to antidotes. Sometimes chemical disaster में हमें we atropine चाहिए होता है. You know, in let's say organophosphate poisoning. Sometimes we need other antidotes like we are suspecting cyanide poisoning, so we need an antidote for cyanide poisoning. So all of those has to be coordinated from the store in charge and pharmacy in charges as well. Then there should be a media and public relation in charge who was talking. जैसे हमारे यहाँ है AIIMS में कोई भी event होता है, there is a media personnel who interacts with the media. The doctor and the nurse team cannot speak to the media. We don't have the time, plus we do not know how to speak to the media. There's a special group of people who handle this media, and there should be a single point of contact for media. Media को कोई भी बात करनी, कोई भी news चाहिए, so there is a press conference with the media personnel which should be done, and there is a public information officer which is also for every institute, big institute, they have a public information officer also. Then there's an infection control team. So a lot of people, hospital planning group, they are also part of the disaster team. Like in COVID disaster, we had an infection control team playing a huge part. There was an infection control committee. I'm sure some of you may have worked with them. They were looking at each and every, they were identifying gaps and looking at how we can strengthen the infection control in each of the areas, let's say emergency area, ICU area, etc. And then there is a training team who is involved in training. For example, we had a training team for COVID. We trained all OT technicians, resident doctors, nurses, online, offline. We did PP training in how to wear your PP, etc., etc. So then there's something called hospital emergency operational plan. Okay. तो एक तो हो गया planning group. तो कौन-कौन से लोग involved? Who are the people involved? Okay. So we have clinical doctors, we have administrators, we have security, we have engineers, we have public relations, we have infection control team and training team. Right. Training team may include nurses, College of Nursing. It may include faculty from different departments. They may be part of the training team. Like today is a training, right? So we are part of the training team where we are training you in disaster management and disaster preparedness. So right, so this is hospital planning group. This is the hospital emergency operation plan, wherein what are the plans we must do? What do we have to achieve? What do we have to do? So the most important thing I like to highlight is this is a crowded slide. A lot of things here. The most important thing is the incident command system. Once there is a disaster in your hospital, there should be an immediate incident command system should be. Can you give me an example in COVID of an incident command system? Any one of you? No, मैं बोल रहा हूँ बहुत सही पॉइंट बोला आपने. Incident command system का क्या मतलब? So this is what was happening. Was anybody attending the directors meeting in the morning? During COVID, did anybody go to the directors meeting? So the director meeting every in the morning where Dr. Randeep Gulere was sitting in the board room or in the Jawaharlal auditorium, that was the incident command for the COVID pandemic. Everybody would come there, right? Like the CNO maybe will be there, the chief nursing officer, all the HODs of different departments who are involved in COVID care would be there. Senior faculty members would be there. Administrators would be there. So that was the incident command. Incident command जो होता है, कभी भी emergency हो, कभी भी disaster हो, immediately there should be an instant command. So there's a team, they control everything. So what they do is they make plans. They meet every day or sometimes twice a day or thrice a day. Right? Abhi jaise Ukraine crisis chal raha hai. There is an instant command system, which is, I don't know if you're following the news, I'm not following it so much, but I know there's the Prime Minister is holding meetings every day, sometimes in the leadership of the Prime Minister, sometimes by the leadership of the Ministry of External Affairs, Dr. Jaishankar. I think Dr. Jaishankar is the External Affairs Minister. So they are what are they doing? It's an incident command system. So they are assessing the problem, they are making strategies कि कैसे evacuate करें students को वहाँ से. Right. Similarly, when there was COVID, we had an incident command system. वो करते हैं, assess करते हैं hospital capacity, surge capacity create करते हैं, communication system establish करते हैं, support areas develop करते हैं और decontamination triage और treatment का planning करते हैं. So all of that is controlled by the incident command system. So if that, so now coming to decontamination, this is a very important part. Decontamination is usually where, let's say there's a chemical disaster. Okay, there's an industrial explosion. We have heard of the Bhopal gas strategy, the infamous Bhopal gas strategy, which happened in 84. Like 85, so many people died. I think 2,500 people died. Unfortunately, so many lives were lost, and this was so bad. So in a chemical disaster, there's a huge role of decontamination. This is usually done outside the hospital. It is not within the. So you make a quick tent, or you have a space, open area, space outside the emergency department. This is ideally where it should be done, and you have water showers there, and or you have hoses here, and where you have a decontamination area. Now decontamination जो होता है बड़ा important concept है, has to be done. The principles of decontamination is, if you have to take one thing from my slide, because this is a crowded slide, warm water for 5 minutes. That is the best decontaminant. People talk about bleach लगा दो, saline से धो दो, कुछ जरूरत नहीं. All you want is warm water. If it is a chemical, if it is a gaseous form, then washing will not help. Right? If it's a gas, let's say you are exposed to a gas, a poisonous gas, that phosgene gas, right? Phosgene gas will go directly in your respiratory tract. You will not be helped by washing yourself. But if it's a solid particle, okay, let's say it's a vapor, it's a fume. Okay, there's a difference between a fume, aerosol, dust particle. Okay, I will talk about this if I have time. I will discuss all those things. But right now, if I have to say one thing is, gaseous disaster, gaseous in हो गया है तो आप कुछ कर नहीं सकते. मतलब there is nothing you can do. But if it's a chemical disaster, you can see solid particles, or you can see a radiation disaster where there may be shrapnels of the radioisotope. Then you can sort of clean the area. पहले कपड़े उतारेंगे patient के, उनको कपड़ों को अच्छे से store करना पड़ेगा, because that may be causing secondary contamination. In radiation disaster, you will have to keep them in double bags so as to prevent further contamination of those clothes. Then wash them, rinse with water and soap. Soap may not, if not there, is okay. Warm water is important. Okay? Now triaging and treatment. And then the second thing is, after you have decontaminated, you do triaging and treatment. So how do you triage? So these are the 4 major categories of disaster triage. I am not talking about hospital department, emergency department triage. Emergency department triage is slightly different. Today I am talking about field triage, which is disaster triage. Disaster triage is slightly different because the resources are very limited. The system is overwhelmed. There are too many patients and very few people to help. So here you have a black category. Red, yellow, green, sabne suna hoga. There's a black category where patients have no spontaneous ventilation or circulation. And these patients, you do not do anything. Because you will not, let's say they are not entirely dead. They are just not breathing. If you may be able to do a CPR. If you had the resources, you can do a CPR and maybe they will come out. But in a disaster, you will not touch them because they will suck up all your resources, and you may not be able to save these patients or these patients who you may be able to save, red and yellow patients. So the black are the ones who are unresponsive patients without spontaneous ventilation, and in ideal circumstances, you should be providing them CPR, but in a disaster, mass casualty incident, you will not do that. So I have a scenario here, and I'd like any one of you to read that. Anybody wants to volunteer, or I can then? आप पढ़ोगे? Want to read that? Let's sit down and read.
There is a road traffic accident. There is school bus full of young children hits a truck in the outskirts of the city. You are unknown person in the medical rescue team sent to the scene. How would you try?
Right? So we have a scenario here, not so uncommon. This happens every second year. I have been through it. We have been in trauma center. We have managed this. Now, how would you triage? Anyone, any guesses? We don't have a lot of time, so any one or two responses will be great. Then we move on to the second. Yeah, anyone? ये आपको बोलना है? How would you triage? क्या करोगे? जैसे आप फील्ड पे पहुंच गए हो, वहाँ बच्चे को चोट लगी है, कुछ बच्चे ऐसे they are in blood. What would you do?
We'll assess the type of injuries.
Yeah.
Patient having a wound, like serious wound, or like there's breathing issues. Go with the red one.
Great. Okay. So she is trying to say she'll try to stratify the patient based on what on each and every patient you'll go. Great. Okay. We'll go to the second scenario. I will discuss the answer to that. Okay. Can somebody read that? Can you read this now? Yeah. आप read करो.
So you're on the scene of an industrial explosion. A chemical disaster has happened in the outskirts of the city. You are one of the rescuers in the emergency response team. So first, how would you triage? Principle of triage in the scenario, and third one is the medical management.
Okay. So anybody wants to discuss this? This is a chemical disaster. Okay. I'm giving you different scenarios. The previous one was a vehicular accident. It was a car or a road traffic accident. This is a chemical disaster. Anything anyone wants to say? What is important here?
First, we have to assess what type of chemical.
Yes.
Then
नहीं chemical तो पता ही नहीं चलेगा ना. Chemical तो usually 10 दिन बाद पता चलता है.
If it is in the gaseous form or it is in the liquid form.
Okay.
If it is gaseous, already you said that there is no other way to
decontaminate.
If it is in the liquid, or you can see the particles, so you can take the person first of all will take out the cloth and then you will put warm water.
Very good. So she's what she's saying is follow the principles of decontamination and then followed by triage, which is what you are coming at. Great. We'll discuss this as well in the next slides. Before I go on to the third slide, which is if somebody wants to read, आप read करेंगे? नहीं दूर है थोड़ा. Anybody आप read?
Three men have presented to your emergency department together, following nausea and vomiting for last 12 hours. The three men work at the nuclear plant located in Rajasthan. How would you approach this scenario? Principles of triage and management.
ये real photo है राजस्थान की. There's a nuclear power plant in Rajasthan. This is a real photo from there which I've got. Okay, so there are. I'm giving you a scenario where let's say you're working in Jaipur, and there is this nausea and vomiting के साथ, and you're suspecting a radiation injury. What would you do now? Anybody? Anybody wants to answer? I'll go on. Okay. So these are the scenarios we are talking about, and these are not unreal. These can happen to us. We have had patients who have suspected radiation. हाँ बताइए.
Like first we will see that how we will decontaminate them.
Right.
Okay. And then we will bring the experts who are experts in this.
आप ही लोग हो experts अब. आज के बाद आप लोग experts. That's what my slide is. Okay. So we'll discuss that. Thank you very much. Yeah, we'll move on. Right. So going back to triage, and I'll come to all those scenarios in my next slides. So what is triage? Okay. Triage means to sort or to separate. It's a French word, comes from trier. This was first used by Napoleon in Napoleonic War in the 18th century, where battlefield triage was done. उसके जो soldiers घायल हो जाते थे, उनको वो triage करते थे. और वो कहते थे इसको ज़्यादा चोट लगी, इसको जल्दी ले जाओ, इसको कम लोड, इसको रहने दो. Things like that started happening on the battlefield, and that's how triage was developed. Triage was first developed from the battlefield in 18th century. Okay, so the modern triage was developed by Dr. Fitzgerald after he completed his thesis in Australia. So we will not want to, so that is just a little bit of history on. So the other concept is urgency is not the same as severe. Okay, that one concept is also important. Patient may be very serious, but he is not urgent. Okay, one example I'm giving from hospital emergency triage is, let's say a patient has terminal malignancy, liver cancer hai, brain mein mets hain, right? He's very serious. He's hypoxic, he has liver cancer, he has pleural effusion, he has massive ascites, I'm sure some of you may be working in medicine ward, oncology, IRCH, have seen such patients. Okay, so this patient is a very serious patient, but he's not urgent because whatever you do, you cannot change his condition. He has terminal malignancy. Unlike a patient who's dislocated knee joint, a dislocated knee joint can cause compromised circulation. वो young patient है, otherwise fit and fine है, उसको पहले urgent हो गया. He's more urgent than this patient. So urgency is not the same as severity. That's one concept I wanted to. Okay. And before we go on to what field triage is, I want to highlight this law of utilitarian. This is a law of utilitarian, prioritizing patients who are likely to survive and leaving those who are unlikely to survive. So that may look a bit unethical to you कि सर इसको क्यों छोड़ दे रहे हैं हम, इसको मरने क्यों छोड़ दे रहे हैं, right? You may say in field triage when there's a large, let's say a mass casualty incident, you have only one ambulance or two ambulances, and you have 500 victims. Who will you try to save? Okay, you will try to save somebody who has a chance of survival, or you would like to save somebody who has no chance of survival. That is where this point comes. Okay, so this is the field triage. This is called the START protocol. I don't know if अगर आपको clearly दिख रहा है कि नहीं, but I'll read through it very quickly. This is called simple triage and rapid treatment. So what you do is able patient is able to walk. तो जैसे disaster scenario पे गए, जो पहला scenario मैंने दिया था, truck young children वाला, किसने पढ़ा था? आपने read किया था, right? Young children वाला. Disaster scene पे गए, 50 children हैं, बेचारे सब पड़े हुए, किसी को चोट लग गई. बच्चों जो जो चल सकते हो वो इस तरफ आ जाओ. Those who can walk come on one side. ये पेड़ के पास आ जाओ. तो एक आपने जो green patients है वो एक तरफ आ जाए. उनको छोड़ दो, उनको पे ध्यान मत दो. उनसे कहो कि आपको एक बस आएगी, आपको ले जाएगी, थोड़ा वेट कर लीजिए आप. क्योंकि जो चल सकता है, जो आपकी बात सुन सकता है और रिस्पॉन्ड करके वहां जा रहा है, दैट मींस इज ABCD इज स्टेबल. एयरवे भी ठीक होगा, ब्रीदिंग भी ठीक होगी, तभी तो वॉक कर रहा है. सर्कुलेशन भी ठीक होगा और वो डिसेबिलिटी भी ठीक होगी. यू कैन अंडरस्टैंड व्हाट इज सेइंग. सो वो माइनॉरिटी हो गए. दोज आर योर ग्रीन पेशेंट्स. Don't attend to them. Then you go to patients who are lying there, who are not able to move. Then you assess them one by one. You look for spontaneous breathing. Are they breathing or not? Yes, they are breathing. You look at their respiratory rate. Respiratory rate less than 30, you look for perfusion. Perfusion is present. Radial pulse is present. Then you check their mental status. Mental status is present, then delayed. So they become yellow category patients. Okay? And if anything is present, spontaneous breathing नहीं है तो रेड हो जाएंगे. Respiratory rate more than 30 है तो रेड हो जाएंगे. Perfusion present नहीं है, capillary refill time more than 2 seconds है, radial pulse absent है तो रेड हो जाएंगे. Mental status low GCS है तो रेड हो जाएंगे. So if that is clear, and black are the categories who are expectant death, where there is no spontaneous breathing, you position the airway, patient is still not breathing, you will just leave them alone. They are black patients. You will not act on them because they are not priority, because even if you put your efforts, we will not be able to make. Let's say you are on a bomb blast scenario, okay? There will be some patients who had a tracheal damage. Okay, they are not breathing. I mean, you will not be able to repair the trachea on the site, and it is 2 hours away. So even if you take them, they are probably going to die on the way. So those are your black patients where you don't want to intervene. Okay? So there is a similar scenario. This is a similar flow chart from the pediatric age group. Pediatrics में क्या है? हल्का सा difference होता है, same format होता है, but यहाँ पे when the patient has apnea, you look for pulse, and if there is no pulse, then there is black, and if there is pulse is there, then you give 5 breaths, 5 rescue breaths. If there is spontaneous breathing after rescue breaths, then it becomes red. So there is a slight difference between pediatrics and adults. Otherwise, it is the same. Red, yellow, green. Green को आपने पहले ही अलग कर लिया, and black. ठीक है? So triage in chemical disaster. Chemical disaster में सबसे important है, there is a hot zone, there is a warm zone, there is a cold zone. Let's say कि आपको साइट पर भेजा गया. We just went through a scenario, right? Who read that scenario? किसने रीड किया था? आपने रीड किया. हाँ. तो आपको जो सिनारियो मिला था उसमें ये देखा गया था कि there was a chemical and you are on the scene. So that what you do is you make a hot zone. Hot zone में वही personnel जाते हैं जो कि properly equipped हैं. They are wearing level A PPE. This is level A PPE. इसमें ऑक्सीजन जो होता है within the bag होता है. within the suit होता है, completely encapsulated suit होता है. You should not be going inside a chemical disaster scenario. Medical team जो होती है, we don't go in the hot zone. So we don't go in the mishap side. We will usually stay in the cold zone. So in hot zone there is scoop and run. बस patient को उठाओ और भागो, बाहर निकलो, उठाओ और भागो, क्योंकि वो hot zone है, वहाँ पे chemicals का exposure है, जो वहाँ पे let's say workers हैं, वहाँ पड़े हुए हैं, उनको जल्दी जल्दी वहाँ से निकालना है. You bring them to the warm zone. Warm zone में you do little bit of decontamination. You do decontamination in the warm zone. You don't do decontamination in hot zone. You do decontamination in the warm zone, and you provide some treatment, minimal treatment. Let's say किसी को external hemorrhage हो रहा है, tourniquet लगा दिया, वो airway ऐसे कर रहा है तो airway खोल दिया. Minimal basic things जो आप कर सकते हो, you can do in the warm zone and shift them into cold zone after decontamination. Cold zone is the zone जहाँ पे decontamination already होकर patient आया है. So this is where you can wear a level C suit. Level C suit is kind of like wearing your N95 mask, kind of like what we are doing now. You can wear your water impermeable suit जो हम लोग आजकल पहनने हैं blue वाला, that is level C. इन्होंने different picture दी है, but even a N95 respirator mask is good. Okay? So that is about chemical disaster. So this is where triage happens. Triage happens in the cold zone, decontamination happens in the warm zone, hot zone से निकाल के भागना है. Radiation emergency, which was the third scenario which I spoke about, is the radiation injury. इसमें again you should develop a contaminated area and a clean area. So let's say हमारे पास 3 patient आ गए, AIIMS emergency में 3 patients आ गए, radiation injury के. Radiation emergency suspected, right? We suspect they are from nuclear power plant in Rajasthan. They've come to us. So what we'd like to do is, we'd like to keep them outside the ED. We develop a small area. We have a contaminated area and we have a clean area. So in the contaminated area, we decontaminate them. So we remove their clothes, we brush off, right? We wash them with water or saline. We avoid scrubbing, and the staff can wear a water-resistant gown, cap, shoe covers, double gloves, N95 mask, sir, and there should be a radiation meter होता है जो available है हमारे पास. न्यूक्लियर फिजिसिस्ट को बुलाना, आपने बोला था ना, एक्सपर्ट्स को बुलाना पड़ेगा रेडिएशन इमरजेंसी में. यू आर राइट, यू हैव टू कॉल दी न्यूक्लियर मेडिसिन में जो डिपार्टमेंट है उसमें उनकी टीम को बुलाते हैं हम लोग, एंड बायोफिजिक्स के डिपार्टमेंट के लोग बताते हैं, दे हैव दीज रेडिएशन मीटर्स. सो आफ्टर बिफोर डिकंटामिनेशन यू डू अ रेडिएशन सर्वे, एंड आफ्टर डिकंटामिनेशन यू अगेन डू अ रेडिएशन सर्वे बिफोर यू ब्रिंग देम टू द, बिकॉज वो टी आवाज करती है रेडिएशन मीटर, बिकॉज दैट कैन डिटेक्ट इफ देयर इज अ रेडिएशन हैपनिंग. अल्फा, गामा और जो रेज होते हैं वो डिटेक्ट कर लेता है वो रेडिएशन मीटर. सो इट्स कॉल्ड अ गीगर मुलर काउंटर भी कहते हैं. Okay, so that is how you manage the radiation emergency. So this is the last slide, I think, before we take on questions, and I will sort of discuss other things. The treatment is basic. Basic treatment करना है casualty में, field triage पे या emergency के बाहर जब mass casualty है, you just do basic treatment. What you do? You can manually open the airway. You control external hemorrhage by putting tourniquet. Direct pressure. पहले तो direct pressure लगाइए. Direct pressure से control नहीं हो रहा, then you put the tourniquet. Tourniquet cannot be left for more than 2 hours. Tourniquet, so you can put the tourniquet and shift the patient to higher center where trauma experts or surgical team is available. Okay, but you cannot put a tourniquet for more than 2 hours. If it's more than 2 hours, then you will have to think about direct pressure only. Okay, but tourniquet is very effective. So you put a tourniquet 5 centimeters before the wound. Let's say there's a wound in my forearm. I'll put it just 5 centimeters above that. Okay, if there is a wound on my joint, I have to do it before the joint. I never put a tourniquet on the joint. So these are common principles of tourniquet application. Do not perform CPR in mass casualty. It is difficult to not do it, I know, because of, but that is the dictum. That is the dictum. Disaster के अंदर CPR में सारे 6 लोग लग जाएंगे आपके एक CPR करने में. वो दूसरे पेशेंट जो आप बचा सकते हो वो आपके मुश्किल हो जाएंगे. So that is why disaster में do not perform CPR. Wounds, okay, sometimes you don't have to do anything. Let's say there is a closed non-angulated fracture. उस पेशेंट को बस हल्का सा स्प्लिंट कर दीजिए और 24 घंटे बाद वापस बुला लीजिए, rather than कि आप उसका एक्सरे करा रहे हो, फिर उसको ऑर्थोपेडिक्स टीम को बुला रहे हो, ऑर्थोपेडिक टीम उसमें बिजी हो रही है. It's not required. There is nothing you will gain by repairing the fracture right now. or just put a splint and send them home. उनको बोलो 2 दिन बाद आओ, अभी तो डिजास्टर चल रहा है, right? और उनसे कहो छोटे हॉस्पिटल में चले जाएंगे, वहां करा ले. This is not serious. It's a non-angulated closed fracture. Wounds may benefit from delayed closure. All wounds don't have to be closed right away. Let's say a patient has cross contamination. उसको बस अच्छे से copious fluid से धो दीजिए और पेशेंट को कह दीजिए ठीक है और अंदर एडमिट कर दीजिए, इमरजेंसी खाली करिए. वो डिलेड क्लोजर बाद में क्लोज कर देंगे, कल क्लोज कर देंगे वुंड को, अभी तो वैसे भी कंटामिनेटेड है, या पहले से 2 दिन पुराना वुंड है, ठीक है ना, उसको अच्छे से ड्रेस करके जल्दी से अंदर शिफ्ट करा दीजिए. So you have to know how to manage your resources. You cannot have your resources overwhelmed, and these are some strategies I'm showing. Do not use radiology and lab in everybody. Don't start doing troponin T and D-dimer and VBG in every patient who's coming in a mass casualty. You have to use what X-ray. Do you have to need an X-ray or not? Like in a blast injury, you will need a chest X-ray because blast injuries can cause pneumothorax. If a patient is having chest pain after a blast injury, bomb blast happened in Karol Bagh, patient has come in now having chest pain, pneumothorax is very high likely. So you may not even need a chest X-ray. You will examine, you see percussion, you just do the ICD. Sometimes you will need a chest X-ray if you are not sure. So point of care ultrasound is hugely important. It will have a huge, it will be very useful. And blood bank is something you have to be very, careful about having if you have a blood bank, it will be very useful to have access to at least 50 units. You should have volunteers. The volunteers should be able to access the blood bank so that they can come over and give in blood. जो ये long extrication time होता है ना, let's say patients जो होते हैं, they were in the rubble for a time. There was this incident which happened in Kerala. There was a boy who was stuck on the mountain for almost 2 days. I don't know if you heard that story. It was only recently 1 month ago. Or if you have a scenario where a boy has gone inside the tunnel and like in a trap down, and it's taken 3 days to bring him out. So in those instances, earthquake instances where some people have been in the rubble for almost 3 days, 4 days, those patients there is a chance of the muscle injury. In muscle injury, there is hyperkalemia. And when you have hyperkalemia, you can have cardiac dysfunction, dysrhythmias, and you can have late onset need of dialysis because these patients may go rhabdomyolysis. So, ये सब चीजें आपको disaster में सोचनी. Okay? Sorry, my slides are gone. But that was really my last slide. So, I'm happy to take any questions if you have. My talk, in summary, I'll just slide लगा दीजिए, last slide. In summary, I'd just like to say that you should be able to understand what disaster is. Okay, disaster is when the system is overwhelmed, whichever system it is. It may be just caused by 1 patient in a small hospital. It may be caused by 10 patients in a small hospital. It is dependent on your scenario. हमारे यहाँ AIIMS emergency, if you have seen, it's a chronic disaster. है ना? अभी भी आप बाहर जाएंगे 50 पेशेंट वहाँ खड़े हैं बाहर. Okay, if that happens in New York City, they will national holiday. But in India and Delhi, it's happening every day because we are a high volume department. Chronic disaster now it is acceptable. कि भाई 50 पेशेंट बाहर खड़े, normal चीज है. Right. So, but what I'm saying is disaster is different. It is overwhelming. Second important point which I wanted to make is the concept of triaging and decontamination. The concept of triaging in chemical disaster, in a field disaster, in a radiation injury, the concept of and the principles of decontamination, and the incident command system in a hospital disaster. That's a very important concept which I wanted to highlight. The incident command system is very important because that is the nerve control or the central commanding which coordinates with everything. The incident command जो होता है वो establish करता है कि भाई आप मीडिया संभालो, आप जो भैया इमरजेंसी के HOD को बोल दिया कि आप सारे मेडिकल और ICU को आप देख लो, फिर उसको बोल दिया, एक प्रोफेसर को बोल दिया कि आप जो है सारा ट्रेनिंग आप संभालो, सब बच्चों का कोविड में ट्रेनिंग करो, है ना. नर्सिंग इंचार्ज को बोल दिया आप सारा एडमिनिस्ट्रेशन देखो, आप देखो लॉजिस्टिक्स, इक्विपमेंट में कमी नहीं होनी चाहिए, वेंटिलेटर की कमी नहीं होनी चाहिए, थिंग्स लाइक दैट. सो ऑल ऑफ दैट इज कंट्रोल्ड बाय द इंसिडेंट कमांड सिस्टम. सो if those 4 things have gone through you, I think it's a successful lecture for me. And I think you are partially trained in disaster now. So thank you very much. I'm happy to have any questions. Yeah. नेट गया तो बहुत तो चलेगा presentation.
If time permitted, we would have loved to have a longer session on the same.
I'd love actually मैंने कुछ I have to there's so much to discuss and so much to talk about कि radiation emergency पे ही पूरा 1 घंटे का lecture actually. But I had just one slide to show you. So the idea is to give you an idea, to give you a concept कि concept क्या है. और हमें सबको अवेयर होना है. We are all working. All of you are working in clinical areas. All of you are nursing teams. We have to be aware of disaster. We have to be knowing कि ये हमें करना पड़ता है, ऐसे लेवल पे करना पड़ता है. Institutional level पे disaster management होता है. District level पे Delhi, there is a Delhi Disaster Management Authority. There is a National Disaster Management Authority also, NDMA, which is trauma center के पीछे है.
Morning में जो speaker थे
जी
हमारे Dr.
exactly.
कौशल.
Morning में जो पीछे थे वो NDMA से थे. So it's at different levels, and my target was basically hospital-based disaster level, which I was covering, but touching on. So thank you, ma'am.
Same principles you can use in the field as well. Okay. जो
Sir, yeah.
When should reverse triage be decided, sir?
Yeah. So this is a very good concept. This is called re-triage. Okay, re-triage में ही reverse triage आता है. So triage is, what is triage? Triage is you separate the patient. So you said somebody को आपने रेड करा, पेशेंट रेड था, ऑक्सीजन डिमांड था, आपने ऑक्सीजन स्टार्ट करा, फिर आपने देखा न्यूमोथोरैक्स था, अपना ICD डाल दिया. Now saturation is getting better, he's absolutely stable, pain relief. You now reverse triage him to yellow, so that red bed is available. If you come to our emergency department, we are triaging so patients come to red, then they down triage to yellow. Or sometimes yellow patient is up triage to red. So triage is a dynamic process. It is not कि एक बार triage जो हो गया वही हो गया. अगर green patient आपने जो शुरू में बच्चा चलकर चला गया वहाँ पे, बाद में उसकी सांस फूलने लगी तो he will be red. Right? So this is why very good question is re-triage and re-triage. Triage and then re-triage.
Only category probably black would not change.
Yeah.
Probably
Black
I
would
said
not
because
change.
sometimes.
Yeah.
Any more questions, inputs?
Thank you.
Sir,
Yeah.
sir, for radiation injuries, is there any specific way, like specific chemical which can be used to decontaminate?
Specific?
Like specific chemical, like as you said that we can use like remove that clothes and all, but still the patient will be emitting radiation.
Water.
Right?
Water is the best way of doing it. A lot of studies have been done. They have looked at different things. Bleach powder वगैरह भी use करें. But they're saying water, warm water, because availability is not there. अगर आप कोई उन्होंने देखा substance उन्होंने बहुत बना ली है, but availability नहीं है ना. Warm water will be available everywhere. It is easily accessible. तो आप water से धो दो. It is the best way. Soap and water or saline water.
Okay.
But normal water is also good.
So some special clothings will also.
So what you do is lead containers होते हैं. तो ideally जो clothes होते हैं ना, जो वो lead container में जाने चाहिए. So the lead container will protect in further radiation emittance, if you understand.
So all these hospitals have these kind of suits, special lead
So lead container अगर नहीं है, let's say lead container नहीं है, so you can have a double bag. Like COVID में हमने किया double bag. So जो COVID का होता था, you can double bag. So 2 plastic bags, thick plastic bags, one on top of the other, and then you can store. And then you should have a system of you contact the radiation experts, and you have a system of disposal of these clothes, because they cannot be disposed in a normal
Will decontaminate till the radiation force that.
Yeah, तो उसका radiation मुझे भी मतलब I've hardly used it once, so I'm not an expert on that. But वो radiation meter होता है, वो radiation meter आप पूरा scan करते हो, survey करते हो. तो जब वो आवाज नहीं कर रहा है, that means the patient is clear. You can bring him to cold zone or the clean area. If he is still contaminated, you have to wash him.
Okay, so the medical providers who have given care for a patient with radiation injury, so after that, whether there is any particular protocol for that patient, like that care, healthcare providers?
Very good question. Sorry, I didn't talk on that. That's a very good question. I think we should address this. So there are chemical disaster में secondary contamination high risk होता है. There is a high risk of secondary contamination. In radiation disaster, the chances of secondary contamination is not so high. For example, if there is a radiation patient and I am working to decontaminate him, my chances of getting contaminated by him is low, not very high. As long as I am wearing my N95 mask, मैं वो impermeable water जो water resistant suits होते हैं वो पहन लूँगा, shoe cover पहन लूँगा, cap पहन लूँगा and I'm wearing N95, I'm fine. It shouldn't be work. So I shouldn't be worried about my contamination. As long as वो जो clothing है वो मेरे से दूर है. That's important. But in chemical disaster, one has to be very careful. So chemical disaster में you have to have that suit which I showed you, right? Especially in the hot zone, and even in the warm zone, you have to wear proper suits because secondary contamination in chemical disaster is higher.
So
So
if
that's a good
somebody is having the gas,
Gases, yeah.
gas exposure, so how we can decontaminate it?
You cannot really. You just have to treat the symptoms. So you have to assess the symptoms. अगर respiratory symptoms हो रहे हैं,
So
respiratory symptoms होंगे. गैस तो respiratory symptoms ही करेगी.
So sir, if let's say person will start having asphyxia, so
Yeah, oxygen, ventilation, and you're trying to find out what the gas was.
So how you will take out the gas?
It will not be taken out. I mean, it will ventilator जब आप करेंगे तो exhale करेगा patient.
It has to go into blood.
Yeah, there's nothing you can do. You cannot decontaminate a gases because he's inhaled whatever he has. It will cause some injury. There is no process of decontaminating air or the system कि आप ventilate या lung में जाके lung को clean कर दें. There's no system like that. You can ventilate the patient. That's all, and you have to wait for it to work.
Okay, we are very happy to see so much of the interaction. I'm sure you have some more questions. We'll request Dr. Akshay to stay over even for lunch.
Okay.
After one speaker has been waiting now. We will have to go into next session and quickly then thereafter we'll break for lunch and then we can over lunch we can have this discussion with everybody.
Absolutely. Thank you, ma'am. Thank you. Thank you, everybody. Thank you.
Thank you very much, sir, for your valuable inputs and upgrading our knowledge. Now I would request to Aditi to give appreciation to Dr. Akshay Kumar.
सामने देख के बच्चे फोटो बहुत
फोटो ले रहा है क्या? फोन नहीं ले रहा है, कोई बात नहीं.
हो रहा है सर. और थोड़ा सा इधर आने पड़े.
Thank you.
You can remove your mask. So we can.
Thank you.
Thank you so much. This was very informative.
Yes, thank you.
So now our next session is on pre-hospital care providers, training, roles and responsibilities by Dr. Savanam Thirumala Thangarajan, MDS, FICO USA, FAD Germany, Advancement Implant Surgery Japan, FAA Sweden, MBA Healthcare Management. Tamil Nadu State Nodal Officer for Pre-Hospital Training and SPOC for Emergency Medical Learning Center. He will be joining us virtually. Hello sir, kindly unmute yourself please.
Hello. Is my presentation visible?
Not yet, sir.
Not yet sir.
Hello.
Now it is visible sir.
Visible.
Dr. Shravan, you may proceed please. Your slides are visible.
Oh, okay, fine. Yeah. Yeah. So, a very good afternoon to one all present there, and a happy Women's Day to all ladies and women there. So, this is Dr. Ramnan here from Tamil Nadu, who is a state nodal officer and a spokesperson for the Emergency Medical Learning Center. Am I audible?
Yes, sir.
Oh, okay, good. So basically, before I could talk into the hospital care management, I just want to give you a brief idea of how exactly it works. So when you see an emergency or an accident on the highway or the road, you immediately tend to call 104 health helpline. When a call lands to a 104 108 call center, an ERO, who is known as the Emergency Response Officer, he receives the call and he will assign an ambulance based upon the requirement. Either it requires an BLS ambulance, ALS ambulance, or a neonatal ambulance. And as the ambulance is assigned, en route to the site, you can get your either ERCP, who is known as the Emergency Response Center Physician's Advice on the go, or once you see the after initial assessment of the patient. So along with the physician's advice, you can stabilize the patient at this scene and then transport the patient to the emergency department or the appropriate facility where it is required. Okay, so this is just a brief gist of how exactly it works. So the emergency medical services works on the so-called SRC model. What does SRC stand for? Sense, reach, and care. So sense is nothing but the emergency response officer where they are all located, which is your response center. So we receive the
Excuse me, Dr. Shavanan, your slides are not moving. Are you moving the slides or is it the same?
Yeah, I've changed the second next slide.
No, actually at our end, this is not moving. Can you please go back? No.
Is it changing now?
No, it is not really changing.
Full screen करके हो जाएगा?
Now?
No, full screen, yeah. If you do, not yet changing. Okay, now, yes. Now it is changed.
Changing now?
Right. Yes.
But this is visible for in full screen?
Yeah, emergency medical services, right?
Not full screen.
Yeah.
If you put on slideshow, probably that will be better.
Yeah, put it on slideshow now.
Oh. This is not
Is it
slideshow.
changing?
This is actually not showing in the slideshow.
Ah.
Is it visible to everyone? Not yet.
Now it's changing, right?
Can you go on to the slideshow, please? If there is a problem, we can actually project from our end.
Yeah, fine. I think I shared my presentation also.
Yeah, so shall we project from our end?
Yeah, fine.
Okay, so you may please stop sharing.
Yeah, stop it.
हमने सोचा था कि में थोड़ा टाइमिंग देंगे बट somehow with the discussions our time is right now at best after lunch थोड़ा टाइम I was wanted कि सबको थोड़ा सा मूव करने के लिए टाइम दें that was important.
Okay, Dr. Shravnan, we may begin
Yeah,
now.
fine.
You may please begin
So
now
next slide,
and you
please.
can ask her to change the slides whenever you want.
Hello? Yeah, hello?
Hello, yes,
Next
please.
slide, please. Yeah. So just a brief introduction of how exactly the emergency response center works. So once you receive an emergency, the call lands to our 108 call center, and that the so-called the ERO, who is the emergency response officer, collect all the details of the victim and assign the nearest ambulance based upon the case scenario. I just require the previous slide, please. Previous slide.
Previous one. Second, third.
Just based upon the need, I just require basic, advanced or neonatal, and en route to the site or the scene of the case, you can get your ERCP, who is the Emergency Response Center Physician's Advice. And once you reach the site, after the initial evaluation of the patient, you can either transport them or give the basic first aid and then transport them to the nearby facility based upon the case scenario. Next slide, please. So, how does this EMS service work? It works on the SRC model. SRC stands for Sense, Reach and Care. So sense nothing but the where the emergency response officer are located, who take up the or get the details from the caller and transfer these details to the ambulance. So they form the sense part of it. Once this data is captured and transferred to the ambulance in turn reaches from the grave site to the site of injury or the site of accident. So that is known as a reach. So the vehicle reaches to the site, and next the care part, which is given by the paramedics, who are known as the EMTs, as emergency medical technicians. They provide a pre-hospital care at the site and during the transport of the patient from the site to the hospital of stabilization. And in the mean course of time, they can take the ERCP, who is known as the Emergency Response Center Physician's Advice, as and when required. Next slide. So basically, rough idea. So when a call lands to 108, it goes through various internal servers, and you have several emergency response officers who take up the calls, and not all calls need to have an ERCP advice or an ambulance assigned. So based upon the severity and the case required, we assign an ambulance, and in the meantime, we take the ERCP advice. Next slide. So the paramedics who are posted or who are in the ambulance have been broadly classified into two categories. One is the basic and the advanced. Basic paramedics is nothing but who provide the basic life support and who are educated like basic nursing. Next slide. But in case of an advanced paramedic, next slide, they are trained for the previous one. They are trained for all the defibrillation and all the complete IV fluid, tracheal intubation. So all these they've been well trained, and they go rigorous reinforcement courses before they come under advanced paramedic. Next. Next slide. So talking about the healthcare system, which includes your physicians, nurses, allied health providers, EMS, along with the support personnel, it also includes the next slide. Includes the healthcare system, which includes your primary health centers, hospitals, district hospitals, and your teaching colleges. And along with that, in Tamil Nadu, we have something which is very unique of Tamil Nadu, known as emergency care centers, also known as emergency stabilization centers. So there are 12 centers currently in Tamil Nadu which have been situated along the highways where there is no hospital situated within radius of 15 to 20 kilometers. So they form as a primary stabilization center, so that the patient is taken care of all the first aid measures, and then they are transported to the higher centers as and when required based upon the advice. Okay, next. So talking about a brief introduction about the roles and responsibilities of these paramedics is nothing but they should first know about the person safety, next followed by safety of the crew, patient and the public. Then they have to do the initial assessment and care based on the assessment, and then they have to transfer the patient from the scene site to the hospital and also maintain the record of whatever medication given or the treatment given, along with maintaining patient advocacy. So all these form the basic roles and responsibilities of an EMT. Next slide. Apart from these, the professional attributes which require are the appearance, how you appear. The EMT should be well dressed, groomed, and clean so that you feel that professional way of approach, and you become a person who represents the organization, especially a government or an emergency response personnel. So your appearance, your attitude, how you speak, the knowledge, skills, the patient's need, and understanding what the patient needs and addressing that issue, all this plays an important role. Next. And in case of doubt, you can always look in for online or offline medical directions. Online is we have the physicians who are always available 24/7 at the health center to give you proper medical direction and give you consultation. And offline requires, which means your protocols, your manuals and protocols which you always carry in the ambulances. So they help you to act as a guide to make your decisions in the right way. Thanks. Next one. And apart from that, here we have a continuing education. We have a collaboration with Stanford School of Emergency Medicine. So every year, yearly once, we have a seminar or a refresher program conducted by them. Apart from that, we have regular training for the paramedics at a center in Tamil Nadu at various centers. So this is forms the patient care. What happens after the patient care and how do you maintain the quality of this care is done by quality improvement, assurance and management. So quality improvement is nothing but how we keep developing or evolving our healthcare system based upon the need and the requirement of day-to-day conditions, situations, for example like COVID, how we are trying to cope up with new strategies. So that is quality improvement. Quality assurance is nothing but your resource management, which includes your management of your ambulance, manpower, and how do you allocate them and based upon the caseload, and you need to know how to manage these resources, and not only educating your EMTs or paramedics how to handle a case, you definitely need to give a motivation so that they feel motivated to work in the field, because they are the first people or the profession who meet the case or the patient on the site, and then after initial stabilization only they are brought to the care facility, and they should have the capacity to give a solution to the particular situation. And apart from this, quality management, which includes your patient care review, which the documentation which you make, and the review of all those documentation, and along with the feedback from your fellow co-workers. So usually the evaluation is done with the help of known as patient care record. It contains a list of questions or the parameters which needs to be noted. So this PCR record stands as a history for the case which we are dealing with, and it stands for another 5 to 10 years. So any case you want to evaluate retrospectively, or you need to do a cumulative compilation of a disease course or a condition over a period of time, these PCR records give a play a very important way of role in assessing all your parameters required. Next. So the EMTs have an obligation to be knowledgeable and provide technically proficient care. So it is a basic necessity for an EMT to be knowledgeable, to upgrade themselves as and when time required. Next. So, and here's the 5 rights which he should know. The first one being, next, the right patient, next the right drug, right dose, right route, and right time. Next slide please. So talking about the right patient, next slide. So there may be, you might be usually having only one single case, but there are times where you might have several patients, like in case of mass casualties. So what happens is, you need to know, select your patient accordingly, an apt patient who needs emergency or medical care at this point. So for that, we do known as a triaging system. We, as previous presenter was said about the disaster triaging, this is known as your clinical triaging, which we do in the ambulance. So which is based upon which is based on CTAS, which is Canadian Triage and Acuity Scale. Next please. So it has 5 levels. Level 1 is resuscitation, level 2 is very urgent, level 3 is urgent, level 4 is less urgent, and level 5 is non-urgent. So based upon these categories, you can categorize the patient into critical and non-critical. Change. Next, you categorize the first three into your critical and the next two into non-critical. Next. So what are the things which come under critical are unresponsive patient where there's no pulse, no breathing, where pulse present is after CPR, and even traumatic amputation cases and case of severe PPH. So all these comes under level 1, sorry. And under level 2, it comes under very urgent as the unconscious who have GCS scale between 4 to 8 or the pulse less than 50 or greater than 100, and all these parameters who are active labor and abdominal presentation, gunshot, foreign body obstruction. So all these comes under very urgent. Next. In level 3, which is urgent, if we have several parameters to be evaluated, such as depression, suicidal thoughts, and heavy menstrual bleeding, where the acute levels are between 91 to 93. So all these comes under level 3 category. Next, less urgent, which includes when they're conscious but disoriented, where the GCS scale is between 13 to 15, and the pulse is anywhere between 60 to 100, with mild contraction for in case of pregnant labor women, laceration, mild bleeding. All these comes under less urgent. Next, and finally the non-urgent, which includes patients who are really well conscious, and ANC mothers or minor contusions, operations, all these, and any diarrhea cases where pulse is 60 to 100 and respiratory anywhere between 12 to 20. So all these comes under non-urgent. So selecting the right patient is very important. Next, talking about the right drug. So you should know which drug to be given, and before you administer the drug, you need to check your label of the drug once again, and always check the expiry and the route of administration, which is very much important. Next slide, please. So next is the right dose. So right drug we have selected, but you need to know what dose it has to be given. So in case it requires, either you can refer with your manual protocols or manuals which is available in the ambulance, or you can just cross-check with your ERCP or physicians who are available all the time to know the right dosage of the drug. Next. And the right route of administration. Though you might be familiar with it, at times you might tend to miss which route of administration is required. So you can always refer your protocol. Next. And the right time. You should know what measure has to be given at what point of time. So all these 5 rights are very important and mandatory, which has to be kept in mind. See, when we talk electively, this all fine and sounds good because we have a steady state of mind to think about. But when in case of an emergency, when you're handling a new situation, it is totally different. So, and always we make sure ensure all the EMTs to keep this so-called empty containers till they hand it over to the hospital. Why? Because there are certain conditions where you might be inquired about what medications have you given, how much you have given. So that time you need to maintain. It's not a hospital setup, you're just moving transit, right? So always maintain your empty container, and always important thing is documentation is very important. Nothing is not documented is as good as not giving or done treatment. Next, coming to the roles and responsibilities of the EMT. Next slide, please. So what are the roles and responsibilities? Let's have the little discussion. So which of the following is not a primary responsibility of the EMT? Could anyone give me an answer? Either consulting with an ERC physician, diagnosing the internal bleeding, following, I think we have changed the slide. Okay, fine. Diagnosing internal bleeding, following the EMS protocol, or reassessing the patient with chest pain. Starting all these 4, ERC primary is to consult the ERC physician in case of any child, and follow the EMS protocol is mandatory. Reassuring the patient of chest pain is a basic responsibility of the EMT, whereas diagnosing of internal bleeding is not the primary work. Why? Because next slide, ERCs are not doctors. They have a different responsibility. Next slide, please. EMTs are not doctors, so they have a separate different responsibilities. They are extension of your next slide. They are extension of your doctors. However, they are not doctors. So always their major motto is to bring a hospital close to the home or the site of injury, thereby increasing the chance patient or the victim's chance of survival. Next slide. Apart from this, the other roles which includes the act as a safety officer, safety for the patient and for the surrounding people, and they also act as a healthcare provider. They also need to maintain the database or records of all the treatment given and all the initial assessment done, and they also have to act as a role model. Role model as in that they represent the entire organization or to the person whoever the public oversees, they consider them as a role model and they take that as a motivation factor so that they can help in future. Next, talking about the other basic responsibilities, which includes they should keep updating their knowledge and skills along with the renewals, all the ALS, BLS renewals, and always have an update about the EMS protocol manuals, and they should always have a regular continuous education programs along with they should know the limitations too. They are not physicians in the first place. Though they play important role, they are not physicians. So anytime when they are not sure what and what not to do, they can always get help from the ERCP physicians. Next. So one thing or one motto which you always need to keep in mind is do no harm. If you are not sure, get help assistance from a physician, but never do harm to your patient unknowingly or if you're not sure what is to be done. And taking care of patients is a privilege, it's not a birthright. Next. And at the time of graduation, you always take a vote like next slide please. That even in the worst days of our life, such as in case of patients either severely vulnerable, confused state or severely diseased or a traumatic condition, we need to be stable. I mean the EMTs have to be stable enough to handle the situation. Next slide. You might face a situation. See, each day could be a different situation for you, and every situation could be a fresh and new for you. But in spite of all this, you need to work with confidence and earn the trust of your public and the so-called the victim. Why? Because next slide. And how do you achieve this? Is by because you need to be professional. Previous slide, please. You need to be professional. Previous. Yeah. You need to be a professional. You need to know your code of ethics, and the right positive attitude is mandatory for an EMT physician. So just not knowing your basics of your ALS, BLS doesn't suffice you, but you need to know how to act at that point of emergency. Next. So apart from that, what are the other attributes the EMS profession should carry? You should have a quality of leadership, honesty, empathy towards this fellow colleague or the patient. You should be self-motivated. You can't keep expecting motivation from the public or the others. You need to keep yourself self-motivated and boost your confidence at different situations. And the more of appearance also matters a lot. Why? Because a well-dressed, well-maintained profession is warranted for this kind of profession. And you need to develop your good communication skills and develop a good teamwork along with your pilot, who is your ambulance driver, and along with the nearby peripheral centers and hospitals, so that you have a good team to good rapport, so that you can pass on the communication to the hospital and to your CPS to get a better control of the situation. And you need to respect your fellow colleagues with the proper time management, and most important is documentation of whatever has been done, along with doing right to the patient and not doing what you feel like. Yes, thanks. Next. So don't expect praise from others, but just tap yourself on the back. You have done a good job. You have saved a life. That matters. So yeah, just stay on the slide. So you should in this next slide, please. Next slide. Yeah, just stay on the slide. So I would just like to ask this. So a casualty physician asks you to start an adrenaline drip, which is 100 micrograms per minute. You know it is in the wrong dosage or an incorrect dosage. So what would you do? How would you react to this situation? After talking about so much of what responsibility, what attitude a EMT should carry, what would you do? EMT in the sense a paramedic. It doesn't mean have to be an emergency ambulance paramedic. Any paramedic, what should they do? Either ask the physician to review the dose with you based upon the EMS protocol, or try explain to the physician this is definitely gonna be deleterious to the patient, or you just start the trip. Why? Because you just have to follow your orders, or you just tell classification you have given, but you don't start any drop at all. So what would be your options? A, B, C, D. Can anyone say? Which one would you choose? A, B, C, D?
So they are saying
Yes?
A.
A. Perfect. Next slide. Yes, it's always, you can have the protocol and manual with you, they can always recheck and reconfirm the physician. So that's what, the physician may not be very full confident on the case which you are dealing with. You know the case scenario, case important and the condition of the patient. So it's always, you cross-check whatever the physician says, you need to cross-check, check with yourself, check with the protocol, and then re-discuss with him, and then before you execute the action. Fine, next. So the take-home message of this portion is, EMTs play a very important critical role. So caring of the patient is a privilege, and please do not harm any of the patient. So in order to inspire or for a patient or a public to get confidence or trust in you, you need to be professional, be ethical, and stay positive. Next. Next, we are coming to the pre-hospital care. Next slide. So, yeah. So you are, just read the question carefully. You are called to the scene of a 24-year-old female who is in active labor. So what was the first step of management which you would anticipate or think? You are being, read the question, you are called to the scene. Okay? So you will do the immediate intervention, A, or initial assessment you will do, or pre-arrival preparation, or the scene sizer. That is, you will receive a call from your ambulance telling like, okay, one patient is there nearby 5 kilometers, you need to go pick her up, she is in active labor. So what option would you choose? Either A, B, C or D? Yes? Anyone from the audience? We'll be dealing like what exactly are these, maybe if you're not familiar with these terms, we'll be dealing with them in the coming slide. But just, can you give me an option, A, B, C, D?
Okay, I think they are hypoglycemic now.
Oh, okay, fine, already started. Okay, fine.
No.
Anyway,
We'll carry on. Dr.
C.
Sharma, we will carry on anyhow.
Okay, fine.
Little
Yeah.
louder with whatever
C.
you are saying.
Next slide, please. So it is a pre-arrival preparation. Next slide. So whenever your patient or any case is assigned to an ambulance or a paramedic, you should always follow your routine medical trauma management. You cannot deviate or you cannot change your medical plan or management for each case. This has to be customized once you see the patient, but always have a proper checklist, a mental checklist has to be prepared, and it implies for every patient. Why? Because you don't miss any important steps in this patient management, because you try to assume things where the situation may not be the same. So always have a proper standard approach for every patient who's assigned whom you deal with, so that you have a proper checklist which has to be followed, and that checklist will be going through the coming slide, so that you don't miss any important step in the patient management. Okay? Next. So these are the 8 important steps which has to be there in every patient who you see right from stabilization. So it is the pre-arrival preparation, always start with the pre-arrival preparation, scene size up, initial assessment, immediate intervention, high transport priority versus rapid medical trauma examination, baseline vital, history and reassessment. So this act comes only in this sequence. You cannot interchange any of these sequences. You can't miss any of this in every patient. Every patient has to go through this sequence. So this mental checklist has to be in the paramedic who is inside the ambulance. Next. So let's see what are all these, what are we talking about. So talking about the pre-arrival preparation, what you have to think, know about it is, think about the case. For example, in case someone is in labor or some case in chest pain, okay, what all you should anticipate? Anticipate the worst, because if it's going to be simpler, you're safe. But in case you think it's going to be a simpler case and it ends up to be too complicated, so you might have a panic attack. So always think or imagine the case to be in a bigger size or a massive case. And always after anticipation, what is the protocol to be followed, what are the equipment required and the medication needed, you prepare. That is the pre-arrival preparation. Once you get a call, make sure you get all these preparation as you reach before you. The ABC side. Okay. Next. What is seam size up? Next slide, please. Yes. Next. Pick up someone once more. So first is your personal protection. Always have yourself protected before you protect or save the patient. Okay. And team safety. Team safety is what we have referred to in case of a collapse of a huge building. You can't keep evaluating or assessing the patient inside the building. So you need to bring the patient outside of the building and then do your initial assessment. So team safety is very much important. Or in case if you find a patient who is hit by a car on the middle of the road, you can't assess the patient in the middle of the road. You need to bring him to a shade or by the side of the road and then evaluate, do your assessment. So team safety is very important. Next, followed by number of patients. In case of mass disaster, like in case of burns or a building collapse, we'll have multiple patients. So you need to know the proper triaging and then you need to choose your patient. Okay? And also look for additional resources. Like in case of fire, you need to have your fire ambulance or fire person along with you. You can't just wholeheartedly manage the situation. So make sure you get help from others also. And also look for what kind of nature or what kind of injury is there. So team size is you need to presume and you need to build up what could have happened, what would be your cause, how can you save the situation yourself first and then the patient and then the public. Okay? Next. So initial assessment. So once the scene size, everything, scene safety, scene size is done. Next, you need to assess your patient. The initial assessment is very, very important and crucial. Why? Because the first impression of what you get from the patient is mandatory and is important. In case if you find a patient who is very conscious and well oriented, I don't think you would take them in ambulance or you would give a priority to them. Whereas when you find a patient who looks very dull, tired, and or maybe unconscious, you would give your priority to them, right? So that's always the first impression of what you get from the patient. Next, the patient position, how they are positioned, where they are. Are they stuck? Are they in case of car crash or a bike crash? Are they under the wheel, tire, or something? So you need to know where the position is. Along with you need to assess your ABC. So this form comes under the initial assessment. Next, after you assess, you need to do your immediate interventions. What are the immediate interventions? Which include your proper positioning of your patient. You need to control in case of bleeding, you need to control it. Do a CPR, defibrillate, open airway, provide oxygen support in case of or not bad mass ventilation. And then you need to shift your patient to your ambulance and give him the IV and check for your glucose levels. So all these comes under immediate intervention. That is, these are all the set of things which checklist which always needs to be in your mind when you see a patient. So make sure the patient is correctly positioned and in case of bleeding control it. It depends upon case to case, it changes from case to case, but this is a common checklist which you need to keep in mind. Next, as we have discussed about in the triaging system, who requires the high transport priority. Always look for immediate life threats which anything hampering as ABCs, that they form an important thing. And any unsafe scenes, for example, you find a huge fire or a whole building has been under fire. So you need to first pull out people from it and not just pull one person, try saving him at one person at a time. Always you need to pull as much as, save as much as possible and then start with your transporting them to the ambulance. So, and always consider this ASAT, which is a mnemonic for patients who are in active labor or in case of any stroke or attack patients, for any altered mental status, chest pain, and trauma, physical trauma, which could be severe. So all these have to be considered and given high priority. Next. Next, coming to rapid medical and trauma examination. So what all does this rapid medical, previous slide. So rapid medical trauma examination, you should evaluate your patient right from head to toe, right from your head, your pupils play important role, and then followed by your neck, how they oriented, how it's resistant, and the neck vein, followed by breath sounds, heart sounds, and check for your abdominal, pelvis, and extremities, and finally with your skin. So you always follow the decap BTLS. Decap BTLS is nothing but your deformities, contusions, abrasions, penetrations, burns, tenderness, laceration, and swelling. So decap BTLS is nothing but right from head to toe. You need to check for all these parameters. If anything is happening or if anything is there, you need to record it. So you can address those issues at the earliest. So this has to be kept in mind. Decap BTLS. Next. After which, then you go and check for your baseline vitals, which is your pulse, BP, or respiratory rate and past temperature of oxygen. Next, and then you look for your history. History, which involves your signs and symptoms sample. History includes your sample, which is your symptoms, allergies, any medications, past medical history, last meal, and even stating to this condition. In case if you have either the patient can give you all this history, collect it, or if not, the bystander or the relative could give this history. Please collect the history and then leave. There's no point of taking the patient without knowing the exact history, or you can take the offender along with you in the ambulance. In the meantime, you can do the first aid along with getting the history from the patient. So history also plays an important role. Next, after the initial history, then you have to reassess. Again, check for ABC again, check for your vitals. So every 5 to 10 minutes, you need to recheck your vitals until you reach your hospital. And always address the chief complaint and give your IV and transport priorities to a nearby healthcare facility where it can be addressed. So we would not look for a primary center in case of major accident or a loss of a limb. You would not look for a primary center. You would look for a hospital or a district hospital or a college. So look for a proper transfer facility. Next. So as we've already seen, the first is a pre-arrival, I'm just going through again, pre-arrival preparation, scene setup, initial assessment, immediate intervention, then followed by who requires high transport priority, followed by rapid medical and trauma examination, then your baseline vitals, history and reassessment. Next. So we have been speaking so much about pre-arrival preparation. Why do you need to know about it, or what is so important about this pre-arrival preparation? What exactly are we talking about this pre-arrival preparation? You need to know about this case. For example, you get a call telling us about labor or a chest pain. You need to know, okay, fine, what all you should be prepared so that you can face the situation in a healthier or you have a complete control over the situation. So you need to know about the case, anticipate the maximum complication as already said, and also you need to know your protocol, what is to be followed for that particular case, your required equipment and the medication. Next. So why is it so important? And this is a golden word. When you are prepared, it is no longer an emergency. So until you are in a certain situation where it happens to you, you would it becomes an emergency. Whereas when you are sensitized about the situation, okay, there's going to be a burn case, there's going to be a heart attack or a chest pain case. So you'll be sensitized, you'll be prepared to handle this case. So it will not be an emergency for you anymore. You'll be in a stable, calm position to handle things in a much better way. Fine? Next. So you need to be prepared mentally, physically and emotionally. So all these are very much important for a paramedic to handle a case. Not just your knowledge is important. Knowledge doesn't work out when you are in panic or when you are in a tense state. So always you need to have your calm peace of mind so that you will be in a position to think what exactly is happening, how to handle the situation. Okay? So along with your knowledge, all these attitude matters. Next, so let's see this case scenario. You are 20 minutes from the scene of reaching. You have received a call and you are away from 20 minutes from reaching the call. Would you be prepared, get ready with either with your medication, protocol manual, vehicle, your mind, or all of the above? A, B, C, D, E, any options, please? Yes? All hypoglycemia or the option E as well, hypoglycemia?
Option E.
Option E, perfect, change. Yeah, so you have 20 minutes of time. So in that 20 minutes of time, you can do all these preparations. Next. Next slide. So this pre-arrival preparation, what are your responsibilities is, you just need not, the assets, the ambulance is your hospital or a mini version of the hospital in your hand. So make sure your vehicle is in correct state. It could transport your patient sufficient amount of transport and is in a good state to transport a patient first. So make sure your vehicle is good and you have all your equipment working and all your medicines in full stock and all the required medicines are in with you, which are not expired, and a copy of your protocol which always becomes handy at any point of time. Next. Next. So we have a protocol manual for all your emergency pre-hospital emergency care. We have developed a protocol which we share it, which we even keep updating every 6 months once in case of anything is required. So we keep updating all these every 6 months once. Next. So coming to this, let's see how well prepared we can be. So you find a 22-year-old female who is in active labor. You've been assigned a case. So what all will you anticipate? What all will you get prepared with? What all medicines will you be prepared with? Anyone? Audience, please. If you answer quickly, then I'll finish up my presentation faster. So what all would you anticipate?
आगे आ जाइए
Yeah.
पूरा नहीं
Could you just come again? Okay, fine. Let's go to the next slide. We'll see what all has to be anticipated. So whenever you're prepared, always review your protocol. As I told you, always have a checklist, a mental checklist. Always check your protocol. And since it's a labor case, have your delivery kit ready, and IV setup is required, and medication of person might be required based upon your ERCP advice. But you can just make it prepared so that it becomes handy or can easily access rather than looking for it once the patient is inside the ambulance. So always make it handy and make sure you have a clean blanket and warm up for the baby in case of delivery. As I told you, anticipate for the worst. So in case you are able to transfer the patient, it's fine. If not if something happens in midway, make sure you have clean blankets and warm up for the baby, and this is session setup for the baby. So as I told you, for that scenario, all these checklists and this preparation has to be done by a paramedic before they reach the scene. So this is known as preparatory phase. Fine. Next. Here, next case scenario, you find a 62-year-old male with chest pain. So what would you think of? How would you prepare yourself?
anything
Yes. What would you, the patient with the chest pain, so what all would you anticipate and what will you get things ready?
MI.
Sir, it can be a case of MI.
Yes. So what would all, see, you're anticipating the MI, what all would you get things ready, what all would you be prepared for the, see, I'm telling you a situation already in hand. So how would you be prepared to handle the situation?
All
What are
whether all the medications are ready or not. My
Yes.
ECG machine is working or not. Then
Yes.
morphine I need to check. The oxygen supply.
Yes. Perfect, perfect. Next slide, please. Next slide. So, as I always said, review your protocol, get your IV lines ready, get oxygen in case of a cardiac monitor available. In case of a AIIMS ambulance, you will have a cardiac monitor, and your medication such as aspirin and sorbitol, which is very much needed in case of MI, and ECG and AED is available in the ambulance. So, be prepared to have a mindset whether we have these equipments, use them rightly. If not, be prepared with your basic medication or the protocol which you have with you, along based on the protocol, and always get your ERCP physician, emergency response care physician, always online when you have such cases. Okay, next. Here you find a 44-year-old asthmatic woman with shortness of breath. So what would you think or anticipate now? Asthmatic woman. Yes, any answers from the audience?
this side is very quiet. What preparations need to be made?
I think you'll be seeing all these cases day to day, but I'm just trying to make, if this scenario is happening in the ambulance, what would the basic preparation which you would be requiring? Okay, fine, let's go to the next slide. So you need to, as I already said, review your protocol, get your IV setup ready, oxygen and nebulizer, why? Because patient is asthmatic, and medication such as salbutamol, adrenaline, get it ready. In case if it is required, you will be giving the patient as based upon the ERCP advice. Okay. So each case is not going to be the same. Each case is different. So when you have your mind prepared, you can handle the situation in a much faster way. Fine. Next. I think I find a 32-year-old diabetic female who has active seizures. So what would you do? Next slide. So review your protocol, get IV9 study, oxygen, cardiac monitor, and since she's a diabetic, check your glucose level and medication for your glucose and diazolam. Okay, so all these have to be ready with you so that in case you find patients requiring this, you can give them and take the patient to the next level to the healthcare center. Next. So finally, when does resuscitation of a patient start? It doesn't mean your resuscitation of a patient starts only when you see the patient in person or when the person is just lying right in front of you. It starts right from the time you hear a message about the patient. In case you are traveling and a patient, you have 5 minutes time to reach your patient site. So in the meantime, you can prepare yourself, make a checklist and get all these things ready so that even the golden hour doesn't mean only after you reach a patient. Golden hour is right from the time where you have the opportunity to save a life. So always be prepared. As I always said, think about the case, anticipate complications and anticipate what you will need. That always has to be kept in mind. Next. So coming to the initial assessment and immediate interventions, what are we doing in this initial assessment? Next slide please. I'll just quickly run through this. So can anyone give me which of the following is part of initial assessment of a patient? Either asking for allergy, decap BTLS, identifying active external bleeding or opening the airway. Which of these is the initial assessment phase? I'm not talking about intervention or this thing. What could come as the initial assessment part of this? A, B, C, D. Which one would be the answer? Yes? Assessment, initial assessment of the patient. D. Next slide please, let's see what the answer is. It's identifying the active external bleeding. Why? Because the next slide. About knowing the allergy is going to be a history of the patient. And decap is the immediate or rapid intervention which you will be doing. And opening the airway is an immediate intervention. So I'm asking about, my question was initial assessment part of it. So identifying active external bleeding becomes the initial assessment part of it so that you will be able to do a immediate intervention for this thing. Okay? Hope are you able to get what I'm trying to talk? Hope I'm clear. Am I too fast or something? Okay, fine. So moving on to the next slide. So what is the initial assessment is? Initial evaluation of the patient because it helps you to identify the life threat and helps to save a life. Initial assessment is very, very important in assessing the patient's condition. Why? Because that will pave a way to save a life. In case patient might say they have a head injury, but there could be severe bleeding on the stomach, so they may not assume. So with the initial assessment, you can address both the head and the injury in the stomach or pelvic region. Okay? So initial assessment plays an important role. Next. So what is the significance of this initial assessment is, in case these 4 things are not looked into, it could result in loss of life of a patient. What are these 4 things are? Severe external bleeding, absence of pulse, breathing or obstructed airway. Any 4 of these is going to be there, and if you don't look into the initial assessment part of it, then whatever you try to do, you would not be in a position to save a life. So make sure you check all these in your initial assessment. Next. Next, please. Next slide, please. So the initial assessment consists of 6 steps. Either the general impression of how the patient is presenting to you, the position of the patient, ABCs, and the shifting of the patient. I think we already discussed this. I'm just trying to go over and over again because this forms the basis for your any paramedic to handle a patient in a case of emergency situation. Okay, next. Here you find an 18-year-old male fall striking his head. On examination, he opens his eyes, but on pinching his skin, but he does not respond to when you speak to him, and he exhibits abnormal flexion. So under what scale, neurology scale would he come under? A, B, P, U. A, B, C, D. Which one would he come under? He opens his eyes on pinching his skin, and he does not respond when he's talked to, when a conversation is made, and he exhibits abnormal flexion. So which scale would it come under? A, B, P, U. Yes? Okay, moving on to the next slide, you see his responsive only when he is pinching. So that means he is responsive to the pain. Next slide. Okay, so categorize the patient based upon that. So talking about why this general impression or the level of consciousness is very important. Why? Because the initial presentation of the patient, either for example the kid, adult, male, female, elderly, all that is very important. And how they present, either they are wide open or they're kind of drowsy or they're not able to open their eyes. So all that gives you an initial assessment of how the patient condition is. You cannot do that later on. This has to be done in the initial phase so that you will know how the situation of the patient is, and then take the first impression, the best impression, as always said. The first gentle impression which you get about the patient, that is always carried and taken forward. Okay, next. So it's just a brief description, either it's kind of a male, female, or whether they are sick or not sick, or the level of consciousness, or all these comes as a general impression. Next. So general information is like age, gender, condition. For example, if it's a 50-year-old male who is having breathing difficulty, or a 10-year-old child who is having seizures, so all these comes as a general impression of a patient. Next. So how do you categorize whether a patient is sick or not? This is I'm talking about in case of general impression. Your clinical evaluation, all intervention is next. So the first impression when you see a patient, how do you evaluate? Can you see this? How do you feel whether the child is sick or not sick? Sick. Next slide. Sick. Yes. Next slide, please. How does this child look? Sick or healthy or not sick? This patient also looks very dull, tired, and he is not able to. He doesn't seem to feel fluoridated. So he was the sick. Next. How does this patient look? Sick. Yeah, change. So this is the first impression. That's what I'm talking about. The first impression of you see a patient, that matters a lot. And how does this child look? Not sick, obviously. So with this, you'll be able to take it. In case of that 4 patients, you need to segregate how they are. So by the way of general impression, you'll be able to. This will act as a guide for you to select your patient also and give the treatment accordingly. So next, coming to the level of consciousness. Either you have a conscious patient or confused or comatose patient. So based upon this also you need to categorize the patient. Next. So you have the APVU scale, which is alert, verbal, pain and responsive. Next. So when the patient is alert, when giving verbal, pain and unresponsive. Next. So how does this patient look like? Does he, which scale are they come? APVU, how does he come, which category does he come under? In the APVU scale. AVPU scale. A? U, exactly. Next slide, please. So, he's an unresponsive patient. So, he has been given resuscitation. Yeah, next slide. So, coming to the next question. What are the other methods to assess a patient's level of consciousness? What are the other methods which you can use to assess a patient? Either your doll eyes test, eyelash reflex, Coma scale, or mini mental status exam. Which one would you use to assess your patient's level of consciousness? A, B, C, D. Yes? C. Perfect. Next slide. Yeah, next. So a general, in summary, so general impression, that is a brief description of the patient, either they're feeling sick or not sick, and the level of consciousness gives you a brief basic idea about how you can approach a patient and take it forward. Next. So what does immediate intervention mean? Immediate intervention, why is it so important? Why? Because it is a life-saving procedure. In case if this procedure, immediate intervention is not done, then the chance of saving the life is not going to happen. There's no point of shifting the patient to an ambulance and then to the hospital facility or healthcare facility when you don't do the immediate intervention. So this is a very crucial part. I'm not talking about the in detail of each and every condition, but a general perspective which has to be dealt with every paramedic when they are transporting or when they are with the patient. Yeah, next slide. So talking about, we have spoken about general impression. Next, your patient position plays important role. Next, you need to talk about circulation. You have to control your breathing, do a CPR, defibrillate. Next, ABC you need to check. So next, Airway, make sure your airway is open. And next, breathing, just check if the oxygen and in case if they're not breathing, use the oxygen and mask. Next, and shift the patient to the ambulance and do a cardiac complete monitoring of the patient. So next. Okay. So the final take home message of this is the initial assessment, which includes all this, followed by immediate intervention. So all the initial assessment gives you an idea what kind of immediate intervention which you're going to play in the patient. Okay. Next. Coming to the last part of it, is just going to take another 5 to 10 minutes. So documentation. So far what you've done is the treatment procedure which we have done, or the intervention which you have focused on. One other important thing which a paramedic has to do in the inside ambulance is the proper documentation. As I already discussed, if there is no documentation, it is as good as not doing any treatment to the patient. Next. So the patient care record is an important factor or criteria which gives you or knowledge about your patient's progress. It helps you to give their status, and they will give their own line of treatment after your initial phase. And the pre-hospital care record is maintained. You can know where exactly you stand, what is any medication is not available, what medication is required in the future, or what kind of other. And also this database on a long run, which you have for example 5 to 10 years of research data, you can do a retrospective research which should be helpful for the future. Fine. Next. So let's see this case. You arrive at a scene of a 64-year-old male with chest pain. Okay. His vitals seems to be normal on arrival. The ERCP doctor, the physician, tells you to administer over the phone. He tells you to administer aspirin and sorbitate. Okay. He's giving instructions to give aspirin and sorbitate. Because he still looks well, you don't, and after giving the medication, you don't check your vitals until he reaches your hospital. And you just, as you take a look for the initial whatever it was, you falsely record it as initial same vitals. Next slide. You are recording your PCR. So every 5 minutes you have to record your PCR in the vitals. So the initial it was 80 and respiratory it was 12. So you have just maintained that, and 180 BQ was there. So you have maintained that and until you reach the hospital and handed over the patient to the physician in the emergency care. Okay. Next. At the hospital, you find all these vitals, change of vitals, where the physician checks where the heart rate is 145, which is steady pulse, where there is a low BP, respiratory is 24, and saturation is 95. So as the hospital doc asks you, how long has the patient has been having this unsteady pulse and low blood pressure? What would you say? What have you documented? In the documentation, you have said he is stable and normal now, and you have not checked in your every 5th or 10th minute. And at the hospital, all these are the vitals. So where do we stand? Where does the paramedic stand? Next slide. What exactly has happened is sorbitate has a side effect of decreasing of blood pressure, and certain cases can be pronounced. So when a sorbitate is given, you should know what are the side effects of it, and you should anticipate what would happen to the patient in case it is going to happen, and you always should anticipate for the worst. Next slide. So as a role of EMT, you have failed by knowing the side effects of the medicine and the pathophysiology of the disease. So you have neither understood the disease condition, nor you have understood the medicine side effects. So always keep honest and accurate record of the patient. Either checked or not, maintain the record as it is. Do not change or do not give a false record. And always take changes. Every single moment which you base a sign is gonna take a toll on the patient's life. Okay. Next. Here arrives at a scene of an 8-year-old female with fever. She has a fever. However, since she is a dementia and she is not able to give her history. Patient is dementia, so she does not give you a proper history. But you have contact with the family when the family members are there with you when you're picking up the patient from the home. And you take her to the nearby hospital without taking 1 second. Without taking any medicine history. And you take her to admit to the hospital telling there's no allergy. Next slide. And you finish up the PCR record telling that she has no allergies at all. This is how you represent. This is a part of the PCR. I'm just highlighting wherever it's required. So allergies here mentioned as none. Next slide. Here the physician, what he does is, because the patient has no allergy, he has given an antibiotic of ceftriaxone. and patient starts to get allergic reaction. What next? What happens? So you are the only one person who was in contact with the family member. Next slide. So it is your duty, or you have the only chance of knowing what exactly happened to the patient. In case if you miss to get the history of the patient, then you will never get it. And the physician is not going to know what exact history it is. So always make sure you record the medical history or the medication which the patient is having, either in case the patient is conscious, if not from the family member. Okay? Next. You are able to see the next case scenario, a 64-year-old male with a chest pain is having. His vital signs seems to be normal on arrival. I think, but you are unable to, the doctor or ERCP advises you to give both aspirin and sorbitate. But since you are not able to find aspirin, you just give him sorbitate and you record in your PCRS, they given both. Okay? So that way, doctor, ERCP physician has given you advice to give 2 medicines, but it's just given 1. Next slide. And you mentioned in the PCI recorder, as per the doctor's advice, I have given aspirin and sorbitate. This is how your record says. Next slide. So what happened? In case if you have given aspirin inside the ambulance, the doctor or the hospital may not give aspirin again. And aspirin, as everyone knows, it helps to decrease the death rate in patients who have heart attacks. So you have missed giving aspirin, and you have mentioned your record telling aspirin was given. So as a result, the hospital may not, or the physician may not give at the time of admission. So as a result, you are increasing chances of losing your life here. Next. So as a rule, only record whatever intervention you have given and not what you are supposed to do. Don't mention what is in the protocol. Write in the PCI record what you have to do and what you are supposed to do. Okay? Thanks. Next. So always for quality improvement and only for the good, for a bright future, and for to improve our healthcare system and healthcare emergency system, a good proper documentation of PCI is mandatory. Next. So the take-home message is the PCI should be filled out honestly and accurately without any deviation, and vitals has to be rechecked every 5 to 10 minutes until you reach the hospital base. Next slide. And always obtain the information as much as possible from the either the patient or the attender, and make sure the doctor will use your PCR guide as the standard or base for him to continue with the treatment as such. Okay? Next. Last, taking the final scenario. So just see this video. I just thought maybe you could kind of wake you up. So just see the slide completely. So it is one location where size up at time is around 11:05 a.m. Next. Ambulance is located, which is TN20G 4632. Kindly please observe the next 3 slides. That is with and done. So just wake up before you go break for lunch. So once again I'm repeating. Ambulance is located. BLS ambulance is located at Hyderabad. Time is around 11:05 a.m. The ambulance which is located there is TN20G 4632. Next. The EMT, the paramedic who is posted in the ambulance is Mr. Rajesh, and his ID is 25231. Okay? Next. And he is the pilot. Pilot is the ambulance driver. So he is Mr. Veeramani, whose ID is 569783. Okay? So got a clear picture of what the scenario is now. Next. 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 So at the call center, you receive a call with the patient's details. Next. So, based with the case details, a case ID is assigned for that particular patient, which is 0254632, which is the case ID, and the time of assignment is 11:06 p.m. Okay, so the ambulance starting odometer, nothing but the number of kilometers started. So odometer is 33546, and the case type which the ERCP, the ERO has recorded, 36-year-old male involved in a two-wheeler versus car accident. So that is the history which is received from the person who called for an ambulance, and the caller name was Mr. Murugan, and this is his contact number. Okay, next slide. So now the time is 11:15 a.m. Okay, can you see there's a collision there? Next, the ambulance arrives. Next, and the person who's standing next to him is his friend Mr. Prabhu, who gives us brief history of he had met with in car accident. Okay, next. So he says the victim's name is Mani, and he has a severe, and apart from this, the paramedics will evaluate the patient. Questionnaire finds he has a head injury, and he was responding to speech. He was really an open fracture on the right tibia, and yet ENT bleeding. Okay, so this is what the ENT finds. Next, after which he checks for the vital. So in the due course of time, he checks all the vitals, and he records it. Okay. Next, and the patient immediately shifted to the ambulance at 11:23. And based upon the ERCP advice, which was given by Dr. Aparna, he was advised to give NS 500 ml bolus, oxygen, tourniquet, T-collar applied. Okay. Next, the ambulance reaches the Rajiv Gandhi Hospital at 11:38 a.m. and admitted at 11:40 p.m. 11:40. Sorry, AM PM is slightly changed. It's 11:40 a.m. So during handover at the hospital, the vitals were monitored every 5 minutes. The pulse was 96, respiratory rate was 20, BP was 170, SpO2 94, and CRT was less than 2. Okay, and the patient was alert at the time of handing over. Okay, so with this, and after this, the ambulance gets back to its base site of Hyderabad. Okay, so just see on the slide. So what could be the previous slide, please? So what could be the pre-hospital care which was given? I think everything was mentioned in this scenario. What all do you say was the pre-hospital care given to this patient? I'm just trying to ask what a scenario was given. I think this is displayed in the slide. So the patient was given as an IV line as per the ERCP physician advice, oxygen administered, and vitals has been monitored every 5 minutes. Dressing has been done for the wound, tourniquet applied, and T-collar applied. So all these comes under pre-hospital care, which is given for that particular case scenario. That's it. So any other questions, please?
ऑन करो इधर से हमने ऑफ कर दिया खाली वो वीडियो ऑन मत कर खाली चेयर दिख रही है स्पीकर ऑन करो वीडियो मत करो ऐसा करो
Thank you, sir. This knowledge will be immensely useful for participants to learn regarding training needs for becoming AMS staff and understand their respective responsibilities. Thank you very much, sir.
Any questions from the audience?
Announce lunch break.
नहीं अभी क्वेश्चंस पूछ लेने दे भाई सरमन सर बैठे
Thank you, Dr. Sharavanan. I have disturbed you for a long time. I know that your schedule is highly packed.
Dr. Kamlesh and Dr. Srikanth for giving us this opportunity.
So thank you. It was very enriching, and we would love to continue hearing you. Only thing, I think our participants are a bit hypoglycemic now, and wish we could offer you. I wish that we could offer you to join us. Once again, thanks a lot.
Yeah, thank you.
We'll stay in touch. Thanks. Okay. I think it has been a very long day for all of you participants. Thank you so much. अभी घर जाने के लिए मैं छुट्टी नहीं कर रही हूँ, so don't get ready. But I know that it's time for lunch. तो अभी बेटा हम ब्रेक करेंगे for lunch and then we will join by कितना 2:30. ठीक है, 2:30 बजे तक आ जाएंगे खाने के लिए. 1 घंटा नहीं ले जाएंगे, फिर शाम को रात तक घर में नहीं जा पाओगे. 2:40 मैक्सिमम. ओके, लेट अस गेट बैक बाय 2. अच्छा, अभी ज्यादातर थ्योरी कम होगा, सारा एक्सरसाइज होगा. So now it will be simulation. चलो, और ध्यान से खड़े हो ना, बहुत टाइम से आप लोग बैठे बैठे your knees must be now tired.
Because of our continuation all sessions.
Anyway, they are very patiently they were hearing and also because of active.
फोन अभी दे रहे हैं मैडम, फोन दे दो भाई इसको. तो VIP है, 5 मिनट वेट भी कर सकता है.
वो फोन किया तो
फोन भाई हम तो नहीं उठाते.
मैम वो जबरदस्ती
तो मैडम का फोन है. हमारा नहीं
एक
किसी
मिनट
का।
भाई, इधर आ जाओ। ये भी ले जाओ। और मैडम का वो जा चुका है क्या? हाँ जी मैम।
ये भी है इनका।
ममता इस पे ये लिख रही है कुछ और उठा के मेरा दिमाग।
सुनो ये वापस देना है।
चलो,
लंच चला गया था ना प्रिंसिपल।
ये बेटा इसमें इधर सॉरी
वो ले लो कमल,
वो गिर गया कमल।
वो ले
मैम का
जाएंगे।
लंच चला गया था प्रिंसिपल।
नर्सरी वाले
वो तो कह रहा है हिमांशु मैंने खिला दिया लाके।
ये उठा दो बेटा, ठीक है?
हाँ ले गया ना यहाँ से।
सारा ले जाओ ना।
हाँ,
इसी
ये
के अंदर
पूरा
डाल
फोल्डर
दो।
अंदर डाल
इसके
के ले
अंदर
जाओ
डाल दो।
मैडम।
अरे इसके अंदर डाल दो।
ना
किसी और का फोन होता तो मैं नहीं बोलती, मैडम का फोन है।
ये ना हटा देते हैं बेटा, जिनका चल रहा होता है वो वाला रह गया। अभी हमें वैलिडिटी में ज़्यादा नहीं चाहिएंगे, मैडम वाला ही छोड़ दो। देखेंगे ये मीना पंडा मैम का भी उठा दीजिए।
और ये आवाज किसका है?
ये
ये तो वो लेके जाएंगे यहीं पे रहेगा।
किसका? जल्दी जल्दी से बेटा, ठीक है। और अभी
मैम
जो
कुछ लोगों
आएंगे
को हमने करा दिया जो वहाँ पे वो
मेरे को नहीं
अभी इनके और मैम के नाम अभी जो वो एक्सरसाइज कराएंगे तो उसमें वो दे देंगे उनको सिनेरियो, ठीक है? फर्स्ट वाला सिनेरियो भी वही रन कर रहे हैं, दोनों सिनेरियो वहाँ कर रहे हैं।
फिर सारा कैमरा
तो वो कहाँ से आएंगे ये बच्चे? ये जो इंजर्ड वाले
वो सब वही बना के
बॉडी
मैम
वाले
लटवाएंगे उनको लगेगा।
उस रूम से निकलोगे ना फिर ये पहले से सारे खड़े होंगे ना पार्टिसिपेंट और सब।
वही कैमरा सेट करा रहे हैं सब कुछ।
हाँ वो ठीक है। तो उनके ग्रुप्स यहाँ से बना के लेके जाएंगे कि जो पार्टिसिपेट उसमें करेंगे, जो ऑब्जर्वर होंगे, जो
जो इमरजेंसी नर्स, जो डॉक्टर, जो ये
वो यहाँ से बना के लेके जाएंगे।
अच्छा,
तुम लोग जो वो सारा उसमें पार्टिसिपेट कर रहे हैं, मुलाजिम
वो फटाफट करके रख लो।
जो लॉरी में बैठ के आ रहे हैं बेटा वो साथ वाले रूम में
मैडम याद रखिएगी अपनी लाइफ टाइम में।
मैडम वो बोल रही है
अपनी लाइफ टाइम में आप याद रखोगे लॉरी वाले केस।
उन्हें फोन कर देंगे।
130 स्लाइड्स यार, ये बच्ची ने बोला मुझे 30 स्लाइड्स तो चलाने दो। 30 पे 30 आते इतना तो हमारे एमएससी स्टूडेंट भी नहीं करते, उनको हम परमिट नहीं करते।
तो बाद में देखा मैं।
चलो यार तुम लोग भी लंच कर लो सारे।
जिसने नहीं किया वो
जल्दी भेजेंगे तो वापस, और उनको ना मुश्किल होगा पार्टिसिपेंट को लेके आना।
मेडिसिन है? कौन सी खाते हो? नाम बताओ ना। मेरे पास है, ले लो। That is what I want to ask ना, कौन सी खाते हो? ये लो लेके जाओ। 250 500 कितना खाते हैं?
लिपि 250 खाती है, 500 आप भी लेके चलते हो?
अरे मेरे
अच्छा अब कल
मेरे पास
कितनी
250 नहीं है।
अच्छा तुम कितना टाइम लगता था क्लास में आने में? हाँ तो उसके बाद 5 बजे तक बेटा लाइट ही लगे। देखो सुबह से भी आप कितने बजे आए हो? हाँ सर्टिफिकेट तो कल ही प्रिंट होके आ गया, मैंने कल ही करा दिया। सर्टिफिकेट तो कल बेटा आ गए थे मेरे हाथ में, लेने कहाँ से गए थे? आज तो सुबह की बात कर रही हूँ मैं। हाँ आज सुबह कहाँ से थे? आज सुबह कितने बजे आए हो? कितने बजे आए हो? कितने बजे आए? कितने बजे? मेरा क्वेश्चन क्या है? कौन सा एग्जाम था? किस एडमिशन किया?
भैया सर से लेके पैर तक
ना वो बहाने मुझे भी समझ आता है, कितने बहाने चल रहे हैं। रियलिटी है
हमें पता है वो वाला जान के
दैट इज वेरी बैड। 1:30 बजे से एग्जाम स्टार्ट लग जाता है। शायद तुम 1 घंटे की रेस्ट लेके भी 2:30 बजे तक या 3:30 तक। पहले तो कुछ नहीं था, 5 बजे में कुछ नहीं आया।
अरे दिस प्रॉब्लम तो 98 से है।
डर गए तो अबाउट व्हाट कैन आई से? इस एटीट्यूड का तो कोई जस्टिफिकेशन नहीं है। मैं डर के तो आई नहीं। यू नॉट अ नर्स की बात है कि आप डर के तो आई नहीं।
30-40 मिनट के
मैम अब आ गए नहीं, आप सब ब्रांड होके जाना।
सुबह से काम भी किया।
See, just record what you are saying right पर खुद से सुन के देखो
हाँ तो हम आ रहे हैं बस चीफ गेस्ट कौन आएगा लंच के लिए हम ही आएंगे ममता चल हाँ चल
आप सभी क्या खाना खा लिया
नहीं वैलिडिक्टरी के लिए रख दो हमारी मॉर्निंग में तो नहीं रखी कम से कम आप तो रख दो मॉर्निंग में तो हटा दिया था अभी रख दो
अब एक चेयर सेट कर दीजिए जो लिखा है
कुछ चाहिए मैडम?
ऑलमोस्ट हो ही गया ना अभी थोड़ा सा रह गया पूछ पूछ बाकी है
निकल गया हाथी
हाथी निकल गया
ठीक है ना तीन मैम की रखी है बस दुर्गा मैम की और बाकी अपने चारों की
ये तो अच्छा मैंने सोचा है ये
मैं पहले सोचा था ये सही करना है
ये भरी हुई बोतल रख देना इसको हटा
मेरे को डर लगता है क्योंकि कमलेश में सारे तो नहीं जाने
हाँ इसीलिए
इसी से आया इसलिए मैं नहीं आया मैं सोचा ये सारा रेडी करना है फिर कमलेश में बोली वो पीछे से आओ इधर से घूम घूम रही खा लिया दीदी खाना चल कहाँ है उधर सारा सारा बैठा होगा ना
हाँ
अब जगह होगा मन खाने
हाँ जगह तो है
मैम ने खा लिया सुजीता मैम ने खा लिया
खाने नहीं खा रहा है
अरे वहाँ जगह ही नहीं है जा रही हूँ सैनिटाइज ये तो खाली बोतल है ना सुनो प्रोग्राम के बाद सबको ये साइड वाले बता देना ठीक है मुझे
ये इनके ऊपर मत रखो ऐसे मैं इसको पैक रख दूं सूख जाता है they will be too worried about their damage while I am in the pain.
इसको ऐसे पकड़ के नहीं इसको ऐसे ही देखना समझ रहे हो इसको ऐसे दिखाना सही बोल रहे ना जो सामने वाले को तो दिखेगा ठीक है हाँ ऐसे ही करना और इसमें क्या है ना ये ऐसे देखो ऐसे रखना मैम आर यू can you hear me ma'am
Yes, sir.
okay
Sorry, ma'am. The telephone didn't have about 30 minutes.
The PPT you want me to run for 30 minutes? Yes. Yeah. PPT I've just finished up fast. Don't worry about it. So, sir, can I have PPT, sir? Participants are accident Dr. Sharma, Mr. Patient, and can you put some blood over the face and the hand? Mata is there? Can you put some blood in the face? You know, plain. Also, मैंने done है ना. और मैंने जो already placed on this side also you can. You can place them in the floor. All the mannequins on the. This problem because we need space for participants to stand also. No, you can remove this table, right?
सुनो प्लीज सुनो मैं घर में ले जा रही हूँ नहीं तुम जा सकते हो लेकिन मैं ये बोल रही हूँ पार्टिसिपेंट्स को बोलो ये वो पूरा मुझे बता दो सेकंड टाइम भी अटेंडेंस है क्योंकि वहाँ
बोलना है उधर बोलो
टुकड़ा था
नहीं तो मैं हमारा ले जाएगा कुछ लोग चले गए हैं
मेरे भी खींचो मैं ओरिजिनल वाला मैं बोल रही थी आज
अरे वो छोड़ के नहीं गए दोबारा लौट के आए
किरण तुमने प्रैक्टिस कर ली तुम्हें क्या करना है
भैया बोलना बस
मेरा स्मॉल भी नहीं करना वो तो करना ही फर्स्ट बार सिनेरियो में तुम्हें कौन करना है करना यार मैंने लिखा है सेकंड में तो सेकंड में तो ऐसा वो है मतलब वो ऐसी इंसान है लेकिन फर्स्ट में
So that's like two chairs, right? And below you get some collars and some boxes. This one. Remove both and you can keep aside one corner of the room.
एक और
Chairs, you can keep it aside, ma'am. I need a little bit space so that they can interfere in the floor itself. In the floor. In the floor. कैसे खड़े हुए
जूलिया खाना खा लेते हैं
बस एक
कैसे है और
हो गया तेरा पास में आओ ये तो जा रही है थोड़ा सा ले थोड़ा सा बस
in a different position. Okay. Let us try to work out how we can bring down the
क्लिनिकल असिस्टेंट चेन्नई है दीदी
एक दो तीन चार कहाँ से साइड हो हेलो वर्किंग दोबारा मैं आ बना रहे
वो मेरे ख्याल से उधर लेके जानी पड़ेगी उधर होगी ना
मैम रुको रुको
करो दीदी करो
Yeah, so what I'm saying, we are trying to work out how all other students to observe and in understanding that we are going to follow
अनु तुझे वो पेन लेना सुनना वो तो ठीक है सिंपल वीडियो बन जाएगी समझ गए गुरजोत नेहा एक चेकलिस्ट पकड़ के रखना है तुम्हें करो शुरू वो वहाँ पे देंगे वहाँ पे चले जाओ कौन देगा वहाँ पे किरण वगैरह लोग हैं उनके पास चले
यार बीच में आई जा रही है यार नहीं क्या काम नहीं करूँ क्या काम कर रही है तू फोटो खराब कर रही है ढंग से बोला डिलीट करो बीच में कोई ध्यान अच्छा मैंने देखा डिलीट करो डिलीट कर दो इसको मुझे बात शुरू करना है क्यों बात कर रहे हैं खड़ी जान से दे दे रहे हैं कर लेंगे वीडियो में स्टार्ट करके तो ताना आज का स्टेटस फर्स्ट ले जो बना उसको मैं नहीं चक्कर
ആൻസർ തോന്നുന്നു
ब्लैक कलर का शेडो लगा है प्लीज दीदी मेरे को नाम लिस्ट दे दो सारे मैंने लेके आया था सर्टिफिकेट और नाम वाले की सीट के पास दिए Yes sir, yes.
Okay.
But sir, can I stop controlling my PowerPoint?
You can share from your side, ma'am. Ravi. मैम आपके आवाज में
तो कलर तो लगाऊंगी ना सब क्या है बता वही जो बोलेगी वो कर दूंगी
just wait, ma'am.
मैंने कर दिया
वो लोग मेनू में कितने पार्टिसिपेंट
तीन होते हैं वैसे तो
और होते हैं अब आ जाओ सारे
लॉग रोल कर रही है उठा के नीचे रख दिया लॉग रोल पोजीशनिंग चेंज हो बोलते हैं तीन चाहिए था ना एक हैंड साइड एक फुट साइड और एक सेंटर
चेंज हो गया क्या
चला गया इसका
ये खुलेगा नहीं
बोला उठाने के लिए किसने बोला
मैम कौन सी है तो इतना देखो
ये लग इससे है ये लगा ये लगा Can you change the position of the animal? Not like the table. No. You can change the position of the animal. मामी देखिए देखो यहाँ पे भी You have to change the position of the animal. I don't want to be there like You can keep your one hand in the up. नहीं खाएगा दीदी The unresponsive one, what we have to do position, yeah, that can be wrong position. The female fracture animal, the hands can be like located somewhere else.
ठीक है वो मैम क्या
And you can make one mannequin like crisscross. Sideline position. Like one has like a in the different
हमें पास यही ऑप्शन हमने भैया आपके पेशेंट को गाड़ी का अभी क्या है गाड़ी कौन सा है आपका फ्रैक्चर वालों को भी कमी पे
ജോസ് ഇത് മൊബൈലാണ് ഞാനവിടെ അബോധാവസ്ഥയിലായപ്പോൾ
हेलो मैम ये पोजीशन करने की सुटेबल है क्या या फिर हम चेंज करें ओके मैम ओके मैम ओके
femur fracture can be in this position, not in the straight one. I don't want it in straight. Like this. You can keep a head of the mannequin to the this mannequin head, leg fractured to the table.
ओके मैम फ्रैक्चर पेशेंट का
इसमें रजिस्ट्रेशन प्लस
Can you keep the hands straight? The femur fracture mannequin, can you keep their hands on the Can you make it as like upward?
एक कोई लैपटॉप के पास चला जाना स्टेशन में
Hello, hello. Extended, please. Can you make the extended
Of public health which is in front of me. Yes? This is Trisha.
That's it. Fine. Super. So where are the real victims?
He will be join us virtually.
आपको जो सिनेरियो मिला था उसमें देखा गया था कि there was a man has been contributing the patient. Simultaneously, one of India will have.
What, ma'am? You kept some articles you kept in the table, right? The small table, white color table.
Okay, ma'am.
अभी डॉक्यूमेंट विच यू प्रिपेयर इज दैट मटेरियल स्पेल हो गया रेडियोथेरेपी रूम एस्टैब्लिश करने के लिए डिफरेंस विल यू प्रोड्यूस
Not there. Actually, no, that is the laboratory which is there, now. Behind you, dear. You're standing, no, behind you, that face. Yeah, so that you can. Sir, can you just show me the exact place or something? Dear, yes, behind you, yeah, you're going right on your right side, there's a space. Yes, table over there. On the chair, you can move there. That's the gap in between the toilets. In that gap, yeah. And this back. Just stable. This one.
I take monitor and
इसमें जरूरत ना होती फोटो चिपका सकते
you officials
Just table is not possible to move up. Yes, ma'am. Yes, ma'am. Fine. Can I check once? भैया अगर मैं स्लाइड्स में can you able to see my slides, sir? Yes, ma'am. Yes, ma'am. Yes,
हेलो, जो भी वेट लैब में है ना प्लीज चुप हो जाए. Good afternoon, ma'am. Miss Durga Devi. Shall we start, ma'am?
Yes.
Welcome back, everyone. We are now to start with an every informative session, that is transport and communication in pre-hospital EMS by Miss Durga Devi, clinical assistant, Apollo Simulation Center, Vanagram, Chennai. She had completed MSc Nursing from Indira College of Nursing, Thiruvallur, Tamil Nadu. She will join us virtually. Welcome, madam. She won Platinum Kaizen Award for Communication Board for non-communicating patients in critical care unit and effectiveness of edit among healthcare personnel. Welcome, madam.
Thank you. Good afternoon all. Good afternoon all.
Yes, ma'am. Go ahead, ma'am. Hello. Please start, ma'am.
Good afternoon to all. Post lunch. All are fine? Sir, can you able to see the participants, sir? Can you turn the camera?
Just wait.
Yes, ma'am.
I would like to see the beautiful Delhi ladies.
लाइट ऑन करो ना.
Sorry, ma'am. Last वाली भी on करो.
Thank you, sir. So can you keep the camera like that only so that it will be better?
Okay, ma'am. Okay.
Namaste and good afternoon to one and all present here. It's my great privilege and honor to be the part of the in-service education in AIIMS Delhi. I would like to thank Dr. Lata Venkatesan, who is our really a role model. Now she is polite. I'm very proud of her. And I would like to thank Dr. Kamlesh, who is the organizing committee member, the secretary, and Ms. Mamta, who is keep on pushing me to go to this session. I hope you all had a good lunch.
Yes, ma'am.
I can hear only one voice, sir.
Yes, ma'am. अच्छा लंच था आज.
So, happy Women's Day to all. This is not going to be a teaching session. You can just sit, relax and cool. I'm going to take you to the very fun activity where you can learn from the fun. Okay? Basically, I am the trauma charge nurse. I am a ED charge nurse. Worked in Apollo hospitals for 17 years. And recently, I took over the charge of Apollo Simulation Center as a clinical assistant. So I'm going to take you through the two activities. One is going to be the PowerPoint presentation, where you can going to just learn about the small things, but you will be knowing all the topics which has been covered from the morning to till now. I'm going to take you to the small capture points where you can take home messages from my presentation. The second part will be like a field triage. I'm going to take you to the simulation part, where we'll be having a simulated patient and everyone should be act like you are in the hospital and you are in the paramedic. So we are going to give a proper instruction how we are going to act on it. Before starting my session, I would like participants from the team, can you divide into 2 groups? Is it possible?
Yes, ma'am. Yes.
Okay. So one group A and group B. I would like to see. So how many participants are there, sir?
Total 35, ma'am.
35. So you can make it as a 17 group A and 18 members in group B.
Ma'am.
Please all of you keep your bags, keep your notebooks, keep your pens, just slate.
Ma'am, we have to divide right now.
I want the active participation from the team. Or can we do like this 1, 2, 1, 2 so that I can divide in A and B? Is it okay? Can we divide in 2 groups?
Yeah, ma'am. I'll divide accordingly. We have the registration forms, so accordingly we'll divide. Now only you want us to divide?
Yes. So that you can sit this side A group and B that side.
Okay, so I'm taking the name for group A. Please सारे एक side पे होके बैठ जाना. So Simli, Priya, Mahesh, Bensi, Soumya, Anjali, Jyoti, Mithun, Silja, Anita, Amar, Damayanti, Vishali, Rindraj, Kalpana Rana and Hina Malik. Please, these are group A. Please stand up.
एक साइड हो जाए जिनका नाम अभी लिया वो एक साइड हो जाए इस साइड आ जाइए
Yeah, please sit one side.
जो लोग जिनका नाम नहीं लिया वो इधर तो उधर चले जाए
Group A can sit at this side, group B can sit here. जिनका नाम नहीं लिया था, those will be in group B. जिनका नाम लिया है अभी, they will be in group A. So group A can sit there, group B can sit here. Okay, group A please sit there. And group B, you please sit here. So this will be just like a post-lunch exercise.
I can see group A is very enthusiastic.
Okay, ma'am. Now they are divided into 2 groups.
Okay. So I'm going to do iceberg activity now before going to the presentation. So that post-lunch, I don't want anybody to sleep on my session.
Please listen.
In the front, do you have any space in the front?
Pardon, what happened? What?
Do you have a space?
Space at the front, yeah, we have. How much space you need?
No, nothing. Just to stand like this. 1 numbers in a row.
Yeah, this much we are having.
Okay, the task is right now. All of you, can you keep your notebooks down so that it will be easy? Keep your mobiles, keep your phone, your overcoat, papers, pen. Once you're ready, please let me know, ma'am. Are you ready? Okay. You are all from the same institution or different areas, ma'am? Okay. You are all from the same institution or different institutions, ma'am?
Same. Same sound नहीं गई
Same place or you are from different institutions?
They all are from AIIMS. They all are from AIIMS only, ma'am. From different areas, different units, but all are from AIIMS.
Fine. Group B is ready?
Group B.
Yes, ma'am. Group A is ready? Group B is ready?
Both ready.
Yes, someone raise your hand who are ready. Group A is active here. I can see only Group A who's raising their hand. Group B, fine.
The one visible to you is Group B.
Just can you keep the video in the middle so that I can see both groups?
इसको मिडिल में रख दे इसको
मिडिल में रखना तो ये
हाँ बस हो गया that's it. Now I think ma'am you will be able to see both.
Yes, I can. Yes.
Yeah.
Okay. The activity is the first activity. In your group A, you choose one of the leader here. Who is going to be the leader?
Okay, Group A, please choose your leader. You are known to each other? Not. Okay, so randomly choose any leader. You can voluntarily give this who want to be the leader.
Okay, Group A, I need a leader.
हाँ बस. Group A, anyone want to be the leader?
I don't know.
Any volunteer who want to be the leader?
Group B.
कोई भी नहीं.
Volunteer team leader.
Okay, Group B. Anyone want to be the leader or any nominations?
This is something else related to your project. Related to the subject.
Let it be. This will be just a fun activity, nothing related to this year in service topics. So anyone can be. Sir, please, I think you can be. Okay, your name? Okay, ma'am. From Group B, Narendra Kumar ji is there. He is the group leader. And from Group A, Anna is the leader.
What is name, sir? Yes, family.
Anna from Group A. Anna. Hina.
Henna. Okay. Group B.
Group B. Narendra ji na. Narendra Seni na. Mr. Narendra Seni.
नरेंद्र कुमार
हाँ?
नरेंद्र कुमार
अच्छा नरेंद्र कुमार. Sorry, Narendra Kumar. Two Narendra are there in the list.
Which group?
In Group B.
Okay. So Group A, Hannah, and Group B is Narendra Kumar. Am I right?
Yes.
Okay. So Hannah and Narendra Kumar, sir, I'm going to give a 1 minute for you both. You have to take your team members. You have to arrange in the alphabetic manner. You have to ask their name, and you have to ask them to stand in the alphabetic manner. Is it clear, sir? Instruction?
Okay, both of you have to ask the name of your group members and arrange them as per their alphabet in alphabetic form.
I just started. Wait, sir. I will tell the time.
List. इन्हीं से पूछ के करना Fast.
ये तो जल्दी करो भाई.
एच से यहाँ बैठ जाओ. HIJ के ऐसा है यहाँ बैठ जाओ.
HIJ के
फास्ट ग्रुप बी फास्ट
ABCD यहाँ नहीं है ना कोई. B है नहीं कोई. D E F G H I नहीं है कोई. मैं पूछ रहा हूँ कोई नहीं है.
GHIJ के है अभी तो ऐसे तो एन से तो मिटाया तब कर आप लोग कौन सा है चलो आप वाले
Done? Group A? Group B done? Group B done? Okay, Group A? So, okay ma'am, both the groups are done and almost at the same time.
So, who did first?
B.
I think Group B.
Group B. Sir, could you please tell me how you did it?
Sir, please come here and tell how you did it.
You know each other before?
Ma'am, just we have told that ABCD we have maximum numbers of seats here. So just I have told them that just you set AB according to ABCD in the seats. So few seats are left vacant in between.
It's okay. Yeah, fine. Super, sir. Okay, from that side, Hannah.
Hannah. Then they want to know how you have done
You also did in the same way or have you tried in different way, ma'am?
नहीं ठीक है I make them to sit accordingly according to their name.
How you did it? You were not knowing them earlier, na? How you made them to sit?
No, I asked
Any
their name.
strategy you used?
I asked their name. Listening.
No, my question is, you told them to come and stand in the alphabet or you instruct the team to come and stand by the name in the alphabet?
Yes.
You instruct the team.
हाँ इंस्ट्रक्ट किया उनको कि आप थोड़ी से ठीक से बैठ जाओ My name is
Okay, ma'am, what she did, na? She called everyone with his, asked everyone's name and then alphabetically she made them to sit.
Okay. How we can do in a better way?
How it can be done in a better way? Any suggestion from anyone? Yeah?
We'll take the list, ma'am.
हाँ.
We can say those who start the name with alphabet A come to this place. So in the, after that we can categorize in a particular alphabet group.
Okay. Firstly A come, then B come, then C come, like that. Okay.
Okay. Any other idea?
Any other idea from anyone else?
जैसे मेंबर्स हैं उनका अगर हमारे पास लिस्ट है तो उस नाम से हमारा
नहीं लिस्ट नहीं पूछना नाम तो पूछना ही था
No, I gave only 1 minute because you are not from the, but you are from the same institution. You will not be knowing each other. The thing is how the team is working on it. That is the main core of the workshop. So what the brother told in that group, you would have tell the team that whoever comes to order may come and stand like next, so that you will be having like a chain. Key is works. Okay. So I think the post lunch, can we go for the session now? There will be 2 more activities waiting for you guys, but before that, I'm going to take you to the importance of communication transportation. I will just share my slide, just a minute, sorry. Can you able to see my slides?
Yes, yes.
My slide is visible?
Yes, ma'am. Visible. You can proceed.
Okay. Given topic is communication transfer.
Okay. Sorry to interrupt, Durga ma'am. Can you please do full screen for this PPTs?
Sorry?
Can you put this on presentation mode?
This will be full screen that much only.
No, ma'am. Side पे भी वो slides आ रही ना.
I put in the presenting mode only here.
Like full screen mode.
Yes, this is full screen.
Okay. Then continue, ma'am.
Okay. So actually this is a wonderful topic which is a day-to-day life, communication, transportation. But communication is very, very important in day-to-day life. So I just took it as a CAT. CAT nothing but communication, transportation. Communication is playing a vital role in patient care. See, so many deaths, it happens because of the improper communication or not effective communication, or sometimes it's not being communicated nothing to the healthcare facility. So many patients' lives are ending in the death due to the communication error. So if you have a effective communication, you will be getting a good clinical outcome of the patient. The transportation with the communication is a much effective for further follow-up and coordination of the patient care. It's like a chain. Transportation and communication in the patient care, it's like a chain, so that we will be ensuring the patient safety, thereby achieving the good clinical outcome. A term, golden hour. Since morning we are hearing this. What is golden hour? What is golden hour? It's mainly emphasize the importance of the time in the major incidents and the trauma in some of the diseases as well. Example, myocardial infarction, MI, like heart attack. The golden hour is the AHA, the American Heart Association. They will frame the time as like saying door to needle, door to balloon, door to cath lab. So this comes in a golden hour. The same vice versa, it comes to the stroke patient, the door to the thrombolyzing time, door to the CT time. That's a very golden hour for the patient. So early transportation, which leads to a good clinical outcome of the patient. So what are the learning objectives about this topic? You are going to learn about the importance of communication transportation in healthcare system and using the ISBAR tool in communication. ISBAR is one of the standardized communication tool which can useful in the healthcare facility. And okay, we are talking about communication, but you should know what to communicate, when to communicate, where to communicate, to whom you have to communicate, and how to communicate. So this comes in a big topic. You are going to see it in a very cryptic manner, and you should know to manage with the limited resources when demand exceeds availability. So pre-hospital care, that is the main topic which was going through the in-service education. We are not going to talk about the
Durga ma'am, sorry to interrupt.
Yes.
Ma'am, your slides are not moving. Are you moving that from your side?
Yes, ma'am.
But here they are not moving. We are still seeing the first slide only.
Okay, so I will stop sharing. Can you tell Sam to share the slides? Is it okay?
Yeah, please.
बच्चे कहाँ गए हमारे सिस्टम वाले?
आप बता दीजिए ना कहाँ पे.
Have you sent this mail to me? This PPT is.
I just sent to Mamta.
Okay. I'll share from my side then.
I'm sorry, Dean, for the interruption.
Is it visible, ma'am?
ऑन है ना, ऑन नहीं है ना, उसको ऑन करो, माइक ऑन पूछ लो.
Thank you, sir.
कौन सा स्लाइड? थर्ड, सेकंड, नेक्स्ट करो ना.
नेक्स्ट स्लाइड करो. उनको बोल दो मैम, बता दो कहाँ से करो.
Next slide, sir.
नेक्स्ट.
Next. Next. Okay, thank you, sir. So the learning objectives of this transportation communication is you're going to know about the importance of communication transportation in pre-hospital setup and how we're going to use the ISBAR tool in communication. So you should know what to communicate, when to communicate, to whom you have to communicate and how to communicate. And you have to manage the limited resources when demand exceeds availability. So we are going to talk about the mass casualty. It's like a large number of victims. You have to use the limited resources and you have to prioritizing based on that. And you should be deciding on the appropriate transportation. So whatever you are doing is great, but without the transportation, you will not be going to get the good clinical outcome. So why is so important? Why you want to know about the communication? Because every time in the life, day-to-day life, we are communicating. Why is so important? Because patient safety is our topmost priority reason, and many patients' deaths caused by communication errors. Ensure the patient transportation and communication are strictly followed. And the next slide. Communication errors are preventable. Nothing in the world that we can just stop, but there is something we can prevent because it's a human errors. Because we do not know how to communicate, we do not know what to communicate to the next side of the person. So if you fail to do that, we'll be losing the patient life. So types of communication in healthcare. We'll be having two types of communication in healthcare. One is the inter-hospital. The next one is the intra-hospital. Inter-hospital, nothing that the information is sharing multiple sites or healthcare facility. Example, from the roadside to the tertiary care. So roadside to the tertiary care. My previous speaker, he was speaking about the ambulance service, how they are getting the calls, which is connected to the centralized pooling system. From there, they will be dispatching the ambulances. The same way, the person who is handling in the field triage, you should know which hospital contains all the facilities. Just like the transporting a patient, it's not going to serve the purpose. Example, if you have a road traffic accident, someone is having head injury, if you are trying to dispose the patient to the next definitive care, you should know about the hospital have the facility of neurosurgeon and the CT availability. Without the neurosurgeon or the radiological investigations, there is no point of shifting the patient to that area. Clear? So you should know about the availability facility of that hospital. Intra-hospital is the any information sharing within the same example. Patient is moving from the ward to the any investigations like ultrasound department or echo or any doctor. So the communication must be very clear, saying that this patient is coming so and so for right leg arterial Doppler or venous Doppler. So your communication should be very clear and very cryptic enough to hold by the other side. Next slide. So these are the mode of communication which was used in even the 1980s. Sir was telling in the previous speaker, was telling about the mobile radio and portable radio and the cellular. But now we are in the 2022. Now our system was very elaborated and was very improved in the stage that where we are having a multiple digital equipment, where you can just show video, where you can share the information very easily, where we are having a telecommunication, so that they can show the ECG, so that they will be giving the medications. Even the treatment will be given through the telemedication itself. And all the ambulances are GPS enabled.
so that the ED facility team can trace the ambulance where are they now, why they didn't reach on time, is there anything happened in between, so that the en route they will be having an overview of the patient travel, so that the safety is concerned, so it will be ensured that all the facility is available before the patient reach to the ED. Next slide. So what to communicate? You keep on telling you have to communicate. There will be a difference between the paramedic or the trained nurses or the lay person. The lay person will call and tell this place so and so there is accident. But if the medical person, if someone is calling and telling means, you should be communicating in such a order saying that you have to verbalize whether it's a male or female, whether it's adult or child. What is the mode of the incident? Example, two-wheeler versus two-wheeler, we'll be expecting only 2 or 4 victims. But the mode of incident is four-wheeler versus four-wheeler means we are expecting more than 6 victims. So your communication should be clear about the mode of incident and you have to tell about the injuries. Example, the person who is thrown out from the bike will be having a breathing difficulty, asymmetrical chest movement. So this much information if you are given to the ED department, they will be anticipating the injuries of the victim. They would have arranged for the intracostal drainage, they will alert the radiology department, maybe they would arrange the OT, or someone is having a blunt injury, they would arrange for a death. So these are the basic information the paramedic or who is the first level responder in the incident has to be communicated to the ED people. And of course, you have to go for the ABCD approach. A, it's a very simple format where you can clear the airway by asking the patient name. If the patient can be able to answer your question, that means the airway is patent. Or you can just think that whether they are having a threatened or potentially threatened airway. B is you have to look for a bradypnea, tachypnea or normal respiratory rate. The third one is the circulation. You are going to check for a pulse, whether it is a feeble, whether the patient is having a very cold, or somewhere is bleeding, or the patient is drowsy, or the cold clammy still, patient is having a tachycardia or bradycardia. The next one is the D, disability. How the patient level of consciousness. You can use the simple format of ABPU. The previous speakers, everyone explained about what is ABPU. Alert, verbal, pain and unresponsive. Or sometimes you will be having a pupillary effect. So one pupil will be dilated, one pupil will be pinpoint, or someone will be having any open skull fractures. Example, they will be having a racumize, black spot of the over the eyes. Someone will be having a battle sign, you can see the red colored in at the back side of the ear. So these are the minor signs. You can be determined that they will be having a basal skull fracture. So being a paramedic or being the medical professional, you are a nurse or you are a nursing officer or a doctor or a junior doctor or you are working as a paramedic technician, you should be able to tell this kind of information. And what are the treatment given in the on-site or the en route. Suppose in the on-site, you are given the cervical spine collar. In the en route, patient is having a vomiting. So you are given the IV ondansetron. So these are the information you have to given to the ED department at the time of transportation and handover. So the ED team and the paramedic should have the same language so that the patient's care will be better outcome. Next slide. Okay, how to communicate? Okay, we saw that why is so important. We know that what to communicate, but how to communicate? If you ask one child to tell me about ABCD, what the child will start from? No, are you there? Can anyone answer? If you ask one of the kids to tell about ABCD, means how the baby is telling. Baby starts from ABCDE, right? Yes. None of the data will start from X, Y, Z, E. The same way, in the communication, you should know how to communicate in a proper standard manner so that you will not going to forget any information about the patient. So, the important communication tool is, next slide. Something is called ISBAR technique. I think everyone knows about this ISBAR. ISBAR or SBAR. Anyone know what this ISBAR? Can anyone answer for this ISBAR, sir? What is ISBAR? Okay. Nothing but I stands for introduction, S stands for situation, B stands for background, A stands for assessment, R stands for recommendations. I'm going to repeat again. I stands for introduction. In the pre-hospital setup, you went to the R team triage. You're going to call the ambulance service or you're going to call the ED people, department people. You're going to introduce yourself. I am so and so paramedic calling in this site. What situation made you to call to the ED? Example, birth, collation versus pus. That situation made you to call. So what is the background? You will be anticipating 20 casualties. So what is the assessment? In your assessment, you can tell that most of the population is pediatric or most of the population is females. Maybe it's a female birth, collation, or you can tell mostly is the elderly people. So this is for assessment, and you can ask always about the recommendation. Okay, I have done 2 patients. I have stabilized their spine. I applied the cervical collar, but still patient is screaming. I think what I can do. You always ask for recommendation. This is the common communication tool which are used throughout the medical community to avoid communication error between the healthcare personnel as well as the non-medical illness persons as well. Introduction, situation, background, assessment, and recommendation. So this is a main important tool where we can use it during the handing over part. Example, you are going to call one of the doctor in the hospital. Your patient is a known diabetic, suddenly felt drowsiness. You are going to call the physician. So you are going to tell, Doctor, I am so and so calling from this ward regarding patient X having sugar of 45. That is your situation. You are going to introduce yourself. Situation is hyperglycemia. The background is, doctor, the patient is a known diabetic patient. He didn't took food in the afternoon, so he developed hyperglycemia. What's your assessment? Doctor, vitals are normal, only sugar is 45. I have given a 50% of dextrose intravenously. Is anything would I like to do, doctor? That is the recommendation. You can ask always. In some hospitals, they have privilege to give the dextrose, or some hospital you have to get the advisor. It depends upon the algorithm what you are following in the hospital. So this how you have to do it. But without doing the assessment, if you miss any one of these points, suppose you are calling a doctor, doctor patient is drowsy. Okay, you are introducing yourself. This is the second scenario. You are introducing yourself. You are telling, doctor, I am calling from this ward. Patient Y is having drowsy. That is no situation. The doctor will be asking, is the patient diabetic? Then the nurse will bring, doctor, 1 minute, I will check the file. What is the sugar level? That comes in assessment. Doctor, I didn't check the sugar. What is given to the patient? You didn't do anything. So, if you follow the proper ISBAR technique, you will be knowing about the patient from the bottom of the patient. Maybe you will be assigning for a 6 patient, or 4 patient, or 7 patient. You should be prioritizing for that. The same way in the pre-hospital setup, you are going to call for a head injury patient. Example, situation you are going to tell. Background is 4-wheeler versus 4-wheeler. What is your assessment? Doctor, patient is having bleeding from the nose. Bleeding from the nose. There will be a big laceration wound on the head. So what can I do for the patient, doctor? That can be a recommendation. You can get it from the doctor. This how you have to communicate so that the error can be avoidable. It's like, okay. So you are going to tell. So you know how to communicate, but there are pitfalls where we can avoid the poor communication. Example, we are talking too quickly on 5 feet. Some it's vary person to person. Some may talk very fast, some may talk slow. But in the real situation, like the kind of mass casualty, your message should be very crispy and clear enough to understand about the need of the healthcare personnel. Sometimes your message will be long and very complicated message. Instead of telling, I have seen on RGA 4-wheeler versus 4-wheeler versus 4-wheeler. You want it to ambulance. That's it. That's a very clear message. But instead of that, you are telling, I was crossing the road, I saw bus was crashing with the bus. I think there will be more victims. I think you can send 4 ambulance. So instead of complicating the message, it should be very crispy message so that it is clear enough by the team to send the help. Next is the irrelevant messages, which is not relevant to the scenario. Some person will be like that only. They will be talking very relevantly. It should not be suitable for that area itself, but they will talk. Next is the interrupting by the other users. When you start talking to the team, the other one come and interrupt. Always. That happens all the time. During the disaster time, it happens, the frequently it happens. If I am trying to respond to the help, they'll come and interrupt you in the between. Next is the, of course, our digital media will be having a sometimes poor quality signals. In some cases, we will not get the good signal. So, half of the message will be conveyed to that side, half of the message they will not be having. There will be one more pitfall. Do you know what? So this is a common pitfall for the poor communication. There will be one more which is very important is listening. Listening is very, very important. Suppose the healthcare provider who is calling to the hospital ED saying that I am bringing 10 patients to your hospital. So you have to wait. What is the reply from the other unit, the other side? What if sometimes there is no bed from that hospital? There is no pointing of shifting a patient to that hospital. So you have to be an active listener to wait for the next and will be answered for your questions. So listening, active listening is very, very important during the communication. Next slide. Next is a very important in the pre-hospital care transportation. Okay, you are communicating everything to the ED team. You are done your first aid measures. How do you want to transport to the patient? That's the next question mark. We have the several method of transport, but the patient can be moved first. So that is a decision making on the paramedic first responder hands. You should be prioritizing your patient and using a triage scaling system. And which patient will go first, you have to decide, and what mode of transport you are going to approach. The transportation is nothing but it's a process of moving a patient to the different areas of the medical facility. Example, once an incident happens, you are going to do a triaging, you are going to do a ABCD measures, you are going to call to the hospital by using a AID technique, IS technique, and then you are going to move the patient as soon as possible to the tertiary care, where you will be getting a definitive care of the patient. So the availability of reliable transportation, which impacts the person's ability to access appropriate and well coordinated in healthcare. So once you communicated with the team, you have to transport very safely And as soon as possible, you have to transfer the patient to the center. Exactly. Why is so important to transfer? Because you will be having a limited personal equipment and you will be having a limited knowledge. One paramedic will be dispatching a only BLS ambulance. There they will not be having any equipment. So you have to, as much as possible, you have to transport the patient immediately to the healthcare facility where they can get the proper treatment. So the rapid transportation to a hospital is usually a primary goal of roadside care because of the limited first aid knowledge and lack of access to the basic safety equipment. That's why you have to do a rapid transportation, not only transportation, you have to do a rapid transportation. Next. Speed does not kill. Speed does not always kill. Sometimes speed saves a life. We always tell that speed is it will kill your life like that. But how the ambulance are running? It will be like very fast, you know. So the speed sometimes saves a life as well. How are you going to transport the victims? That's the next question. Based on your availability of the modes and based on the situation, you can choose the mode of transport. Okay. So we'll be having next slide. We'll be having 3 different modes of transport. One is by road, aircraft, and marine. In the road, you can transfer a patient by bike if the person can able to stand, or you can just take the patient by ambulance. That is the all over the world now. Or the train. Sometimes you can use the train facility as well to move the patient, because in the train itself there will be a hospital facility. You know, during the COVID, what they did, they made the train into the hospital facility and the patients are start treating over there. Next is the aircraft. We will be having a air transfer through the helicopter or the aeroplane. We can move the victim. It depends upon the situation and the numbers of the casualties. The third one is the marine. Marine is nothing, is a boat ambulance. In some cases, in Odisha, during the flood time, they were using the boat ambulance because that time the road was fully flooded with the water. There is no facility to bring the patients or to save the life. So what they started doing there, they started doing a boat ambulance. It was really helpful for that time of during the flood crisis. Most of the life was saved because of the boat ambulance. So you have to think wisely which transport is very easy and very convenient to save the patient. Some of the patients not fit to transfer to the aircraft. So before transferring, you have to look the candidate or the victim is fit to transfer in the modes, in the different kinds of modes. Next slide. So this is the bike ambulance where you can see if it's very high traffic city, the ambulance cannot go enter the bike, but the bike ambulance will go and they will start doing the first aid, like simple dressing or applying collar, like that they will be doing. That is the bike ambulance. Next one is the road, where we can use the ambulance. It comes in different forms of ambulance, like a basic life support, advanced cardiac life support, and neonatal life support. Some ambulance comes for the maternity, pregnant women. So you have to maintain a proper message saying that which type of ambulance you would like to need. Suppose accident between the school bus, you have to look for a pediatric life support ambulance instead of calling a BLS or ACLS ambulance. Next slide. Next is the aircraft, that is the helicopter or the aeroplane transport. But prior to that, the victim should be get the fitness from the medical facility whether the patient can able to fly. The fourth one is the boat ambulance. That depends on the situation when we can use the boat ambulance. So, good communication and the early transportation, the both together will give a good clinical outcome, thereby achieving a patient safety. Our top priority reason is patient safety and good clinical outcome. When I say this good clinical outcome means yearly transportation, yearly recognition, and yearly communication. Someone is having a chest pain. You are transferring a patient to the hospital. En route, you had a cardiac arrest. You are anticipating patients having cardiac arrest. You are going to start the basic life support chest compression. If you delay in doing the chest compression, patient will be having a brain death, but the heart beat will start, patient will be lost, but the patient will be in the vegetable state. So we won't get the good clinical outcome. The person will be in a vegetable stage, coma state, because patient already had the brain damage. So anticipating the injuries or anticipating the patient must be thinking in some other way. You have to think and act fast. If you cannot able to think on something, you have to dispose the patient very as soon as possible. So the good communication and the early transportation will give patient safety and good clinical outcome. So you have to decide on the transport. Decision on transport is very, very important. You have to use the triage algorithm which is given to you people. It differs to hospital. You will be having a different triage algorithm. You people will be having a different triage algorithm. Make sure you are applying on this. And then discontinue certain life-saving treatment effort. Example, mass casualty. If you are having a more than 25 numbers of casualty, you are only one paramedic. You should know which patient is salvageable, which patient is not salvageable. Instead of wasting your time, a person with unresponsive with good chest compression, after you leave it and come and say someone is having a limb injury. Okay. But in the real situation, if you have less members, of course we are not stopping the chest compression. But we are talking about the pre-hospital care in the transfer time. You have to apply the strict criteria for the use of case of equipment, because during the crisis, you will not be able to get the proper equipment and enough equipment. Next, you have to prioritize the transport patient by using the video cases. You should know which patient needs first transport. So you should be having a triage scale in your hand so that the patient can be moved properly. The third one is having access to the emergency department only for the patient who needs immediate treatment. The person who is having an airway threat should be transferred immediately instead of who is having only multiple abrasion and screaming for help. So you should prioritize, you should anticipate the injuries, what the patient can be having. To improve the good quality outcome on patient safety, you should be decide on which patient can be transferred immediately. This is based upon your decision on transport. Any doubts? Any questions? Doubts on it?
Participants, any doubts you can ask?
Have a doubt regarding the communication and transportation? So the first level responders making a huge impact on the patient outcome, that means a good clinical outcome. So the first responders always should be in a judgmental, you should use your critical thinking and which patient can be transferred first and what are the limited resources you can use during the crisis times and what are the immediate interventions can be done for the patient and how to communicate with the patient and what are the methods you can use it so that we will be achieving the patient safety and good clinical outcome. So any doubt?
This is something we can do. If you have any doubt, let us clarify. ये आपको दे दिया कि चलिए सबके साथ कुछ करते रहेंगे. You might be feeling post-meal sleepy. That's a blessing. All right. So what we'll do?
Can we move on to the next activity?
Yeah. You want to give the instructions first?
Yeah.
So while they are seated here, you can give the instructions. Thereafter, we'll move to the next room. Okay, and that will take about 10 minutes, right? Because that would take about 10 minutes. We would like to give them a brief break because since morning it has been back to back. Okay? Yeah. You can give the instructions right now. Okay, for the group activity. That they'll be listening.
So group activity, color paper is ready, ma'am? Or I will run the scenario first, then we'll have a group activity.
Okay, fine. That will be.
Okay, we'll be having a two scenario.
इसलिए दे रहे हैं कि ये भी खत्म हो जाएगा उसके बाद फुल्ली ग्रुप एक्टिविटी.
सिनेरियो सुन लेना भाई.
सिनेरियो सुन लेना.
Please listen carefully.
Kamlesh ma'am, can we go for scenario or activity?
Yes, please. Go ahead.
Go ahead, ma'am.
So, dear participants, we are going to have a hands-on session. I need active participants from your team. We'll be going to run the two scenarios where you're going to use whatever I taught you now regarding the communication transportation, and then we'll be debriefing about your activity just for about 5 minutes. Then we'll be having one fun activity. Then I'm going to run the second scenario, which will be a little bit complicated. And then I'll be winding off. Is it okay, sir, madam?
Yes, ma'am.
Perfectly all right. ये बेटा अपने पास अभी रख लीजिए.
Okay.
ठीक है? Here about the activities that madam is saying.
Thank you, madam, for sharing your valuable knowledge with us. Since morning, we have received enormous valuable theoretical inputs from our eminent speakers. So, now it's time to shift the gained knowledge into practice. For that, we have arranged simulation training for our participants by Ms. Durga Devi, Clinical Assistant Apollo, Simulation Center, Vanagram, Chennai.
Okay. So the first scenario will be, I need 4 members from the participants.
Volunteer first.
Volunteers. Just enjoy it, just have fun. We believe always learning from the fun.
घर अभी नहीं जाना, ठीक है? घर जाने के लिए तो 5-6 बजेंगे. पहले वॉलंटियर फटाफट. Volunteers, smart. You all are so smart and active, huh? Why don't you come forward? Yes, welcome, Mithun, welcome.
Okay, देखो everybody is going to be there in some group.
Some will be doing, some will be observing, some will be assessing, all things simultaneously.
Okay, we have 4. Please come here. Tell your name. 4, you can be next activity. We have next activity also. So 4, please come here and tell your name.
Good afternoon, ma'am. My name is Mithun. I am from Numerancy Ward, AIIMS.
One nurse.
4 participants you asked, no ma'am? 4? तो पूछना.
4.
Yeah, these are the 4 volunteers. They are giving their introduction to you.
Oh, okay, 4 members there. Okay. So one should act as a paramedic. Paramedic means it's a male nurse.
Male nurse तो ठीक है, Mithun जी हमारे.
One male nurse.
Yeah, I'm a nursing officer.
You have to act. We will give you a scenario in that you have to act as a male nurse in that scenario.
Okay. Don't worry. Okay. I want one should act as a ED doctor.
One among you can be ED doctor. Who will be that?
One of you.
Emergency department doctor. Who can be that?
Emergency से है कोई?
Okay, ma'am. Selected next.
Somebody from emergency other than Mithun.
Ma'am, next.
Yeah. हाँ तो then you be the emergency doctor.
I need 2 ED nurse.
हाँ, ED nurse.
Okay, ma'am. Finalized.
Okay, can I know the names of the participants?
Yeah.
Yeah, ma'am. I'm Mithun Mohan.
And
Sorry,
we will
sir?
be acting as वो भी बता दो. Mithun.
Yeah, I'll be acting as a nursing officer, male nurse.
Male nurse. Okay, super sir. ED doctor?
Ma'am, myself, Mrs. Jyoti Agarwal, acting as a ED doctor.
ED doctor. Welcome, doctor. So, ED nurse.
Ma'am, I am Leah. Leah and Ritu, we both will be emergency nurses.
So, basically, you are a ED nurse.
Yeah, ma'am. Leah and Ritu will be acting as ED nurses.
No, basically, you are what?
No,
We
we
are
are
nurses.
nurses, but we are not emergency ED nurses.
Oh, okay. It's a new role given to you. Congrats. Okay. So the scenario is here.
Please listen.
Brother, Mr. Mohan, right?
Yes, ma'am.
Mithun Mohan.
Yeah. So you are in the hospital station. Your ambulance is parked already.
Okay.
You are waiting for the on-call. Okay.
Okay.
You are in the late evening of your shift. So gets over. You are very fed up that it's going very late today.
Okay.
So we got a call from the one of the sister from the shopping mall saying that my brother had a chest pain and fainted.
Okay.
That's it. She is unable to talk further. She is unable to give any other information. So your ambulance reached over there. Okay?
Okay.
Along with your driver, but we don't want driver in this part. So you are a male nurse. You are trained in ACLS. So you are going to reach in this scenario.
Okay.
The vital signs would be the airway is clear. He can able to talk.
Okay.
Is having the normal breathing.
Yes.
Pulse is 50 beats per minute. His blood pressure is 110/70.
Okay.
So you will be having a patient along with a sister. Patient is not in the position to talk to you because he is having a severe chest pain and sweating a lot.
Okay.
Okay. So you will be having some observation points by one of the facilitator. She will be checking out because basically you are a nurse. Am I right?
Yes.
Since morning you are attending so many speakers. So they will be teaching you as a paramedic or a nurse what are the things you need to observe. What are the things you are supposed to give as a first aid or some intervention. We are going to see how we are going to put it together in that scenario. From there, I am going to take you to the learning objectives. I am going to tell you about what are the things you went really well, what are things need to be improved. Okay, you can get this next. I am going to appreciate what are things you are going to do it, but I really appreciate that you came as a volunteer. Hands off you, bro. Okay, so this is your scenario. Your learning object will be history collection with the relevant history, recognizing the chest pain with the heart attack, and how you are going to communicate to the team. There were 2 more learning objectives which is hidden. I don't want to reveal now because basically you are a nurse. So whatever you observed since morning, you are going to put it together. If you miss something, that is okay, fine for us. It's just we learn from the mistakes always. Okay. So don't get offended, don't get tense. Just talk on that.
Okay.
So you are paramedic. You are going to you are
We'll shift to wetlands for this activity. We have done
listen. You are on the way in the ambulance now. Okay.
Madam?
So you have to prepare. You are on the way to the mall, shopping mall,
Okay.
to pick up patient. On the way, you have to prepare your mind first to make it calm. What you are going to anticipate and pre-preparation things of the ED. So you got a call. You're going to your ambulance will be dispatched towards the shopping mall now.
Okay.
Clear?
Yes.
Okay. So Mamta, where will be the place? They will go.
Okay. We have arranged the scenarios in the wet lab. You all please can move towards the wet lab where they can enact what they want to do, and there also we'll go further with the second scenario.
My kind request to all the participants, don't block anyone. Don't block. So just note down the things so that it helps for us.
Okay, ma'am, one request from our side. Please select the participant from scenario 2 also here only, because in that room it will be difficult to select. So you give a briefing for scenario 2 also here only. Okay.
But not in between we are going to have an activity, ma'am.
That will do there, no issue, but at least we will be knowing who all are the participants, who all will be filling that checklist and all. Na? From here only we will decide the roles and go to that room.
So what I said is, let them see first the scenario how it's going, so that they'll be having interest on
Okay.
Okay,
Done. Okay, please, all of you, please move toward wet lab.
बैग सब छोड़ दो, ये खाली पेपर अपने बैग में डाल कर, हमारे यही सुबह से पढ़े
You have any doubts, right? You have any doubts, brother, to ask me?
No, ma'am. Ma'am, I would like to clarify one thing.
Sorry?
The two nurses and one ED male nurse and doctor together we are going to mall, right?
No, only you are the male nurse going to the scene.
Okay.
You will be seeing the patient, you are bringing to the ED. I will give a time frame. You first reach the scene.
Okay.
Told your learning objectives, get the history from the sister.
Okay.
And start doing the basic things what the nurse supposed to do in the ambulance.
Okay.
That is the advanced cardiac life support ambulance. I hope you know about that.
And what about ours rule, ma'am?
You just stay there, ma'am. He will bring, I'll give a time frame. Once he has done, you have to bring the patient as soon as possible to the ED. But he will communicate to you. Once he reads the scenario, he will assess the patient. He will start giving information to the hospital saying that.
On the phone?
Phone, yes.
Okay.
Just use a phone saying that patient is coming so and so. What are the...
He give me the history of this patient, then I instruct him.
So, he will be...
I will be collecting the history and all everything from the system and I will be transferring this information to doctor, right?
No, you will be doing your first aid measures. You're going to connect the monitor here. You're having advanced cardiac life support.
Yeah.
Okay.
Or if the monitor is not there, you can verbalize always.
Okay.
Okay. You are seeing some chest ECG changes. Okay. I just repeat the story now.
Okay.
You will be seeing some ECG changes and you are going to inform your ED team. What are the things you are going to inform your ED team? By the technique what I told you, ISBAR technique. So the ED team will prepare themselves. Okay?
Okay.
Okay, can we go now? All the best. Okay, the ambulance arrives now. The ambulance is parked. The male nurse will be coming to the mall. It's crowded already. Everyone is watching, and he's breathing heavily with the chest pain. Patient, chest pain. इसकी वॉल्यूम start crying, just pain.
Okay, so we have a kids therapy test. So this is a patient who recently fainted in the shopping mall, and this is all of them. So rest every scenario has been told to you. If you need any supply, either to here at the setting or in the ED department we have here, you can take it to here or directly ask us whatever you need. Okay. Please start.
Observer ready, right?
One of the participants we need as a volunteer to observe the scenario to fill the checklist, whether they are doing everything right or wrong.
So your ambulance is still on the way. They have parked ambulance in the basement of the shopping mall. The patient is coming, third floor. With the
Yes, ma'am.
Okay, the ambulance bailiff. Don't see
laptop ले.
Okay. Okay, can I brief now? Kamlesh, they are not supposed to disclose the checklist.
We are not disclosing the volunteers, ma'am.
No, it is right now. The bailiff is
Right,
there.
okay. Let me read the checklist, ma'am. We should not disclose the checklist. Please don't be necessary.
Okay, the bailiff is coming to the third floor. The sister who is screaming because the brother is fainted. Okay, the brother who is in pain now. Patient, pain. Okay, just keep the road lights. That's it. Yeah, no complaint.
Doctor and going to the ambulance. He's having chest pain for the last 5 minutes, and he's started from chest and ready to left hand. Last is that way. I also that is an MI. So tiny medical arrangements in the ED.
Sir, कुछ कीजिए sir, please.
You have a monitor. You have a monitor over there. You can connect it.
What's the monitor?
You have a monitor. You can connect it. You have a monitor over there. You can connect it.
Okay, connecting leads, chest leads.
Okay, so this is the ECG you got with this.
Doctor, I am calling ambulance. We are not a big hospital, but having significant changes in breathe V1, ST elevation, and V2, V3 as well. All these changes with ST elevation. And should I give morphine on the way? Can I have an IV like IV access? Yes, I have IV access. Doctor, should I give food?
Okay. Patient is in ED now. So transfer the patient to hospital. So ED doctor and the nurse.
Can you reach the emergency?
Yeah, patient reached the emergency. The ED doctor and the ED nurse. Can you take over?
On the way we have. See the अभी 10 minutes. It's approximately 15 minutes for the beginning of symptoms and pain started from the left. On the way, your started at the beginning.
आप इसके साथ हैं मैम? यस मैम। क्या नाम है इनका? मुकेश जी, आप ठीक है? सुनिए मेरी बात सुनिए, आपको मेडिसिन दी जा रही है, ठीक है? आपने ये दो गोली पानी से लेनी है और एक चबानी है। घबराइएगा मत, थोड़ा सा उठिएगा। हमने ऐसे सिनेरियो क्रिएट करना भी चाहिए। अब मेडिसिन लीजिए, आप मेडिसिन दे दो मैम को। चबानी है, ठीक है? ये चबानी है आपने गोली। अपने बॉडी में वही बीपी नॉर्मल है ना? आराम से सांस लीजिए। सिस्टम फोन ऑपरेटर बोलिए गाड़ी वाले को इन्फॉर्म करेगा फटाफट से करके। ऑलरेडी लेकर जा ओके जी, अभी थोड़ा सा दर्द कम हुआ, आराम लग रहा है, ठीक लग रहा है आपको? हमने गाड़ी के ड्राइवर को बुलाया है, ठीक है? घबराने की जरूरत नहीं है, आपने लेग को भी ले ली है। I just want everyone should be on mute. Okay. So, first of all, big applause to the team. Can you just special thanks to the sister and the patient. Really, they acted really nice. Thanks a lot, guys. And of course, the active participants. Where are they? There is the paramedic. Come forward, yeah, come forward. You are the hero of the session. Come forward. Okay, the team. Okay, one EC doctor, two nurses. Okay. You tell me, brother, how you did it? What are the things went up? How do you felt after the closing session? How do you felt?
It was very nice. Though I have in the last 30 years experience, I have transported a patient in ambulance. I only was with clinical setup, but today I got an opportunity to transport the patient with the ambulance also.
See, once in a while in the lifetime, you should be switched over. You know, I worked in a ED chapter, but during the flood in Chennai, I went in the ambulance to pick up a patient with the kneel, you know, up to the thigh level, I was having the water. We went along with the cardiologist with the just to start the dopamine infusion. I went all the way and we brought the patient back. Okay. Once in a while, you have to switch over your career and you have to see how is the next side. How many times you have scolded the EMS? Why you did this? Why you did that? Right? I did several times. Why you are applying colors for the chest pain patient here? Why did you apply chest pain patient here? What I did was
There is no
transportation.
I don't have to be getting this good.
You did well. Okay, tell me, madam, how you did? Ma'am, next to mailers. Madam, you tell me how you did. Doctor, right? You are ED doctor. How you did, ma'am? Did that?
One of my thing is that कि मतलब पेशेंट के आने से पहले one of my colleagues said कि प्रयास करने चाहिए, मतलब बेसिकली पेशेंट को सिक है, प्रयास करने की जरूरत नहीं है, बट मुझे सबसे पहले आई थिंक इंस्ट्रक्शन देनी चाहिए कि पेशेंट हैव टू शिफ्ट इट डायरेक्टली इन द रेड जोन,
independent unit or whatever so be available in the emergency.
Ma'am, I'm so sorry, I cannot understand. He need that much? Can you tell me? Yes, please.
He was explaining actually the patient. I didn't inform her that the patient is a threat.
No. I just want to know how you did. You did that. Both of you did it. Okay, what about the nurses? We'll come to the next point for what you did. Yes, ma'am. Nurses. What nurses?
When patient was already on oxygen, like when the paramedic bring it, so we just give the proper position. We'll give the drugs, and make sure the putting the IV cannulas for the morphine injection.
No, you both did well. Am I right? How are you feeling after the scenario got over? Like, stress free, no? Oh my god, they have done the scenario. You have that feeling okay?
Yeah, you saved the life of the one patient.
Of course, you saved the life. Okay, I would like to see the.
The is good. No, I don't know how
I would like to see the facilitator. I think the checklist. Who was that the checklist? I have given a checklist which is apt for this scenario. How did it, ma'am? Just common. I don't want to read. Just the common knowledge. No, don't say a checklist. You just tell overall, madam. How many
For me.
No, you just tell how they commonly.
They are doing very well, yeah.
They are doing very well. Okay, so I would like to emphasize on the learning objectives, discussion of the relevant history that you did very well. You asked the sister, and the ED doctor also asked the history of the patient to the sister. Recognizing the heart attack. The cases beautifully you recognize the heart attack, but in the ED team they didn't think about the cath lab, shifting a cath lab station. You know the ST elevation. So, the various was able to identify the heart attack.
We are waiting for the cardiologist. Actually, the added admission is there.
But you didn't call even. You didn't call. You didn't alert the cath lab. You didn't ask for a loading dose. Nowadays, loading dose is available. Example, display is available in the ambulance.
Yes.
Supposed to be given in the ambulance itself. The common door to time, door to needle for the heart attack is 30 minutes, and door to catheter is 60 minutes. Door to balloon is 90 minutes. This is the golden hours for the person who is having a heart attack. So, you have communicated very well. You told the doctor saying that patient is having a chest pain, radiating to the shoulder, and you took the history from the sister, and you well communicated to the ED team that patient is having a changes, but the ED team does not prepare for a cath lab, does not ask for a cardiologist to come and stand by, but he has informed you from the mall. They took at least 5 or 10 minutes to patient to arrive. What meantime the ED team is doing it? You have to prepare your ER, you have to prepare the things for the cath lab, you have to arrange someone from the financial support to get a clearance, and you need a healthcare worker like patient family, like the guest relation officer to get help, because sister is very anxious. You cannot go and talk and get the clearance. You can ask for a public relation officer, and you would have asked for a cardiologist to stand by with you, and you would have asked for the mobile echo machine in the ER. So these are the pre-preparation to it. That's why we have connected the ambulance to the ED so that you'll be having enough time to prepare yourself. You can elaborate your team as well. So you have time to elaborate your team as well. Okay, one patient is coming as a chest pain. You start IV cannula. I will start preparing the patient's skin preparation. I will start the fluids. I will give oxygen. I will give a morphine for the pain. But I am not understand why you operate a cervical collar. Because he had a fall. He had a call, you were sitting and you were just lying here. But chest pain, he gave a clear history saying that he is having a chest pain followed by he fainted. Now the caller really completely thoroughly for him. It was dangerous. So everybody is having a adrenaline rush during this kind of scenario. You should stay back. So I told you got the call, you are on the way to the ball. You are anticipating. You don't think what it could be. You think that's fine. Just pain. Followed by pain, sweating. Okay, these are the reasons you can anticipate. Maybe you will be having a heart attack. But otherwise, you did well. Is it clear? Yes. Okay, can we go for second activity? Yes. What is scenario?
Hello. Next, can we start with scenario 2 now first?
Oh.
Because no, the thing is we have little. Otherwise, we'll be switching from one room to the other.
That's what we wanted, ma'am. Actually.
No, too many movements are going to be little difficult. So if we could finish with scenario 2 and then go to your fun activity. Otherwise, let them do here only. The fun activity. Can it be done here only?
Oh, that's fine, ma'am.
Yeah, that is fine.
Yeah, I want to divide in the 7 groups, no, ma'am? I told 7 groups, right?
Okay. Yes. 7.
Yes. So I would like the participants to break in a 7 groups, 5 members in one group.
Okay, all the participants please. 5 each. Yeah. 1, 2, 3.
3 first streets are here.
Yeah.
1, 2, 3, 4, 5. So this is group 1. Next 5. 1, 2, 3, 4 and 1 more 5. You will be group 2. Okay. 1, 2, 3, 4, 5. You will be group 3. Tell you. Okay. 1, 2, 3, 4, 5. You will be next group. I think एक बीच में और भी है ना कोई. So you 5 will be there.
1 group also 1 group will be 6.
Okay. Then you can do this. Okay. And 1, 2, 3, 4 and 5. You can be in 1 group. Please stand together. And rest कितने बच गए हमारे पास? 1, 2, 3, 4, 5. You will be another 3. Ready? Okay. It is other way. Actually,
this team called male group, this team called female group.
Two mixed together. Please mix together.
Yeah, 2 females this side, please. Women's day today.
Please keep your bags, keep your roads down.
These are all students. No, any participants. ये मॉडल नहीं अलग से दिया यानी ज्यादा है मुझे
many there. In this group, how many people are there? 1, 2, 3, 4, 5, 6, 7, right? One can come join in your group, please.
Okay, any one person. Okay, one of the uniformed officers, please come this side.
Thank you. Okay, now I'm divided. What next? Okay, next. Okay, then the answer is, can you listen so that I can explain you? This is also one of the iceberg activity. This is part A. We'll be having part B as well. It's a part A. So each members in your group will be having a one color paper with your scissor and one plaster.
Distribute it. This side.
One paper. One paper now. One paper now. No. Now
One color paper or two color paper to one team?
No, one color paper right now. The next
one. Okay, one color paper to one team.
Yeah.
Okay, one sheet each. One sheet is of different color to every team. That is already given. एक ही जना डिस्ट्रीब्यूट करो तो उसको कलर्स पता रहे कौन सी दिया रेड नहीं हुआ किसी को ना रेड किसी ने भी नहीं दिया रेड हो क्या
So each team
maintain a gap between first and eight. Okay. 5 people. There are only 4 in your group. आपके ग्रुप में 4 लोग ही है बस इस ग्रुप में से एक इधर आ जाओ आप थोड़ा सा प्लीज ऐसे डिस्टिंक्शन में पता चल रहा है ऐसे सेंटर वाला चल रहा Little more to this side. Can come before. Six can come before.
Okay, ready? Ready?
Okay, that team are mixing right now.
Okay, the instruction is. Okay, the instruction is all the team has received a color paper, one scissor, one sellotape. Am I right?
Sellotape, students please keep sellotape also. Give me.
Okay, ready?
Okay, I hope everyone has got a scissor and sellotape. Yes.
Okay.
Yes, I'm ready.
Okay, the activity is I will give an instruction. I will tell a start. Then only you have to do it. Okay. So the instruction is I have given a color paper in your hands. You have to cut and make the circle. Put the plaster. Inside the circle, you have to put another paper. So you have to cut it in small pieces. You have to make it as a chain. Chain.
Okay, 1 second. Please.
You have to cut the paper. Wait. I'm sure you wait. 1 minute. I'm going to tear and show you, okay? So this is a paper.
Please see here on the screen.
Okay, I'm going to cut it. Okay. You can just do any number of sizes, no problem. Take it as a round. So that's it. Okay. Then make the second one. Insert it. Make it as a chain. Like this. Clear?
Okay, you can please start. Let's start the habit.
Yeah, please start.
Please start.
I want to see who's doing a big chain. Big chain. Do you like to see which team is doing the big chain?
Okay, students, you have to observe who made first. किसने पहले complete किया? बोला नहीं उन्होंने ना, कुछ तो मैंने शुरू कर दो. Any time. Durga ma'am, any time limit is there?
We'll give it 3 minutes for them. 3 minutes.
3 minutes. Okay, every one of you, you have 3 minutes.
Okay, the time starts now. I will point to the time. You have to see how much long they are doing it. Long. It's a lengthy one. Very active participants here. Happy to see.
Okay, one team is finished. तो से ले लो बच्चे उनका.
Okay, no problem. I want to see. We have 3 minutes, so I want to see.
Okay, ma'am. One team has finished.
And it has finished.
कैमरा में दिखाने की थी अच्छा बेटा इसके टाइम नोट कर लो देखते कितना टाइम में फिनिश किया
No. I have a time.
लिख लो अरे 10 वाला पेपर लो ना तो उसमें अच्छे से आप
Okay, 1 second more.
Only one minute. And one team has already finished it.
Oh my God, so happy.
The length will be completed. Okay, I think one more team has finished it.
Okay. Thank you. We have 30 seconds. 30 seconds.
Last 30 seconds. Last 30 seconds.
10 seconds.
10 seconds. Last 10 seconds. Okay,
Okay, now can I take at the table? The table we'll see who's eligible. Use that now.
But लेकिन लैंड में तो
Okay, so who's the first one? Mamta?
red one, ma'am.
Red, no, the lengthy one. My instruction. Blue length one.
Blue was lengthy one.
Okay, blue. Okay, who's the team blue? Can I see the team?
Okay.
Blue team.
Blue team was the lengthy one and the initial one. Okay.
Okay, blue, who's the team? How you did it? How you did it? Blue team.
Only blue team.
Only blue team. Sir, how you did it?
How you did it? They want to know.
Actually vertically कट किया था. Use the vertical cutting plus बीच में scissors को एक कटा है, faster छोटा pieces काट दिया था, उसको मैंने चिपका के रख दिया था यहाँ पे.
70 and 1% tight.
So great teamwork. Yeah. I would like to talk to the red one, who is the first one.
First किसने किया है
Red one.
पूरी टीम आप इधर आ जाइए.
What's my instruction, ma'am? I told who is doing the lengthy one. Why did you finish very fast? My instruction is who's going to do the lengthy one, the bigger one. But why did you finish very fast with the short one? So, the listening is very, very important. You should listen properly what someone is telling you. But my voice is so low, so they are not. My voice is low. I'm shouting like anything. Okay, anyway, great. Can you go back to your same place, same task, but you should use only one hand. Okay, please listen.
Hello, ma'am, good evening.
Yes, ma'am.
Hello. If you don't mind. Hello, please everybody. Okay. I believe your point has reached home, and now I think can we move to the next scenario, because it is also going to take some time.
Yeah, okay, no problem.
And there is a time limit over here in our this facility. So if we could complete that one, and we can use more time in that.
Fine. Okay, fine.
Is that okay with you?
No problem, ma'am. Yes,
Okay. Now your key messages we have received, I believe.
So you have to work as a team, and you should have a active listening, so that you will be achieving your goal. That is the main motto of this activity. Okay. Can we move on to the next scenario?
Who do you want more? Do you want participants? Do you want facilitators?
I need 8 participants from the team. 8.
8 participants as volunteers. 5 participants. 8 आ जाइए. Let us go telling here. वो लोग रहने दें. Others can come in. Anyway, come to the center. जल्दी से this is your. Okay, one person from that team.
2 ambulance containers. Team members 8. Okay, ready?
You see,
अगर आप ब्रेक कर दे तो हम आगे चल जाओ आ जाओ कोई नहीं जल्दी मेरे सिंपली आ जाओ प्लीज एग्जाम में तो पहले की हमने तो ले लेंगे जल्दी स्टार्ट
8 people are there, yes.
Super. Thank you so much, volunteers. So I want 2 male nurses to act as a paramedic. 2 male nurses. Who's paramedic? Okay, 2 paramedic, male nurses.
Yes.
1 ED physician. 1 senior ED physician.
Okay, 1 senior ED
Junior residents. Junior residents. ED.
2 residents.
1 male, 1 female is okay.
Very good.
Okay. 3 ER nurses.
Yeah, okay. Auto selected.
Okay, fine. Okay. So 2 paramedics. Please listen. You got a call from your commander center saying that car hit against the lorry in the highway. The driver lost his control. You are getting a call by a pedestrian about the incident. He is a pedestrian, lay person. He was just crossing the road. He saw that there is an accident. He is going to call your command center. So your command center is sending a 2 ambulance. 1 ambulance, sir, you are going with the white shirt, and the second ambulance, sir, with the overcoat, you are going in the second ambulance. You are reaching the scene. You are going to see 6 victims, 6 casualties. The scenario is one family, after finishing their baby shower, on the way to their home, function mode. Okay. Opposite, the lorry driver was sleeping. He lost his control, hit against the car. This is a scenario. You are going on the field triage. 6 patients, 2 ambulance, 2 male nurses. Your learning objective will be proper triaging by using START method. That means simple triage and rapid treatment. Next is you are going to assess ABCD approach. You are going to communicate to the emergency team next to you. 6 members. You are going to inform the senior ED physician saying that RTA happened in the highway. You are expecting 6 victims or more than that. You are going to communicate to him in a proper method. What are the injuries you are seeing? What are the slides I shown in the PowerPoint presentation? Male, female, adult or child, incident, injuries, ABCD approach. Then you are going to do a yearly transportation. You are going to prioritize the patient. The patient can be moved first. Okay, this is based on the paramedic decision. You will be having a patient condition on the patient chest. Okay, you can see you will be having a triage color code. Mamta.
Yes, ma'am.
Basically, these 2 of them is a nurse, right? Paramedic.
Pardon?
Basically, the 2 of the paramedic who's going to act, they are the nurses, right?
Yes.
Okay, fine. So
All the body school for nurses, ma'am.
okay, you are going to triage. You are going to apply a color code. You are going to call the ED team regarding this incident. And simultaneously, the ED team going to discuss with your team, the head will be discussed with your team regarding the anticipating the casualties, what are the incidents going to be, and what are the investigation you needed, what are the measures you are expecting it. This is from the ED team. You should have a team brief. The paramedic, sir, both of you you went with the advanced cardiac life support ambulance, you will be having some of the equipments. Example, you can use the collar, you can use the gloves, you can use the spine cord, you can use a pelvic binder, you can use a gauntlet pad for dressing, even you can start the IV cannula, everything. And you are going to put a triage bag, you are going to shift the patient, which patient can be moved first. That is decision by the paramedic. So once you transferred, I will tell you that you are transferred. But you have to do interventions in the field triage on site. Example, you can apply IV line, you can apply a collar, you can give some analgesic or IV fluids. I will tell you that okay, patient reached emergency. Then the emergency team will be taken over. Again, you have to do a ABCD approach. You can be triage again. You can under triage as well. This is by the ED team. Is it clear?
Not clear? जो भी करना है करना।
Is it clear now?
Yes, yes, and it seems to our victims already seem to be in place, ma'am.
Yeah.
Once more, at the ground we are trying to explain to them. Just once.
The ambulance is on the way. The male nurses both are traveling in the ambulance. They will be reaching in another 1 minute. Okay, the ED team can
with no definite pulse. We have 45 minutes who is stable. 35 mainly optic features, right side. 21 have we have weak female with the complaint of back pain. She is accompanied by her brother that is 13-year-old male with multiple abrasions over his face and
one minute. Yes, there is no role for the
Okay, please let us listen, please.
There is no role for the ED team here. Only the paramedic will be in the scene. They will be assessing. They will be triage score.
Okay, two paramedics only will be there in the scene. Rest. ED department can come to this side. Those who are in ED department can come to this side. Please.
I will give an instruction once they have done everything. I will give instruction.
सिर्फ those जो staff nurses हैं हमारी field में, they only will take care of all of these.
Then I will call the ED team can come in. That time you can come and do your job.
Okay. Everybody else will be observing.
Okay. Actors ready? Okay. Actors ready?
Are you ready?
Okay, scream and shouting for help. Scream and shouting for help.
Okay, just 1 second. All of you can start your scene now.
Patient can talk. You can talk to the patient. Sir, you came with the ambulance, you have some equipment with you, you can use it. You can use it. That is some equipment. So you can call the ED people. You can call the अच्छा आप कौन है दो गाड़ी का एक्सीडेंट इसमें 8 months अच्छा और एक और पेशेंट है जिसका बैक में हुआ है उसको देन एक पेशेंट बैक में फ्रैक्चर हुआ अरे पापा रेस्पॉन्स क्यों नहीं कर वो बात ही नहीं कर रहे हैं सबसे ज्यादा बोलते हैं यही तो बोलते हैं सबसे बोलते हैं सबसे ज्यादा भी बात ही नहीं कर रहे हैं ओके जी तो बराबर बस पहुंचने वाले टीम अभी तक नहीं आई ओके जी तो बराबर सबको ट्रांसफर जिसका ट्यूमर फ्रैक्चर टूथ है और हाँ और बाकी रेस्पॉन्सिव रहेगी एक्सप्रेशन यू गोइंग टू फर्स्ट उनका जो फीमर फ्रैक्चर है उसमें मूड ओपन मूडेड है या क्लोज मूडेड है ओपन मूड है और उसको हमने ड्रेसिंग किया और सपोर्ट भी दे दिया तो आपके पास अभी क्या क्या अवेलेबल है हम लोग अभी बोल रहे थे ब्लीडिंग हो रही है हमने बैंडेज किया और उनको टर्निकेट बांध दिया ठीक है और एक प्रेशर बैंडेज कीजिए जल्दी से ठीक है जो अनरिस्पॉन्सिव है और ओके so now can you ask some things
Okay, hello.
Which patient are you going to shift first? Which patient going to be shift? You can shift 4 patients. Which patient you going to shift? One ambulance. You can accommodate 2 patients. ठीक है? ठीक है? और जो बाकी 4 लोग हैं वो दूसरे एम्बुलेंस में आएंगे ठीक है ओके So which patient they want to go first?
The pregnant mother and the other one with back fracture, spine issue.
What about the other patients, ma'am?
Others they are saying in second ambulance.
What
22.
आप इनकी जान दी जा रहा
ये मैंने बोला हाँ वो बोलते हैं वो देखो स्प्रिंट मैंने कहा यही मेरे पास यही है
अभी हम इनका रिएक्शन हमने और documentation Okay. Okay. It is over now, ma'am. Yes.
Okay, can you just thanks to the actors? They did wonderful, wonderful.
All right, sir.
Awesome, yeah, thank you.
I think he is going straight Bollywood or Bollywood. Okay, everybody, attention this side. Everyone please pay attention. Okay, over to you, ma'am. Okay, the entire team.
Okay, we'll start from the, okay. You all done a great job. I would like to hear from the observers.
Observers, please हम यहाँ आ जाओ सामने.
चेकलिस्ट जो कर रहे थे.
चेकलिस्ट जिन्होंने फिल की है.
Observer और facilitator से.
No, just observer. I don't want to.
Okay, जो पीछे खड़े थे ये भी सोचे कि आपको कुछ नहीं पता है. Enter कर लिया, now you have to do.
Observers जिन्होंने देखा.
Observers come forward. जो कुछ भी नहीं कर रहे थे enjoy कर रहे थे. आगे आ जाइए थोड़ा सा. Okay, guys.
अब कैमरा उस तरफ घुमा दो उनकी तरफ.
Okay, I go.
चेकलिस्ट में थोड़ा सा ऐसे होता है.
How it went? Not some patients. ये तो facilitator थे ना? नहीं. Observer. जो चेकलिस्ट हमारे वो नहीं उनकी आराम से बात की थी. प्लीज गिव योर फीडबैक. आपको क्या लगा उनकी एक्टिविटी में? व्हाट वर द गुड पॉइंट्स, व्हाट वर द वीक पॉइंट्स?
तो ऑब्जर्व कर रहे थे प्लीज. ओके,
करना शुरू कर
अरे पहले एक्टिविटी करने दो ना.
पहले ये खत्म करो.
ऐसे रुक जाओ.
पीछे पहले वो तो करने Yes, please.
Okay. Kind attention. Please, just 10 minutes. Sorry, 5 minutes.
Okay. At the back, we'll have to now pinpoint. At the back. Can you pick up to this side?
No. I don't want to pinpoint anyone. I will tell you the triage which was done. Actually, it was not done. They didn't do a triage properly. If you have someone with the unresponsiveness with a no definitive airway or definitive pulse, all the other victims shall be coded as a code red. I mean the red color. Category 1. Once they mobilize to the ED, we can be under triage. That is our main aim in triaging. Based on the history, incident, if someone is in the spot death, in the motor vehicle accident, all the others will be considered as a P1 category, red zone. And I have given a scenario for 22 years old female unresponsiveness with GCS of 6/15. She was having the raccoon eyes, black color in the left eye. She was having the battle swing of the ear. Have you seen, sir? No, he is telling yes, ma'am, you are telling no. Yes, Miss Okay. She was having the suspicion of neck injury. She can be mobilized first. not. She should be mobilized first. And you should apply a cervical collar for her. But no one is applied. The second one, 6-year-old male with unresponsiveness with surprise. Mukesh was crying for her father because that can be patient is called as a P4, deceased patient, black color. So you should not wait starting with chest compression, saving the life, no. If you have a less manpower and you have a definitive no, it is not going to be. Lab, so he is working. He was complaining of hip pain. And was 70 over 40. The heart rate is in 30 over 50. He was having pelvic he should be transferred first. So we are given 2 ambulances, 1 head injury, and 1 abdominal blunt injury. I saw that he was applying a pelvic biter. We have given a vitals clearly saying that he was having 70 or 40. That means he is bleeding somewhere. The lap belt and the seat belt showing that he is having some laceration in the liver or the that one should be given. The next one is 30 years old with a femur fracture. But he was applying collar. He was having an open wound. The treatment supposed to be direct pressure, splinting, and transfer. But you have some time. So that patient, nobody given a amputation, nobody given a dressing. And we have a pregnant mother. She was screaming for her back pain. She needs only reassurance. Back pain due to late trimester. Because her anxious is about the baby. That's why she is screaming, but all the team will went to the pregnant woman. If she was complaining of back pain, she is supposed to be lying in supine and or should be left lateral position to avoid compression of the umbilical cord. Okay, so pregnant woman, her vitals are stable. The things one is she's having a back pain. She's supposed to be put on the left lateral position. The 6th candidate, who's the brother of the pregnant woman, just he was screaming for the laceration. That 2 can be transferred later, but the head injury and the pelvic fracture, like a blunt injury, who's having a instability of the vitals, should be moved fast. All the 6 members should be triaged as a P1 category, red color, except the dead one. Clear, sir? So your learning objective is proper triaging, simple triage and rapid treatment, assessing the ABCD approach, good communication, and early transportation by deciding which patient can go first. You should prioritize based on the condition of the patient. Not someone screaming and shouting, which is not supposed to transfer immediately. The one who is dying for the life. So you have to communicate a lot. You have to expect a lot, but wasting by time. So you should be good enough to answer this kind of patient, very bullying patient. You take my sister first. She is having back pain. I am having laceration. Take us first. But you are in a position to save the patient life who really need a medical care. This is based on your decision making. Proper triaging system, proper communication, and early transportation is depend on the patient condition. And you should work as a team. Whatever you are communicating to the EMS, that will be correct so that they can arrange properly. I think that's a proper communication. Am I right? You are not even 9:30.
Yes, ma'am.
That's all about my side. Thank you so much for your enthusiastic participation. I think you learned at least how to triage, how to communicate, and how to transfer which patient can be transferred immediately.
Thank you so much, ma'am, for your valuable time and so much inputs and making the participants to learn through practical sessions.
Thank you so much. I would like to thank Mamta ma'am and Kamlesh ma'am for your great effort. Not but last and not the least, your beautiful nurses who really participated very actively. Special thanks to the nursing students. Of course, yesterday night we had a Google Meet with we explained them, and I was so amazed the way they are acting it.
Especially.
And my hearty thanks to Dr. Lata Venkatesan for inviting us to take a part of this in-service education. Thanks a lot and thank
We are also highly thankful to you, ma'am. You spared so much time for us and you took so much efforts to prepare all the scenarios and you made them practically possible. Thank you so much, ma'am.
Thank you so much. Have a great day.
Thank you. All of you please now move to studio number 1.
अरे सीनियर रेजिडेंट कुछ बोल ही रहा है, यहाँ से वहाँ घूम रहा है हमारा सीनियर अच्छा रहा यार पहले तो लग रहा था पता नहीं क्या ठीक है अब दूसरे मौके बता दो नहीं अभी शुरुआत ही करी अभी तो आगे बैठो नाम ठीक से लिख देना बच्चे
Now we are going to start our valedictory session.
Before that, post test is over, collect it back from everything.
Yes, madam. Google Meet के लिए mic on.
All of the participants, please fill your post-test and feedback forms. Now, I would like to welcome Aditi, second year first BSc nursing student, to read the report of this in-service education program.
Good evening, everyone. Today was the amazing learning experience for all of us. The workshop was organized by College of Nursing, AIIMS, New Delhi, under the supervision of Madam Lata Venkatesan, Principal cum Professor, College of Nursing, AIIMS, New Delhi, and organized by Dr. Kamlesh, Madam Kamlesh Kumari Sharma, Associate Professor, Madam Suchita, Nursing Tutor, and Madam Mamta Chaudhary, Nursing Tutor, College of Nursing, AIIMS, New Delhi. And the great efforts by the PB second year students. The inaugural session started at 9:30 a.m. with the welcome address and felicitations of dignitaries. Then after the tea break, there was a speech of our Honorable Director, Dr. Randeep Guleria. After that, the first session by Dr. Sanjay Kaushal on the overview of pre-hospital care. During the session, I am sure we all learned a lot about why pre-hospital care is necessary. Then in the second session by Dr. Sanjeev Lalwani on the legal and ethical issues, and he enhances the motto of no law allowed anybody to die. Then after that, the third session started at 11:53 a.m. Topic was disaster preparedness and the field triage by the Dr. Akshay Kumar. Then next session that was taken online by Dr. Sarvanan at 12:50 p.m. on the training role and responsibilities of pre-hospital care. Then we all went for the lunch at 1:45. After that, there was a theoretical session on the communication tool on the pre-hospital care by the Dr. Durga Devi. And at the last but not the least, the scenario session that was like Sone Pe Suhaga, in which we learned many of things. In first activity, there was a scenario of myocardial infarction, that is a cardiac emergency, and scenario second, that was a collision of a car and a lorry, in which we are basically do the triaging and manage the situations. Thank you all.
Thank you, Aditi. Next, I would like to welcome Dr. Kamlesh Sharma ma'am to distribute the certificates to the participants. I will call the name one by one. Please come forward and receive your certificates. Tripti Dillan.
कैमरा के आगे आ जाए कैमरा के आगे
Annie Biju. Mahesh Chand Yadav.
It's been a long day, but I think it's well earned.
Mahesh Chand Yadav. Ritu. सिर्फ रितु लिखा है.
कैमरा के आगे आ जाइए
वृंदा राज.
तालियां प्लीज. इतनी मेहनत करिए सुबह से हैं लगे हुए और बिना नॉन स्टॉप.
वृंदा राज.
कम से कम सर्टिफिकेट के लिए तालियां बजाओ.
राधे श्याम.
Congratulations, very well earned. So apply this now in your daily practice.
Matthew Kiran VP.
Do you feel it was worthwhile?
Thank you.
Matthew Kiran VP. Midun Mohan.
Don't give the wrong ones, beta. Very well.
Neha Rawat.
हाँ मिथुन
Thank you. How are you?
Fine, ma'am.
Radhe Shyam.
Neha Rawat.
Radhe Shyam ji thak gaye.
Sirja Anish.
Neha Rawat.
Sirja Anish.
Neha Rawat. कि आप कहाँ पहुँचे?
Anjali P. Shivan.
तालियां तो बजा दो थोड़ी.
आशा यादव.
मानते हैं आप लोग कर देना.
नरेंद्र कुमार शर्मा. ज्योति अग्रवाल. चंद्रकांत शर्मा. Hina Malik. Priya.
Priya.
Rameshwar Lal.
Mr. Rameshwar.
Kalpana Rana.
Thank you.
Neeraj.
Kalpana.
Onita. Damayanti. Vaishali. Amar Jadhav.
Amar
Sangara. Shraddha Daima. Soumya Chapo. Leah Clara Joseph.
Sonia मैम सौम्या लिया तो वो है
Usha Tirki. C Rani. Sandeep Kumar Yadav.
रानी
रानी
संदीप कुमार यादव.
सी रानी कौन है भाई नहीं है वो तो नहीं है जो एविएट वाले हैं
नहीं वो तो एनी है
फिर चलो बाद में दे देंगे
नरेंद्र साइनी.
संदीप
विमेंस डे पे लगता है कुछ प्रैंक्स के चक्कर
नरेंद्र नरेंद्र कहाँ पे नरेंद्र रखने की जरूरत है फिर से हमें.
Who have not received? हाँ
भाई डॉक्टर्स को नहीं दे रहे
हम खाली कर रहे ये तो वैसे ही सबसे मेरे को नेबुलाइजेशन को क्या लेना पफ लेना है फोटो तो ले लो भाई कौन ले रहा था कौन कहाँ पे है ड्यूटी आपकी
उतना काम करके
हम काम में गए नहीं मेरे को ऐसा प्रॉब्लम है फोटो खिंचा लो फिर हम भिजवा देंगे और कहाँ ओपीडी वार्ड कौन सा भी आरपीसी
Thank you, Kamlesh ma'am, Suchita ma'am, and Mamada ma'am. Now, I would like to request Madam Suchita, Tutor, College of Nursing, AIIMS, New Delhi, to deliver the vote of thanks. So, very good afternoon, one and all present here. It's my proud privilege to propose vote of thanks for today's session. First of all, I thank Lord Almighty for His grace and blessings and making this program to happen a success one.
I would like to thank our Director Sir, Professor Dr. Randeep Guleria, for his support and encouragement and always encouraging us, building morale of our students and the participants. Special thanks to our Registrar Sir, Professor Dr. Sanjeev Lalwani, for gracefully accepting our invitation for being the chief guest of this today's in-service education program and encouraging us with his words of wisdom. A note of thanks to our CNO ma'am, Mrs. Kamlesh for her support. Special thanks to Madam Mrs. Meena Panda, CNO, NCI Judger, for being our guest of honor. I would like to thank our principal ma'am, Dr. Lata Venkateshan, Professor cum Principal, for her vision, her enthusiasm, constant support, encouragement and her dynamic leadership to make this program a success. I would like to thank Dr. Kamlesh Sharma, Associate Professor, College of Nursing, AIIMS, New Delhi, our organizing secretary, for her constant support, guidance at each and every step for organizing this workshop. A note of thanks to all our eminent speakers for sharing their knowledge and enlightening our participants on the given topics. I would also like to thank our BSc PB Nursing second year students for their endless efforts, hard work and their sincere efforts really for making this program a great success. I would also like to thank all faculty members of College of Nursing AIIMS and college staff for their support and help. And special thanks to Dr. Ambus, Professor in charge SET facility, all the staff of SET facility, Mr. Sujan, Mr. Sharma, all staff of CMET for their support and help. And thank you all dear participants, without whom this program would not have been possible. Thank you for your patient listening, hearing and active participation. So, thank you very much. And last but not the least, thank you to the organizing team members, Ma'am Kamlesh Sharma, organizing secretary, and special thanks to Madam Mamta for her sincere hard work and effort, and our students, post basic nursing students.
And Madam Sucheta.
Okay, and once again, thank you all. God bless you all. Jai Hind.
Okay. नहीं भागना नहीं है, 1 second हो. Okay, I know you have been ready. Yes.
Thank you every participants for your active participation and making this workshop a memorable one. Now I want to request you all to enjoy your tea. Thank you so much.
Group photo.
Yes.
One group photo also.
Since morning we have not had. चलिए and हमारा
इधर खड़े होते हैं पीछे से
अभी हुआ इंट्रोडक्शन है ना.
इस साइड अच्छा आएगा सुजन, इस साइड हम यहाँ खड़े हो जाते हैं वहाँ.
बताइए.
यहाँ मैम यहाँ आप बैठिए.
अच्छा.
सारी लाइट जला लीजिए प्लीज.
आजा ममता.
All of you come.
सारा जला लीजिए सारा.
फ्लावर्स का मुझे आज भी बहुत कॉम्बिनेशन अच्छा लगा.
बहुत सुंदर.
वेरी क्यूट. उसने 3 बार एप्लीकेशन लिखा है. एक दिन तो मैंने भगा दिया. मुझे लगा कि वो खुद जो दे रहे हैं ना
जिनकी हाइट ज्यादा है वो पीछे, जो हाइट कम है वो आगे है. मोबाइल लीजिए, हाइट कम कर
बेटा.
पार्टिसिपेंट भी है, स्टूडेंट भी है, सब है, पेशेंट भी है.
बताओ पार्टिसिपेंट चाहिए, वो चाहिए, स्टूडेंट चाहिए, कौन चाहिए?
नहीं पार्टिसिपेंट चाहिए.
चलो ठीक है, सभी आ जाएंगे.
मोबाइल दो.
बेटा फोन दे दो ना.
आप थोड़ा इधर हो जाइए.
अरे ये ले लो.
मोबाइल कहाँ गया?
सुजैन ये ले.
मोबाइल कहाँ गया?
पहले आप मोबाइल ढूंढ लो.
हाँ, अपने से भी ले लेना एक आध. एक आप लीजिए.
मैं ले रहा हूँ.
आ जाओ वापस.
क्योंकि बच्चों का कभी मैं देखती हूँ कि थोड़ा सा.
मिथुन जी.
लाइट तो जला हुआ है सारा
अंधेरा में
ये वाली लाइट्स ऑफ है
ये ऑफ है ये ऑफ है ऑन
हाँ ये सारे ऑफ है ये पूरी लाइन में
जो मेन
तो इधर से ऑफ है
सर उस साइड से वो भी
ठीक है कोई बात
नहीं कुछ
ओके
थैंक यू मैम
थैंक यू एवरीवन एंड
चाय पी के जाना प्लीज
थैंक यू
थैंक यू
अगेन कॉलेज में नहीं आया था थोड़ा सा
थैंक्स अ लॉट सबके लिए
आप